Dr. Subohi Zafar, Senior Radiation Oncologist, Apex Super Speciality Hospital, and Mr. Ashwani Jaiswal, Senior Radiation Therapist, AIMS Rishikesh, to kindly take their place. This session will cover everything from IGRT basics, real-time motion management, and radiation safety. Now, to begin this academic journey, we have a topic that reflects the evolving identity of radiation therapist. I now invite Mr. Yogesh Nenave, Senior Radiation Therapist, NCI Nagpur, to kindly come on stage and deliver his talk on skin development for RTTs, advancing role.
Hello. So, lovely good morning to all of you. Hope you enjoy your Rabdi Jalebi and yesterday Shiv Dham. Jai Bholenath. Namaste to all of you. Before I would like to start my presentation, I heartfelt thanks to Dr. Rajiv, Kamal and each and every member of your community members for your excellent, marvelous arrangement of this conclave. So, with this start today my presentations. My presentation topic is the skill development for radiation therapist in advancing role. As per the naming of this presentation, everybody seated in their hall. So my today's presentation, line of presentation of this roadmap is including this type of topics. So now all the radiation therapist fraternities, the one question in there everyone has mind, so why radiation therapy skill is important? Anyone? Just 1 minute answer why. Last slide. अपने को क्यों ज़रूरत है? But yes, commonly nowadays in the 21st of century, the radiation therapist is the most effective and importance of the radiation therapy skill. Why? Because of radiation therapists play an essential role to ensuring the high quality of patient care. And one of the important point is that the every year of million of people affecting the cancer, for that front line, for their precise treatment, hope you all are agree, respected doctors, physicists and therapists, front line for their precise treatment is a radiation therapy stand behind that. To justify that sentence or remains, what is the important to the enhanced patient care, the strong set of soft skill allow to understand the patient need and support, to improve the teamwork and career progression. So now, today my aim is that to focus to combination of the advanced technical expertise, expand clinical decision marking, high-level interpersonal communication skill to manage patient care, growth in leadership, education, and research. So now coming back to few decades back, this is the evolution of the technician to therapist. Now, the radiation therapist is a transit from 4-box field technique to world-class state-of-art technology rapidly. Most of the few seniors, Gurvinder ji, Ajit Singh sir ji, and so many, those who are the 25, 35 with more than experience, they know that how a radiation therapist evolving role nowadays, comparing that era to this era, in terms of primary focus, technology, role in team, education, scopes, and etc. So now coming to the next point, that is a effective communication. I think from my point of view, I hope you all are agree that the most powerful skill which are the wanted in this era, that is effective communication. So now effective communication in what? So verbal communication in the treatment room. Hope you all know that the radiation therapist use the push shoulder up, shoulder, remove the fat, chin up and down, relax body, chest to me, this type of instructions we are giving in front of the patients. So that is okay, but what are the second step? Radiation therapy should be communicated the member using the language not alarming to the patient. For example, I am in the wrong tattoo. Hope we are treating the so many patients on couch. Just now today I talked with the Ramesh ji in their center has 250 treated per day patients. So somehow there is something should be wrong, but that keep in mind in front of patient we cannot lose the talk. So if you want to correct it, then what is the next step? Next step is nothing but this is very important to understand that the non-verbal communication skill. So now non-verbal communication skill always come from your eye contact, tone of voice, body postures, and the facial expressions. For example, if your partner makes a shift and table does not clearly lateral, the radiation therapy should tell us that the table does not clear, the gantry is going to hit the patients. So this type of sentences, patient lose your confidence. So now coming part to the immobilization. So key aspect of immobilization is the reproducibility, precision, accuracy, reduce treatment margin, patient comfort, stability, and the specific application. When you combination of this point of contact, so immobilization, it is a very and highly important and effective for the entire treatment of radiotherapy. Regarding immobilization, I just want to give a small example. My friend Mr. Prakash is know very well about the immobilization because he are delivering a lecture by POCL, how to make orphic precision. So day by day, if you are seeing instead of teaching that the high treatment era, but first you know that the immobilization, how it is important. So now coming to the after immobilization CT scan. For us, CT scan is just not a scan. Why not? Because when you are comparing with the normal CT scan or normal patient CT scan and this CT scan is a very important. Why? Because of CT simulation is a precise state of art. First step of radiation therapy that uses the CT scanner to create the 3D printer images, internal anatomy, including the location and the organ at risk. Because that CT scan is the final remark margin for our entire treatment of radiotherapy. So now CT scan coming with the few aspects, 3D visualization, anatomic, target accuracy, immobilization and positioning. I think everybody knows that without these things we can't do anything. Reference marking and improved treatment technique. So now coming to our important point that the radiation therapy skill. So number of skill, everybody seated over here, everyone has a good skill. Just you have to identify what is that one. So I just try to point of contact that few skill which are always required, that the advanced and technical skill, hard skill, soft skill, professionals, leadership, research and skill. So now coming to the advanced clinical and the technical skill. So technological advance like online adaptive ART images, IGRT and the central advanced practice requiring the high level technical experts. So online adaptive radiotherapy, this is the advanced clinical. Nowadays the high evolutions or the techniques, machines, MR, Linac or Ethos, they can easily do the online adaptive. But those who are not this kind of machines, so still we are facing challenges for the online adaptive radiotherapy. After this complex treatment technique, everybody knows as the big name, SRS, SRT, SBRT, but did you think that you are expertise with that? What are the main point of contact with that? You know the expertise of specialization procedures such as the IMRT, SBRT, SRS, SRT, brachytherapy, etc. Multimodality imaging and delineation, advanced skill in the image registration, fusion, target delineation and contouring, and of course quality assurance. So now come to the hard skill. The word of heart itself, every hospital has a billion or crore machines costing that comes under the hard skill. So hard skill including the operating sophisticated medical equipment, understanding complex medical procedure, interpreting the medical data. These skills are teachable, measurable, often acquire those formal education and clinical training. Every management has to be relied on us that yes, these therapists know about all the operating of radiation therapy equipments. So everybody should know that how to troubleshoot any issues and fundamental to your role as a radiation therapist. Understanding the safety aspects, accurately patient positioning, and interpret the medical images. So now coming to the important point, that is a soft skill. Without soft skill, we cannot do anything, either in the technical, clinical, personal, professional. So soft skill is related to how to interact with the patient, colleague, supervisor, relative, ground staff, etc. Because they determine your capability of work within a team, adapt a challenging situation, and to create the comfortable patient environment. So now, how many points? Or these points, like empathy, communication, as I talked to earlier, that effective communicator involving the listening carefully to patient concern and responding appropriately. Problem solving. So now, what is the meaning of the problem solving? The skill is required to ability assess the situation, come up the effective solution. And one thing is, you all are remember that problem solving skill are very important for the radiation therapist. Always come forward as a problem solving skill, not problem creating skill. If you try the problem creating skill, definitely it will be directly or indirectly affect our patient care. So whatever our point, that will become with the problem solving. Adaptability. Having adaptability skill means you are the open to changes and can comfortably adjust to new situation and environment. So now, professional leadership and the research skill. Everywhere we are attending the conferences, we are talk each and everyone, some of my colleagues. So now everyone has to be expected to driving lead can change, contribute to enhance evidence base of professionals, research and evidence-based practice, engaging the clinical researches, developing a new standard protocol, coordinating clinical trial, disseminating knowledge of the through publication and presentations. Next is the leadership and management. So this is the very important point nowadays, taking a leadership role, project management, developing policies, and advocating the professional, national and the international level, and postgraduate education. I think everyone has to be from last 5 or 10 years. Radiation therapy is not stopped over there like a graduation or post-graduation. Now they are coming to the one step or two step ahead. I think few example which I know that our organizing secretary Raju, he has done their PhD. Yesterday I talked with the Rakesh, yesterday just I think Mukesh Jain has also completed their PhD. My friend Prakash, coming year or next year he's complete their PhD. So number of examples you are setting that we are not stoppable over here, always comes with the continue learning skills and take the opportunities to find our best role in our professionals. So now future development. Future development is improving your radiation therapy skill to consist effort and dedication approach. Both hard skill and soft skill can be to be honored, practice, continue education and willingness to learn. So now understand your strength and weakness. As I said earlier that everyone has a good quality of standard of care. So now identify your areas of the development, recognize your weakness is helpful to direct effort towards improvement. So pursue continuing education. Committed to continuous education, learning, professional courses, conferences, workshop to improve hard skill and soft skill. It is not mean that we are just remind for to set the patients and take the images, go home, come next day and daily routine. Recently, our Ashok ji, I think AERB visited. Huh, Ashok ji, is this right? IAEA visiting. So this type of opportunities come for therapist level also. My seniors, Manoj ji, they are doing excellent work in their professional, that data collecting, I think. So these are some few points come towards our educational levels that will be helpful for our developments. So seek continuous feedback. I think this feedback is important from the patient perspective and their relative. Don't shy away, ask for their feedback after each sessions. So now we will conclude to this topic. Radiation therapists always true to reproducible treatment by carefully positioning and immobilizing patients, play a well-established role in both aspects, clinical and technical part. So radiation therapists apply or whatever that treatment room required effective communication, understand how to verbal and non-verbal communication can enhance the supportive patient safety aspects. And day by day, radiation therapists reduce the need of constant on-site radiation oncologist presence, improving the departmental efficiency and reducing the patient spend on the treatment couch. So now my final point is that always radiation therapists come together is a beginning, keep together is a progress, and working together is a success for better quality of life for the patient. Thank you so much once again, each and every one of Apex Conclave committees. Yes. Any question?
Any questions from the audience?
Thank you.
So I think you dealt an important topic, and as an introduction, this is very important that you have both soft skill as well as hard skill. So along with the learning, along with the acumen you have, it is to always communicate better with the patient and also with your colleagues in the when you are simulating. That is very essential, and that has to begin from there, because when the patient comes to our department, that is the first place he has an orientation about our department, what we are going to do with the patient. So this was a good topic which you dealt with, and I think more people will be benefited by this. Thank you.
Thank you, sir. Now, as precision starts with imaging, our next talk focuses on the core principles of IGRT. I invite Mr. Naveen Dubey, Chief Radiation Therapist, Chandan Hospital, Lucknow, to please come forward and enlighten us with his presentation on basic concepts of IGRT.
जय बाबा विश्वनाथ। आप सभी को प्यार भरा नमस्कार। यहाँ उपस्थित रिस्पेक्टेड चेयरपर्सन, esteemed delegates, my dear colleagues. It's a great honor and privilege for me that I have shared my thoughts in the principle, the basic principle of IGRT, image-guided radiotherapy. IGRT, image-guided radiotherapy. All of you are aware about IGRT. It's just a reminder call for you, because the topic is very important in modern radiotherapy, because your treatment and becoming more precise, and IGRT plays a key role in achieving accuracy and safety. Okay. It's not working. The main objective of my presentation are first to help you understand the need for IGRT, second to explain the basic principle of IGRT, third to identify the sources of errors and uncertainties in radiotherapy, then to understand the PTV margin of concept, and finally to recognize the role of radiation therapy technologies in IGRT. Because IGRT play a very critical role in daily treatment accuracy, and RTT also play a crucial role in this IGRT. मैंने जब अपना कैरियर स्टार्ट किया था 98-99 में, तो हम लोग 2D कन्वेंशनल रेडियोथेरेपी से स्टार्ट किए. आफ्टर दैट 2D कन्वेंशनल रेडियोथेरेपी में एक बोनी लैंडमार्क लेते थे, बड़ा सा फील्ड साइज हुआ करता था 12/10, या पेल्विक रीजन में जाएँ तो 20-25 का एक मार्जिन हुआ करता था. इमेज का कोई बहुत अपॉर्चुनिटी नहीं हुआ करती थी. आफ्टर दैट हम वी मूव इन 3D कन्फर्मल रेडियोथेरेपी एंड लेटर टू IMRT. विथ ईच स्टेप इमेजिंग एंड प्लानिंग एक्यूरेसी इम्प्रूव्ड and dose delivery become more conformal to the tumor. 2D से 3D में कन्वर्ट होने में काफ़ी समय लगा. ICRU के गाइडलाइन के हिसाब से 29, ICRU 50 and ICRU 60. Then planning was basically on X-ray basis. We depend on the bony landmark and we used large treatment fields. Because of this, accuracy was low and normal tissues receive higher doses. Target localization was not very precise. Then we move to IMRT. We cover CTV, GTV, CTV, PTV margins. Intensity modulated radiotherapy, giving highly conformal dose distribution, it provides excellent OAR, sparing. But the problem is because margins are smaller and dose gradients are steep. Or setup efforts or organs motion can significantly affect treatment accuracy. So IMRT require very accurate patient positioning, which is where IGRT become extremely important. In this graphic, आप देख सकते हैं इसमें कि 2D से 3D stereotactic radiotherapy, SRT, IMRT, then IMS guided volumetric VMAT, tomotherapy, cyberknife, LINIAC, एंड आयन बीम. और अब तो हम एडाप्टिव रेडियोथेरेपी की तरफ बढ़ रहे हैं, फिर AI बेस्ड रेडियोथेरेपी की तरफ आगे बढ़ रहे हैं. तो डे बाई डे मशीन के अकॉर्डिंग और सारी मशीन या हमारी टेक्नोलॉजी के बेसिस पे हम धीरे धीरे अपने आप को इम्प्रूव कर रहे हैं. ऐसा नहीं कि टेक्नोलॉजी बेसिस भी है, मशीन वाइज भी हम काफ़ी तेज़ी से इम्प्रूव कर रहे हैं, अपने आप को आगे लेके जा रहे हैं. और जो हमारा आज का टॉपिक है, कम टू मेन पॉइंट, लेट्स टॉक अबाउट IGRT. व्हाट इज़ IGRT? IGRT मीन्स यूजिंग इमेजिंग बिफोर और ड्यूरिंग रेडियोथेरेपी, यानी कि to verify patient position, localize target and organ at risk, correct setup and motion related errors, and improve accuracy to treatment delivery. So basically, IGRT help us to confirm that what we planned is exactly and what we are delivering. In this graphic, also show that IGRT is a technical imaging technology such as X-rays, CBCT, USG or MRI are used to verify and correct the patient position and target localization immediately before or during radiotherapy. Now, why need IGRT? हमें IGRT इमेज गाइडेड रेडियोथेरेपी की आवश्यकता क्यों पड़े? तो we need IGRT because radiotherapy faces daily uncertainties such as patient setup variations, internal organ motions, anatomically changes during treatment. बहुत बार आप लोगों ने देखा बहुत सारे वेट लॉस होते हैं, बहुत सारे चेंजेस होते हैं, और तो उसके लिए परफेक्ट प्रिसाइज डोज डिलीवरी के लिए हमें इमेज गाइडेड की आवश्यकता पड़ी. IMRT भी था, पर इमेज गाइडेड रेडियोथेरेपी की आवश्यकता इसलिए पड़ी कि हम प्रिसाइज डोज डिलीवरी कैसे कर सकते हैं, कैसे पेशेंट की पोजीशन प्रॉपर हो, हम एक्यूरेसी हो, यानी कि जो प्लानिंग कंटूरिंग आंकों ने किया है और फेसेस ने प्लानिंग की है, हमारा रोल उसके लिए क्या है, हम कितना प्रिसाइज डोज डिलीवर कर सकते हैं. क्योंकि कंटूरिंग एक बार हो गई और फिर कंटूरिंग के बाद फेसेस ने प्लानिंग भी कर दिया, तो डेली का जो हमारा रूटीन है वो तो हमारे ऊपर पेशेंट टोटली डिपेंड होता है, टोटली डिपेंड ऑन RTTs. क्योंकि आप क्या कर रहे हैं भाई, आंको एक बार 2 बार या वीकली अगर वो ऑब्जर्व कर रहे हैं आपको, तो आप क्या कर रहे हैं, आपका रोल बहुत इंपॉर्टेंट हो जाता है. RTT का रोल, बेसिकली RTT का रोल बहुत ही इंपॉर्टेंट होता है इसके लिए, और ये टीम वर्क है. सो IGRT help reduce this uncertainties by ensuring accuracy beam alignment every day for every fraction. Parts of IGRT. IGRT consists of 2 major components. First, principle of IGRT, which includes error uncertainties, PTV margin concept correction protocols, and immobilization. Second, technology for IGRT, which include multimodality imaging and motion management methods. Both are equally important to successfully IGRT implementation. What is an error? An error means many many mismatch between true anatomy and physiology, and planning position versus treatment delivery position. Errors are important because if we miss the target, it leads to underdose, and if we overdose the organ at risk, it leads to unexpected toxicity. So error management is critical in radiotherapy. Type of errors, basically three types of errors. Error can be classified in three ways: by sources, such as a delineation setup and organ motion; by time, interfraction and intrafraction errors; by pattern, systematic and random errors. Understanding these helps us design corrections, strategy and margins. On the behalf of this, हम बहुत सारी चीज़ें, हमारा जो भी प्लानिंग बेस होता है, हम जो भी इमेज गाइडेड के लिए जाते हैं या इवन ट्रीटमेंट डिलीवरी के लिए, मैक्सिमम ये एरर्स हमारे लिए मैक्सिमम ये सारे एरर्स जो है हमें मॉडिफाई करते हैं. एरर्स चैन भी आप इस ग्राफिक्स में देख सकते हैं: इमोबिलाइजेशन, इमेजिंग, कंटूरिंग, प्लानिंग, सेटअप, डिलीवरी एंड इमेज गाइडेंस. So imaging errors. Imaging related errors include poor visibility of tumor or organs and risk on CT, inaccurate image fusion between CT and MRI, image distortion due to patient motions, foreign bodies or machine artifacts. पेशेंट का अगर इम्प्लांट है या हमसे कहीं छोटी मोटी गलतियाँ, या हम जो मार्किंग करते हैं, मार्किंग बिहाफ पे हमें कहीं अगर हमने ऐसा कोई फॉरेन बॉडी छोड़ दिया है, सो दैट्स इमेजिंग रॉन्ग, देन एवरीथिंग दैट फॉलोज विल आल्सो बी रॉन्ग. अगर हमने इमेजिंग, इट मीन्स कि बहुत बढ़िया कंटूरिंग हुआ है, बहुत बढ़िया प्लानिंग हुई है, और हम इमेज फ्यूज़न नहीं कर पा रहे, हम इमेज को वेरीफाई नहीं कर पा रहे हैं, यानी कि हमारा क्लिनिकल नॉलेज बहुत अच्छा नहीं है, तो डेफिनेटली बहुत अच्छी कंटूरिंग, बहुत अच्छी प्लानिंग के बाद भी पेशेंट पोजीशन और प्रिसाइज डिलीवरी पॉसिबल नहीं होगा. सो एरर्स इन डेलिनेशन एरर. डेलिनेशन एरर्स मीन्स अगर कंटूरिंग हो रही है, कंटूरिंग में कहीं हम आउटलाइन, बॉर्डर लाइन मिसमैच कर रहा है, या हम प्रॉपर फ्यूजन नहीं कर पाए हैं, प्लानिंग में इशूज़ हो रहा है, तो एरर्स ऑकर्स ड्यू टू इनकरेक्ट इंटरप्रिटेशन ऑफ इमेजिंग लीडिंग टू पार्शियल और कंप्लीट टारगेट मिस. CTV errors happens due to poor understanding of microscopic spread, which may cause marginal failure or increased toxicity. So accurate contouring using guidelines is extremely important. It's a major role for oncologists and also faces. Setup errors. Setup errors are the difference in target position between planning CT and treatment delivery position. It can be detected using 2D imaging like APIT or KV X-ray and 3D imaging like CBCT. This is the most common daily errors we manage in IGRT. Setup errors occur due to technical factors like laser misalignment, couch sag. Actually हम कभी का मैक्सिमम टाइम हम क्या करते हैं कि बहुत सारे इंस्टीट्यूशन में देखा गया होगा कि जब पेशेंट पोजीशन करते हैं तो पेशेंट का जो इंट्रेंस होता है, एक ही साइड से बार बार हम पेशेंट को मैक्सिमम अगर हम पेशेंट 50 या 60 पेशेंट अराउंड कर रहे हैं, या 200 सम इंस्टीट्यूशन ट्रीटेड मोर देन 200 पेशेंट्स, या 100% इन मशीन. सो हम क्या करते हैं कि एक ही साइड से हम पेशेंट को मूव करते हैं, एक ही साइड, तो मैक्सिमम टाइम काउ सैगिंग, और हम उसको अलाइन नहीं करवाते हैं, अलाइन हमारा लेजर मिस अलाइनमेंट हो जाता है, या काउ सैगिंग होता है. इसकी वजह से बहुत सारे एरर्स आते हैं जो सिस्टमेटिक भी हो सकते हैं और रैंडम एरर में भी आ सकते हैं. सो पेशेंट रिलेटेड फैक्टर्स लाइक पुअर इमोबिलाइजेशन. इमोबिलाइजेशन का रोल आप सबको पता है कि अगर प्रॉपर इमोबिलाइजेशन नहीं है, स्टिमुलेशन हमारा नहीं है, तो हम लाख कोशिश कर लें, और आप सब उस दौर से गुजरे हुए भी होंगे, और आप सब जानते भी हैं कि क्या क्या इशूज़ आते हैं. अगर आपके पास इमोबिलाइजेशन डिवाइसेस प्रॉपर नहीं है और आपने किया नहीं है, तो दोनों में आपके लिए हमेशा मुश्किल खड़ी रहती है, और आप हमेशा जूझते रहते हैं कि भाई हम इमेज कैसे वेरीफाई करें, मिल नहीं रहा है, आज तो यार इसको कर दो, कल देख लेंगे, फिर एक बार कल से ट्राई करेंगे. तो अगर ये सब चीज़ों से बाहर आना है तो हमें डेफिनेटली इमोबिलाइजेशन प्रॉपर होनी चाहिए हमारी. डेली सेटअप वेरिएशंस. हमारा स्किल, नो डाउट कि हमारा स्किल हमको पता होना चाहिए कि हमें क्या चाहिए, कौन से आर्गन को मैच कराना है, कौन से बोनी लैंड को मैच कराना है. एंड इम्प्रॉपर एक्सटर्नल मार्किंग. सबसे इंपॉर्टेंट है मार्किंग. अगर आपका लेजर अलाइनमेंट प्रॉपर है और आपने प्रॉपर मार्किंग करी हुई है, तो मुझे नहीं लगता कि बहुत सारी दिक्कत हो. दैट इज़ वाई गुड इमोबिलाइजेशन एंड वेरिफिकेशन आर इसेंशियल, बिकॉज कि अगर इमोबिलाइजेशन है तो पेशेंट भी बहुत अच्छे से अपने आप को कंफर्ट जोन में पाता है. अगर प्रॉपर इमोबिलाइजेशन नहीं है, आपने बहुत टाइट मोल्ड बनाया हुआ है या बहुत ढीला है, तो भी पेशेंट के लिए कंफर्ट जोन नहीं होता है. नाउ ट्रांसलेशन एंड रोटेशनल एरर. Translation error occurs in X, Y, and Z directions, vertical, lateral, and longitudinal. Rotational errors occurs as a pitch roll and yaw roll. 6D cows जिनके पास है उनको ये पता होगा कि pitch roll and yaw what is this, तो आप उसके बिहाफ पे भी ज़्यादा सारी चीज़ें कर सकते हैं. Can correct the both translational and rotational errors 6D couches which improve setup precise. Organ motion and deformation. Organ motion happens due to respiratory bladder, rectal filling, weight loss, and tumor regressions. These changes can happen over seconds of weeks. So even if setup is perfect, internal anatomy may still changes, and image-guided radiotherapy help us detect that. क्योंकि ऑर्गन अगर पेशेंट समटाइम्स एक हफ्ते बाद या एक हफ्ते के बाद 15 दिन बाद या 10 या 15 फ्रैक्शन के बाद पेशेंट वेट लॉस करता है, बहुत सारे इश्यूज रहते हैं, तो वहाँ भी एक एरर्स आने के चांसेस रहते हैं. एंड एरर्स अकॉर्डिंग टू पैटर्न आप इसमें देख सकते हैं कि सिस्टमेटिक एरर यानी कि इट इज़ अ सिस्टमेटिक एरर्स रिमेन सेम इन डायरेक्शन एंड मैग्नीट्यूड फॉर ऑल फ्रैक्शंस एंड causes consists row shift. Random errors varies every day and causes blurring of dose distribution. Both errors are used to calculate PTV margin. PTV margin के लिए systematic and random errors बहुत important role play करता है, क्योंकि हमने PTV margin, why need PTV? PTV ensures adequate dose coverage to the target while sparing organs at risk. Small margin may cause target miss and large margin may increase toxicity. So margin must be carefully calculated. PTV margin हमारा सिस्टमेट इंस्टीट्यूशन वाइज बहुत मैटर करता है. रैंड हम ये तो नहीं कह सकते कि ओवरऑल. और पीटीवी मार्जिन कॉन्सेप्ट इनके आईसीआर इंटरनेशनल कमीशन ऑफ रेडिएशन यूनिट एंड मेजरमेंट, इन्होंने आईसीआर 29 किया 1978 में, और 1990 में इन्होंने आईसीआर 50 किया, जिसमें जीटीवी, सीटीवी और पीटीवी मार्जिन था. आईसीआर 62 लॉन्च इन 1999. सो जीटीवी, सीटीवी एंड पीटीवी को कन्वर्ट किया गया आईटीवी एंड पीटीवी मार्जिन में. सो दीज आर पीटीवी मार्जिन कॉन्सेप्ट. हाउ पीटीवी मार्जिन डिराइव्ड? मैक्सिमम लॉट ऑफ फार्मूलाज फॉर देयर, बट मैक्सिमम ऑनको एंड फिजिसिस्ट गो विथ वन हर्क फार्मूला, क्योंकि ये इंश्योर करता है कि मिनिमम सीटीवी डोज जो है 95%, ये 90% पेशेंट के लिए होता है उनका. तो वेन हर्क फार्मूला टू इंश्योर दैट कि 90% कवरेज वेयर 95% कवरेज टू 90% पेशेंट्स. सो हम मैक्सिमम वैन हार्क फार्मूला के साथ जाते हैं पीटीवी मार्जिन जो हम कवर करते हैं. Immobilization radiotherapy. Immobilization is not only using devices, but is a process to reduce variation and motion. It reduces interfraction and intrafraction motions, reduces imaging dependency and saves setup time. Good immobilization improve reproducibility and comfort. मैंने पहले भी कहा था अपने उसमें कि immobilization बहुत ही important role है रेडियोथेरेपी के लिए, इवन इमेज गाइडेड रेडियोथेरेपी के लिए भी और हमारे लिए भी. ऑफलाइन एंड ऑनलाइन वेरिफिकेशन, ऑल ऑफ यू अवेयर अबाउट दिस कि ऑफलाइन वेरिफिकेशन क्या होता है, यानी कि जब ट्रीटमेंट कंप्लीट डिलीवर हो गया उसके बाद. और ऑनलाइन वेरिफिकेशन इट मीन्स कि जब हम ड्यूरिंग ट्रीटमेंट हम अपने आप को जस्टिफाई कर सकते हैं, उसी से हम सारी चीज़ें चेंज कर सकते हैं. सो माई टेक होम मैसेज, प्रिसिजन रेडियोथेरेपी इज़ नॉट जस्ट अबाउट मशीन, इट इज़ अबाउट माइंडसेट. मैंने पहले भी कहा कि मशीन नहीं, आप क्या करते हैं वो बहुत मैटर करता है. कई बार हम ऑटो मैच करते हैं, आप लोगों ने देखा भी होगा कि ऑटो मैच करने के बाद बहुत सारे वेरिएशन आते हैं, बहुत सारे चेंजेस आते हैं. तो हम क्या चाहते हैं, हम कैसे उसको परफेक्ट करते हैं, दैट इज़ मोस्ट इंपॉर्टेंट. इट इज़ अबाउट मशीन. आईजीआरटी इम्प्रूव प्रिसिजन एंड पेशेंट सेफ्टी. इमेज गाइडेड है ही इसलिए कि हम अगर डेली इमेजिंग करें तो हमें वेरिएशन दिखता है, हम उसको अपने आप उसके साथ अपने आप को इम्प्रूव कर सकते हैं. पेशेंट को बहुत ही केयरफुली और बहुत ही प्रिसाइज डोज डिलीवरी कर सकते हैं उसके साथ. थर्ड इज एक्यूरेसी डिपेंड ऑन आरटीटी स्किल एंड जजमेंट. मैंने बार बार कहा कि बहुत अच्छी कंटूरिंग, बहुत अच्छी प्लानिंग के बाद भी अगर आपका स्किल डेवलपमेंट, आपको क्लिनिकल नॉलेज नहीं है, तो हम वहाँ आके सारी आंखों की सारी मेहनत और फिजिक्स की सारी मेहनत बर्बाद कर देते हैं. अगर वहाँ कोई गलती डेलीशन एरर है और हमें थोड़ा सा नॉलेज है, तो हम ये तो कह सकते हैं, डायरेक्टली हम नहीं कह सकते नहीं सर ये गलत है, ऐसा तो नहीं हो सकता, पर हम ये जरूर कह सकते सर कैन वी सी दैट. तो हम एक रिक्वेस्ट कर सकते हैं, रिक्वेस्टिंग मोड, बट वो तब होगा जब हमें पता हो कि ये सही या गलत है. So, imaging is meaningful only when interpreted correctly. IGRT supports personal radiotherapy, and the future is adaptive, AI-based radiotherapy and patient-centered. Thank you so much. ये हमारी छोटी सी स्मॉल फैमिली, क्यूट सी फैमिली है. अभी हमने स्टार्ट किया हुआ है चंदन हॉस्पिटल में. हमारे HOD और चेयरपर्सन सर उदय सर भी यहाँ विराजमान हैं. तो थैंक यू सो मच. Any question?
Any questions from the audience? No. Thanks Naveen ji for such an excellent talk. और ये आपने बिल्कुल सही कहा कि RTTs जो होते हैं, एक्चुअली जो रेडिएशन डिलीवरी, इट्स अ टीम वर्क एंड RTTs आर द बैकबोन. अगर समटाइम्स क्या होता है कि हम लोगों को भी कभी कभी पूछना पड़ता है RTT से कि हम कैसे इनको बेटर सिमुलेट कर सकते हैं. तो ऑब्वियसली इट्स अ टीम वर्क, एंड IGRT इज़ वेरी इंपॉर्टेंट नाउ अडेज बिकॉज वी आर डीलिंग विथ like we are delivering a high dose of radiation to the tumor very precisely. So it's thank you for such an excellent talk.
थैंक यू सो मच मैम. एक्चुअली उधर से हमें बहुत कुछ सीखने मिलता है. रिसेंटली हमने स्टार्ट किया तो डेफिनेटली आई वाज इन कमला नेहरू जस्ट ए फ्यू मिनट्स. आई वाज इन कमला नेहरू जिनसे डॉक्टर बी पाल थैरियल सर, उनको पद्मश्री मिला था पहली बार. जब वो संसद में उन्होंने दिया था, स्पीच दिया, तो हम लोग पास एक कॉपी लेके आए थे. तो उन्होंने कहा था इसे टीम वर्क जब उनको मिला था, ये केवल मेरे अकेले का नहीं है. मैं बहुत अच्छी कंट्रोलिंग करूँ, फिर से बहुत अच्छी प्लानिंग करे, पर हमारा RTTs जाके अगर वहाँ 1 सेंटीमीटर शिफ्ट कर दिया उसने, तो हमारा सारा मेहनत बेकार हो गया. और हमने कहीं मिस्टेक किया हुआ है और फिजिसिस्ट ने भी किया हुआ है, और RTT को पता है कि नहीं सर यहाँ ये इशूज आ रहा है, तो वो ये तो नहीं डायरेक्टली नहीं कह सकता कि ठीक है चलो सर हम
हायरार्की मेंटेन करना बहुत इंपॉर्टेंट
डेफिनेटली मैम, कि हम ये नहीं कह सकते नहीं सर आपने गलती
पॉइंट आउट
करी.
करना भी इंपॉर्टेंट है.
हाँ,
अगर
पर हम एक
कहीं-
रिक्वेस्ट कर सकते हैं कि नहीं
हाँ.
सर आप कैन यू.
हाँ.
तो जैसे सर हमारे उदल सर हैं, वो कहते हैं नहीं दुबे जी आप यू मे कंटिन्यू करिए सर. और सर प्लीज़ हैव अ सीट. तो सर आते हैं, बैठते हैं, देखते हैं, बहुत से समझाते हैं, क्योंकि क्लिनिकल नॉलेज अल्टीमेट है उनका. तो हैट्स ऑफ हिम. वंस अगेन थैंक यू सो मच. हाँ,
Now comes a topic that truly defines precision in modern radiotherapy, because when millimeter matters and even a degree can make a difference, accuracy is no longer an option, it's a responsibility. It will be a great pleasure for me to invite a name who needs no introduction in the field of medical physics, Dr. Biplab Sarkar, Chief Medical Physicist, Apollo Kolkata, to kindly take the stage for his talk on 6-dimensional patient position correction. A warm round of applause for him.
Thank you everyone, and I'm thanking sincerely for calling me over here for this presentation, and thank you Apex team. Beforehand I'll giving the thanks to all and RTTs India Conclave. Now my topic is 6-dimensional rotational and rotational correction. Mainly I'll focus on the rotational correction, how it is work and what we see in regular practice, in a day-to-day practice. Say for example, we usually face, it is in, I'll take the name of the vendor, which is not bad as well. Say for example, in Electa, we see a lot of, say for example, there is a table correction of 1 degree or 2 degree. Now you will see a table moves almost 4-5 centimeter. Now why this happens in place? So what is the fundamental logic of correcting the rotational error? Say some of us is in a good setup, they are doing a lot of stereotaxis, including the lung, liver, and the cranial stereotaxis. So we should understand that why there is so much of table correction is applied for patients for a very small rotational corrections. Okay, we try to understand this particular topic for the day. Now, our story starts somewhere in 300 BC with a Euclid, when the Euclidean coordinate system is defined, and then subsequently René Descartes is a French mathematician who's defined the Cartesian coordinate. We'll concentrate on the Euclidean space and Cartesian coordinate. Even today also whatever we define is in a Cartesian space, Euclidean space. So the proposition is applicable only for the rigid body. Rigid body means which is immobile and well immobilized. Say for example, the torsion, if there is a torsion in the page in somewhere, then this proposition or this theory doesn't hold. Say for example, deformation doesn't hold with this theory. You cannot correct the deformation with your rotational corrections. It is not possible. Say for example, patient has lost weight or there is a tumor regression, so you cannot correct this kind of situation with your rotational corrections. So it is the rigid body dynamics is applied to all the correction. The same mechanism they used to build up a bridge, the same mechanism is applied for the patient positional correction as well. Now there are 6 motions we know. there are 3 translational motions and 3 rotational motions. Now, translational motion are x, y, z direction. You can do it in any sequence, first x, then y, then z, or first z, then x, then y, and whatever. Whatever way you wish to do, you can do it in any order. But in a rotational corrections cannot be, doing the rotational correction is a very tricky thing, it's a bit tricky thing. It cannot be corrected with the, in any sequence. I mean, there is a particular sequence which has to be followed for the correction of the rotational errors, otherwise it is not possible to correct it. Okay, so it is not due to the absence of 6D couch, it is due to the fundamental drawback of the Euclidean system, or fundamental property of the Euclidean system, that it will not allow to correct the rotational corrections with a proper sequencing. Now, it has to be a vector shift. Like, you cannot see, you will not see that table is correcting x, y, z, and then rotating like this or something. They will have a single correction, one set correction. It is a vector correction. Okay, so the total vectors have to be defined, or it is very difficult. It is very easy to calculate. I mean, it is a class 12 level calculations has to be done, and then this is stored in the system, that whatever particular x, y, z and rotational corrections, what vector shift will be created, and it is calculated immediately and applied to the couch, and it will be corrected. Okay, this is called as a vector shift. So the corrections is something like that. So it is not that arbitrary, first I rotate x direction, then y direction, z direction, nothing like that. So this is incorrect. So first table will move. There is a translational motion. There will be, every rotation have a associated translational motion, and that is a very high translational motion. For 2-degree correction, it has to move around 5 to 7 centimeter. Okay, so first they have to correct the origin of the system. I'll show you how it is correcting. Origin of the system, first the translation motion will be applicable, and then the rotational correction. It is a, it's not going back. So this is a 6-dimensional couch, which is actually we are using for a regular practice. So this is a quite good thing. The 3 translation and 3 rotational error all can be corrected against the isocenter. Effective way of correcting the positional errors, it is cost very high. Okay, so this is one of the drawback of the system. So these 3 are the rotations: yaw, roll, and pitch. Okay, these 3, just for a remembrance I am telling it. So what is the origin of the rotational error? Major origin of the rotational error is the table sag. One of the major reason is that your rotation is table sag. So see, you can see that this is actually taken by our colleague Dr. Upender Giri long back, and then see this photograph. See, there is a 2 centimeter, 2 millimeter, almost it is almost 2 centimeter shift in the cranial direction. So this is falling because of there is an attachment used. Okay, so now these tables are more smart. It is a bit old picture, but the philosophy remains to be same. There is a serious table sag in the cranial direction. Okay, because see, for example, when the patient is tested for the tested for the commissioning, they will not use a proper weight. What they will use is a small phantom. Okay, so it weighs 500 grams. A human brain, human head weighs about 11 kgs. So there is a mismatch between the test method and the actual patients. Okay, so there will be a table sag, serious table sag. So there is a 2 methods of correcting it. One is 6-dimensional motion enabled robotic couch, and there is a method if you doesn't have a rotational couch, 6-dimensional reliable couch. Now this is the correction. Now this is the planned one, the top corner. Now this is without the table correction. See how the dose cloud is moved away from your from the tumor. And the third one is the after 6D table correction. So it is almost merging with each other. It is not necessary that it will 100% match. the minimum accuracy of the table position correction is 0.2 degree and 0.2 mm, which is quite low actually, but still there is some discrepancies. It is not that 100% it can correct, but it is more or less it will correct majority of the cases. So for example, if I don't correct the 6D correction, then the PTB dose will fall somewhere here. Fortunately, this time it is coming to the lateral side, the dose cloud is going lateral side of the tumor, so it is not affecting the brainstem. If you just remember the position, if it is the other way around, then it will affect the whole brainstem. Okay, this is a 16 gray 1 fraction plan which is exceeding the brainstem dose for a single fraction correction. So this is another typical example. See, there is a target which is invading the brainstem, partially invading the brainstem. Now this is the planned one, then this is the after 6D correction, and this is the before 6D correction. So you can see that after 6D correction also it is not 100% corrected. But the main concern for all this for here is that we have to preserve the brainstem. We cannot supersede the brainstem tolerance dose. That is an offense. Okay, because if you supersede, if you exceed the brainstem dose, then patient might lead to a paralysis in due course of time. Okay, so this is more important than the more important than the tumor control here. So there is a dose loss. Still there is a dose loss after 6D correction also. So it is not always possible. Now this is the physics why it is how it is being done. Now if the tumor is away from the isocenter, which is 100% time, you will never see a patient tumor is at the isocenter. I mean to say that the couch having its own fulcrum point. Fulcrum point is the isocenter for couch. It is not your isocenter is the, so corrections are done from the fulcrum point, which is at the tail end of the couch. Okay, so 100% time you will find the couch, the isocenter is not at the tumor center. So this is a star and a arrow which is piercing each other. Now I rotate the, I missed something. Now, sorry. Now I come up with a, this is piercing the star in a particular angle. Now I rotate the star a little bit, it's a red star. Now with all effort, I cannot match the same angle with this arrow, red arrow. So what is the problem? Why it is not possible? Because now how it will be possible? Rather say how it is possible. Now this is the same arrow and star. I have given a bit of rotation. Now I have to move the table first. So table isocenter is moved, a coordinate system is moved. Then I apply this rotation. Then again it will, the star and arrow will touch each other in the same exact angle. So this is the reason you see a lot of shift in the cranial direction before you when you apply a rotational correction. So rotational correction, every degree of rotational correction is considered about 5 to 7 centimeter of translational shift. Okay, so associated with, even just rotational correction is also applicable, cannot be applied. So if it is in the isocenter, if the tumor position is the, it is a feet first supine and you are at the corner of the end of the couch, your tumor, then it will be very easy. Then you give a rotational correction, it will correct. But in general, it is not, it is just a theoretical one, you never find it in a practical purpose. So, how to handle a rotational correction? Rotational correction, is it required to correct all the rotational thing? Probably not. It is not required to correct all the things. So some corrected with the 6D correction. Some told that, some says that we never know how to correct the rotational corrections. That's fine. I mean, you need not to correct the rotational correction in the majority of the times. It is a very limited effect, but it is very pronounced effect. Okay, so you can ignore it safely. There is no problem, not bad in the large number of times. For large tumor, ultra large tumors, see this is my rotational correction. Now these corrections are not effective. I'll say that where it is, I'll show you where it is effective and where it is not effective. Now there is some methods they use a vector shift. I mean, they will create a vector out of the x, y, z and all three angles, and then apply the total shift, but this is usually very large. it is exceeding the PTB margin. So it is not very recommended, but before 6D table comes into the commercial use, there are a lot of publications, especially from Japan. They are doing the spine stereotaxis where they have shown the different method of correcting it, but this is no more valid. They are mathematically not rigorous neither, but by that time came into the 6D couch came into the system around 2014 or so. Before that, this is the only method to correct the thing. They used a matrix method. There are several methods and all these things. Then additionally, you cannot apply the rotational correction in your PTB to CTB to PTB margin, because there is no vendor allows you to correct it in the CTB to PTB margin. So what we have to do, we have to convert all rotational corrections into a translational correction and incorporate it into the CTB to PTB margin. Now, so what we did collected a CBCT for two CBCTs. One is the first we take, then correct the position, and again you take a CBCT, and then convert this total 6 coordinates into a 3D translational coordinate, x, y, z, capital X, capital Y, capital Z, and then applied that shifts into the planning system to see that whether we are correcting it properly or not. Okay, so this is a Excel sheet which we corrected. So resultant, you created a resultant values with the 3 shifts, and we checked it. It is quite good. Actually, it is 99.8% accurate. That how the correction without a 6D table can be done with only the translational correction that is being created. So, and we measured it. We dosimetrically verified it with the arc check and all these things. So it is quite laborious and labor intensive, time consuming process, but we have did it. We finally found that it is quite good. So now this is the two things. One is the TPS calculator, the top one, and the lower one is the one which is the 3D shifts applied to the TPS. So it is quite good matching between each other. There is no dose fall off between these two things. So it is not necessary that you should have always a 6D correction, 6D couch to correct your stereotaxis. It is possible to otherwise also to correct the table positions. Okay, there is a certain publications which is done. And just to conclude it, now brain stereotaxy, we did a bit of job on the brain stereotaxy. The rotational correction usually reduce the Y rotation, Y margin. Okay, so see, for example, without rotational correction, Y margin is 1.2 millimeter. It is a brain stereotaxy, but with rotation, it is reduced. Okay, X margin will increase, Y margin will reduce. That is the standard process of thing. Now, this is for the lung SBRT and liver SBRT also. There is certain changes over there. Say 5 is reduced to 4.4. Okay, so similarly 3 is reduced to 2.8, 4 is reduced to 4 is increased, Z margin is increased. So there is certain changes there, but this needs to be verified. Now large tumor, this is we talked about so far with the small tumors like stereotaxy. Now large tumor, there are two school of thoughts. One is says that this is published in BJR in 2018. This is actually a cylinder. This is for a nasopharynx cases. What they have showed that with a error of pitch error of 1.5 degree, which may reduce to a significant dosimetric error, and patient may it is deteriorating to the patients. Now this is applicable only for the cylindrical shaped tumor. Now there is another school of thoughts which is published in 2000, I think 20, not very late. It is very recently, 2022 or so, and they showed that there is if it is more than 4 centimeter in diameter, then there is no effect of the rotational corrections. Okay, so but these two studies having its own limitations. One is for the cylindrical and the second one is for the only spherical target. So it is having its own limitations. So I'll just summarize the thing. So try to simulate the patient in most comfortable, how to reduce the error, that is the most important part. Try to simulate the patient with the most comfortable position. Do not force the patient to straight position is, or make it bilaterally symmetric. Keep the immobilization reasonably tight and cover with the blanket. Cold always create a additional errors in positional errors. Keep a good IGRT workflow in the department. Train your therapist, resident doctor and physics to follow the IGRT workflow. Thank you. I'll just end up with the use a generic margin, and thank you for your time and patience. Thank you all.
Any question from audience?
Hello. Thank you, Biplab ji. Actually, you focus on this issue.
I'll be rather happy. You call me Biplab, I'll be rather happy.
What is a take-home message for the therapist actually when they can set the patient when considering these types of rotational error actually? So where we can focus it actually?
Yeah, the thing is that the therapy is rotational. See, often for what we encounter in our general practice, for a large tumor also people wants to correct. Over correction is not correct. Okay. See, the correction, if it is, see, if the if the positional correction is half of your PTB margin, then it should not be corrected. You should go with the whatever position patient have. Over correction might lead to a error in the other side. You are taking an instant image, a CBCT, which is cost you about 10 seconds or 12 seconds, or a X-ray image, which is for 2 milliseconds or 3 milliseconds. Now, based on that, you are over correcting the patients in his position is incorrect. So, for large tumor, see, except the nasopharynx, which is so far known, large tumors, anything which is larger than 4 centimeter in diameter should not use a rotational correction. Okay, it is over correction. And for small tumors, you do the rotational correction. There is no harm in it. But actually, you have to do, but not for the large tumors.
Thank you. Thank you.
Yeah, thank you, Dr. Biplab. Very nicely you explained the errors which every day we are facing on treating machines. I would like to add to that since you have a higher technology and you are able to correct before delivery with the unit which you have, but when the centers are not having that all 6-dimensional facility, I think if we place our focus during simulation, and during simulation if we are able to do topo of the site and we can make a cut at upper level, center level, lower level, and then we can view what exactly rotation is going to be with that topo and cut, and accordingly again we will go inside and do the positioning with that marginal changes, and then we will give a marking and again do the topo and cut of these 3 levels. Then definitely the therapist will be able to have less on the table of treatment machine, and then XYZ and roll pitch can be minimized. So we can do that practice and it will be beneficial.
Yeah. Whatever sir you said, it is very correct. Whatever we observed over the years, that first day when patient comes for the simulation, they are very anxious. Peat utha ke rakha hai. They are not putting for a liver SBRT or a inguinal load SBRT, they are not putting the completely down, they are not relaxed. So you have to console, along with the whatever you told, which is the technical part, we have to console the, see, first day patient comes, patient is very relaxed. Then they realize that we have to be part of this for next several days. So they became very relaxed. Okay, so we do those things, I mean, talking to the patient, consoling him or her, taking them in confidence, it makes the lot of changes. I mean, whatever topo is there, we also do this way, because we have to first correct it the origin. We cannot have it 6-dimensional. We have a 6-dimensional curve. That does not mean that we can do everything, whatever wrongdoing. It is not acceptable. They have to be very correct in the first day, in the beginning itself, and then subsequently whatever small error is coming, then they have to. We made a, if it is more than more than the PTB radius, we have the patient reset the patient every time. Thank you Apex team for your help, and Rajiv ji. for your support. Thank you, Upendarji. Bye.
Okay, thank you, sir.
Thank you, sir.
Thank you. I would request the speakers to stick to their time so that we can finish the session in time.
Movement is natural, but managing it precisely is an art. Please welcome Mr. Dantpani Ipli, Senior Medical Physicist, MPMMCC, for his presentation on real-time motion management and tracking.
Good morning, all. I would like to thank ARTTI Conclave Apex Super Speciality for inviting me for the talk. As you can see in my qualification, it is DIPRP, MSc Physics, and PGD RTT. I started my career as a radiation therapist. For a few years, I continued, and then I thought of upgrading, so I completed my DRP, and currently working as a medical physicist and RSO in TMC Center in Varanasi. I would like to congratulate previous speakers because they have helped me to build on my talk. Biplav sir, he spoke about various errors. Yogesh spoke about the communication skills which is needed by therapists. And also Naveen sir spoke about various IGIT techniques. The topic on which I'm going to speak today is real-time motion management and tumor tracking in radiotherapy. I hope it aligns much with the advance in radiotherapy and patient care theme of this conclave. Why tumor tracking matters? Now, we all have seen that, like before starting with this topic, I would like to say, like with the discussions which we had earlier, it very much implies that the error in execution of treatment in radiotherapy, in the complete course, it will start with a therapist and it may complete with a therapist. It may sound controversial, but because the treatment starts with simulation and the error continues. So everything starts with a therapist and ends with a therapist. So it's like a complete cycle. So the role of a therapist is very much important in the treatment. So now why tumor tracking matters? We all know that there are interfraction motions. Interfraction motion, as the previous speaker spoke about setup errors and the impact of interplay and imaging artifacts due to the motion. Now what would be the clinical impact? As we all know, it may lead to underdose of the tumor. Apart from that, if there are OARs in the vicinity of the target, we may overdose the OARs. So it may lead to higher toxicities. Now there are modern day approaches for this, for tracking and tracking these. One is gating, the second is real-time tracking, the third is beam hold, and the last is adaptive. I won't touch much on adaptive, but I will try to cover other three. Now, over the decades, we can see that due to the technological advancements in radiotherapy, what we are trying to achieve is this. From the conventional to the IGIMRT, this is how we are trying to sculpt the PTV. And we are trying to limit our dose to the PTV. Now, if we look at, most of the therapists would appreciate that while simulation, we can, if we have 4D scanners, we can see these movements. And these tumors and these motions are going to lead to a higher PTV margins and higher toxicities because we are going to irradiate higher or larger volumes. Now, it's not only due to the lung or the liver, there are various motions in head and neck also. So when a clinician draws a GTV and a physicist along with clinician gives a PTV margin, because of this motion, the margin becomes quite large. Yeah. What are the strategies to encompass these motions in our treatment? First of all, during simulation, what we can do is motion encompassment. that is by doing a slow CT, breath hold CT for DIBH, or a 4D CT for ITV generation, which would be a retrospective scan. Apart from that, we can do respiratory gated scans. Then we can have breath hold DIBH, as I mentioned earlier, for motion encompassment, and motion mitigation like abdominal compression, which may reduce the motion of the tumor, and tumor tracking. Now, when we talk about treatment approach, the real-time tracking technologies include direct X-ray tracking like Synchrony and Synchrotrax or Vero, EM transponders like Calypso, which is also known as the GPS for the body, surface or optical guidance, SGRT, and ultrasound tracking like Clarity, and MLC and couch tracking, which generally people use. Now, respiratory gating techniques. Now, there are various surrogates which we can use for like external surrogates like marker blocks, like RPM, now it is known as RGSC, SGRT for optical surface guidance now, and also spirometry is used like in Electa somewhere people are using these. Internal and direct tracking using markers with the help of fluoroscopy. With MR also people are doing real-time soft tissue tracking. With gated window and duty cycle also like gated scans. But yeah, but obviously what is going to happen is with gated, the duty cycle is going to increase. The overall treatment time is going to increase because the beam would be on only for a partial time of the whole treatment time. And apart from that, there are residual motion management where people are using additional margins. People also utilize 4D CBCT to verify, but obvious it is a bit time consuming, but it is helpful. Now, clinical application, when we talk about motions, the most common sites which are used for applications of motion correction is lung, liver, and pancreas. The motion with lung, we can see the highest margin of error would occur if the tumors are in the vicinity of the diaphragm, and because of the motions, we can say that degree of motion is of the magnitude is of 20 mm. It has been recorded in the literature that the motion could be of up to the order of 20 mm, and the motion management strategies which we utilize for that is abdominal compression, respiratory gating. With MR Linac we do MR Cine tracking, Synchrony which is marker based, and for liver, although the margin is a bit on the lower side as compared to the lung, but it is higher when we talk about the tumors which are near the diaphragm. So the management strategies for them would be compression plates, ultrasound guidance, MR guidance, or implanted fiducials. For pancreas, with recent MR guidance, a very tight PTV to GTV to PTV margin when we see, with a very tight margin we can go ahead with the treatment. Now, dosimetric challenges and impact. As a physicist, we always discuss with the clinicians that with such a large volume, how do we expect us to reduce the OAR doses, and how do you expect the therapists to treat the doses delivery, deliver the doses accurately, and how to reduce these errors. So motion management, yes, but obvious it is going to help a lot. But apart from that, from simulation to treatment, we have various errors which are always a headache for physicists, like motion blurring, interplay effect, baseline drift, OAR proximity of the tumors, and apart from that, the day-to-day setup variability. For this, various strategies has been used historically, and currently also people are utilizing. Like for motion blurring, people do 4D planning, ITV margins are given, gating is used. For interplay effect, repainting, dose repainting, multiple arcs are used, so that with multiple arcs, the overall error is averaged out and the dose is more accurate as compared to a single arc. Now, apart from that, real-time monitoring adaptive radiotherapy is also used for, because on day-to-day basis the tumor shrinks, the baseline data of the CT changes. So adaptive RT is always going to help. Apart from that, for OAR proximities, we do DIBH for breast cases and chest wall cases. And apart from that, in proton robust optimization is done for encompassing the errors on which are going to occur on day-to-day basis. Now for setup variability, as previously mentioned by the previous speaker, daily IGRT and CBCT, how it is going to help. Now, what is a 4D CT scan? It takes a real-time scan of the whole motion of the tumor. So how it is done is, there is a real-time gating equipment provided by, I will stick to Varian because I have Varian, I do not have much about Elekta thing. So there is a camera which you can see at the foot end of the patient, and there is an infrared plastic box which is kept at, which acts as a surrogate, the in-room camera and the associated software. Now during acquisition, if we see this sinusoidal wave somewhat resembles the whole respiration of a patient. So when we place the infrared marker on the position of surrogate during simulation, it will acquire the position of tumor in each position. So after the acquisition, it would be segregated into 10 different sets, each set defining the position of the tumor at every couch position. Now for execution, if you can look at the threshold borders of in the sinusoidal wave, these are the upper and lower border of where we want to treat the tumor. So how we treat is, so when the tumor is within that region, the beam is on, and when it goes out, it doesn't work. The beam is off. Now when we compare technologically about various technology available, there are electromagnetic, SGRT, optical based, KV or fiducial based, MR guided and PET based. Now out of this, if we look at the imaging dose, electromagnetic, SGRT and MR guided doesn't have much of the dose, whereas PET and KV have low or diagnostic range of doses. Whereas invasiveness, when we talk about invasiveness, SGRT and MR guided are non-invasive. Now I won't talk much about MR Linac because in the next session I think there is a talk about MR guidance. So I will just touch a bit on MR Linac. Now it uses a 1.5 Tesla MR, which can provide cine imaging also, which can use as real-time tracking of tumor, which can be used for real-time tracking of the tumor, but it is mostly helpful for soft tissue tumors. Now for MR-based real-time tumor tracking, there are various modes on which they can be utilized, like real-time MR cine imaging, anatomical position monitoring system, comprehensive motion management, gating by exceptions, and surrogate tracking. These are 4 management strategies which are used in MR Linac. One is free breathing exhale, where a gating envelope is used, where the tumor is treated when the tumor lies within the target, within that gating envelope. Whereas average position is taken where what we say as a ITV generation is done. Then apart from that, there is a breath hold when the tumor is much more away from the OARs and we treat, and there is an exception, that is beam is paused when the target moves outside a given tolerance, because although we think that there is a normal breathing during treatment or during simulation, but there is always some unusual things which can happen. So for that, to eliminate that thing, there is a non-respiratory motion exception. Now Elekta Unity uses CMM, intrafraction drift correction, where it traces the tumor and it modulates the dose accordingly. So this is a very good feature with Elekta Unity, where the tumor tracking is done. Now, I don't know how many of know about Syntex biological guided radiotherapy. It was first introduced in 2023 for lung and bone tumors. It's a biological guided system. It has a 6FFF beam linac. Apart from that, it has a PET detector. Initially, the field of view was 5 centimeter. With recently on January 8, 2026, the newer model Reflection X2 was launched, and it got its FDA approval. The PET sensitivity of it is 20 times greater than the standard value, and the rotation speed of the linac is comparable to, it is much higher than the tomotherapy, and it is comparable to somewhat to the diagnostic CT. The rotational speed is around 60 RPM, and it has binary MLC, and the clinical workflow of this biological guided radiotherapy is FDG is injected before the treatment, 60 minutes prior to the treatment. Signal is accessed, and planning is done on the basis of the signal value, and treatment is executed accordingly. The planning metrics for this is 2.7 normalized target signal, and which is a hard constraint which has to be achieved. Then the activity level has to be 5 kilobecquerel per ml, and the screening criteria is those patients or those tumors which are showing SUV values greater than 6 are only utilized for this. Now, summary and future directions, if we want to summarize everything, AI driven prediction like CMM, which uses, is a AI driven prediction somewhat, and online adaptive radiotherapy is also coming up, like it was discussed earlier, that machines like Ethos and various other upgrades are utilizing online adaptive radiotherapy, and biofeedback variables like Varian provides the spectacles which can be used for guiding the patient. Apart from that, MR guidance expansion is done. So the key takeaways from my presentation would be we need to match the strategy and about what is the ITV. It has to be uniform throughout the nation, if not nation, but at least within the center there should be tailor-made PTV values depending on your technology available, and physicists, technologists, and oncologists has to sit together and generate a plan to how to execute their treatment deliveries where a tumor with a higher motion is involved. Thank you. I would also like to thank Mr. Abhishek Singh. He's one of my colleagues. He provided me some time to prepare this. And also Mr. Manohar from Yashoda Hospital, Ghaziabad. He helped me with the MR linac thing. I'm open for questions. Thank you.
Thank you, Ipili. It was an excellent talk, and it is a big topic, and you tried to cover it within 15 minutes. So it is, and for all of us who don't know, he's working. We are working together in Mahamana, and I look after thoracic and head neck oncology. So it is more of my discipline, which we have encounters more often. Initially, when we started 3-4 years back, there were a lot of confusions regarding how to approach. Just he shared that experience. We have big tumors and you are targeting to achieve this constraint. How is it possible? So over a period of time, I shared my clinical inputs. They shared their physics inputs, and our technologists have implemented. And now, for last almost 1.5 years, we have no confusion. We rarely have any confusion. Everybody knows their work. My job is to contour, my job is to give the constraint. The options are two: either you achieve the constraint on day 1 or you be ready for replan. Because the constraint has to be achieved, clinical output has to be patient. We cannot compromise patient quality of life and save the patient. Similarly, we can't compromise on tumor control. So over a period of time, we have realized that the teamwork matters. And at every small inputs, they have right to question me. I am not the owner of that patient. I am just a caregiver of that patient. And my team, everybody has that liberty to question me, sir, can we do it better? And I am always welcome to my suggestion, as my colleagues would concur. But it was difficult convincing them. I shared with them, whenever a patient does well, when a patient has very good quality of life with a good tumor control, I share those experiences with them. Sometimes it happens I am working on the machine, what is the motivation? Whatever I do, nothing is going to change. Sometimes technologists treat the patient, they are not interacting with the patient once the treatment is completed. But the clinician, when he shares that what you have done is actually showing the results, they become convinced, they become part of your team, and they are more. So right from day one, when patient visits our OPD, and from the time when he visits for follow-up, he appreciates their work, and I share with them. Sometimes they say, no नहीं हम तो आज जाएंगे और कल start हो जाएगा. मैंने कहा हमारे यहाँ नहीं होगा. हमारे यहाँ नहीं होगा क्योंकि जो हम करना चाहते हैं जब तक हम श्योर नहीं होंगे हम नहीं करेंगे. And my team has always helped me in that, and they have been very cooperative. Both my technologists, my clinical team, as well as my physics team, they have been supportive. Sometimes we had discussions that these things are not possible. But over a period of time, as I said, in last 1.5 years, I rarely have any experience. I just share them that I want this, and invariably they do. If the constraint is not achieved, they are ready for replan, and we have done. So ultimately, we might not succeed 100% time, but we should try to best go forward. So I would like to thank Ipili. He is one of our first members who joined our organization, and we have been from the beginning working in the institute, and we have made a good team, and we are working together. And I would like to, you did a commendable job in your presentation. I would welcome other questions.
Thank you very much.
Hello.
Hello.
It's nice presentation here.
Thank you.
And nice to meet you after a long time. You all have said about the tumor tracking, that is lung movements.
Yep.
And we are practicing treated under the SBRT high-end techniques.
Yes.
Just I want to ask or suggest by physics point of view, we are practicing the pre-correction CBCT, post-correction CBCT, mid and the last end of the treatment. So can you analyze the end of the treatment CBCT or any other changes in the first CBCT and the last CBCT, or any other data is available on the site, or any collections?
There have been studies where what people have done is they have done composite dose calculation, like velocity has been utilized, where people have seen that how deformation is going to help, and how on the daily basis what has happened according to those CT, and average CT is generated, and the same plan is created on that, and they analyze how much dose the GTV has received. Or
it will be marginal changes as compared to the treated.
That's what I said. The PTV margin generation, it has to be tailor-made by each and every institute, because every institute has different technologies. So what is good for me may not be good for you. Okay, because like for CSI, we did a recent study. I think Mr. Kamal, one of our senior radiation therapists, presented on CSI. What we did was we did similar kind of study on CSI, and we found that the margins which we are providing is much greater than what we could achieve. So we are in plans to reduce the PTV margins. So such kind of things can happen. It cannot be a generalized statement that I can do this, I can do that. No, it cannot be like that. It has to be tailor-made. It's a team effort, and it has to be decided by your team. What technologies you have, what you have executed, what you have achieved, and according to that you can decide whether you want to do this, or like whatever changes you want to make into your plans. So it cannot be like if I say something, it would be based on my experience, my technology, and my team. So it completely depends on the team which you have, because in the starting of the talk I said the error starts with the therapist, it ends with the therapist.
Why? Because I'm asking, because nowadays that SBRT patient 40 or 45 minutes lie on the couch, and the most of the institutions started the practice with the DIBH.
Yes, I
so
understand.
for that last CBCT, I don't think so. Everyone is agree that patient is not able to take breathe hold.
Yes, I
so,
understand.
And forcefully, not in the forcefully as per the protocol, physicist standard doctor says that no, we want to take this CBCT, post-treatment CBCT that we want to analyze.
Either you have a gated treatment,
yeah,
or the number of arcs is going to increase because of the dose painting, so that averaging of the dose happens.
Non-coplanar beam also started with
Yes,
that. Yes,
it is bound to happen. Such complexity, like if you want a very tighter margins, so such kind of achieving such kind of plans, such kind of things are going to happen. It's bound to happen, and it is very necessary. Like we also do at our center, that if there is a very complicated plan, we call our therapist and we sit together and we explain them that this kind of thing is happening and this is going to come towards to you, like because this is what you are going to execute. So you need to be mentally prepared that this is going to happen. And for gating and everything, I don't know how each and every center in our country does, but we call the patient 1 week before the simulation and we coach the patient daily. Our team spends around 30 to 40 minutes on the couch in cities during simulation on daily basis. We are not taking CT, but we are coaching the patient. We are also giving them exercises that we have to go back and do this. So we give timer, we tell them you have to count 1, 2 and take that breath. So it's like that.
Thank you.
Yeah,
it's a big margin. Thanks.
Yeah. Yeah. Thank you.
Hospital that really if you are doing this practice, lung, liver and abdominal motion management cases, it is you must have also experienced after few sittings, patients are not so much energetic to hold the threshold values in the same pattern which you have planned. So the responsibility at that moment of therapist becomes more.
Yes, completely agree.
How he has to going to identify that where he has to do the shooting of the dose, that kind of knowledge, that kind of impression, he has to take care for doing that interesting. These are very interesting cases, and therapist in that case once will get that similar distribution of the threshold values every day, will feel very much confident after delivery of the treatment. So that responsibility our increases at that level, and that is similar, same way like हमने वो पढ़ा है ना कि अर्जुन ने तीर कैसे चलाया आंख में देख के. So we are sitting on the console and we are shooting that. So that in these cases, liver, lung and abdominal, where the always motion is going on, we have to be more and more confident in before delivery to the patient.
Yes.
So
I agree, sir. Thank you, sir. Thank you.
When you simulate, you do a 4D CT scan, just ask for a generation of ITB. And if your free breathing scan is going out of that, that means you have not done your 4D CT well. So the 4D CT means that any range of movement of the tumor should be covered. So if that is not covered, you have not done your 4D CT well. Either the patient coaching has not been that great, or the patient is not compliant, or the patient is anxious. So you have to look into it, that your free breathing scan or your mid ventilation scan should be within the ITB. And because if that is out, the day one that will fail. So what you are planning you are going to do will going to fail. So that the radiation technologist has to look at this. You many a times you do the scan, you do the binning and send it to the, just ask for a generation of ITB. That will give you a basic idea whether your 4D CT is adequate or not.
Thank you, sir, for such a wonderful presentation. A reminder that safety is not an option, it's our responsibility. I invite Dr. Upendra Giri, Chief Medical Physicist, Apex Super Speciality Hospital, to kindly come on stage for his presentation on radiation safety.
Thank you very much. So, myself, Dr. Upendra Giri, I'm working here since 2017. So, maybe it will be 9 years here. So, in this time, so we have only one machine at the beginning, and I commissioned Varanasi, and since last 3 years, Varanasi is working. So, last 2 lectures where you saw they were dedicated to theories, mainly theories. But what I will discuss here, I will show here all practical problems. What therapist faces and what should be challenging work in your clinic. So this is here. So radiation safety in modern radiotherapy, preventing errors in daily practice. So why this topic is important? Modern LINAC like Varanasi and true beams, they are extremely advanced and safe. But most radiation accidents worldwide have not happened because of machine failure. They happen because of small human errors in routine workflow. These small mistakes do not look dangerous until they accumulate and become serious events. The objective of this presentation is to make aware about the small errors which leads to disaster in radiotherapy department. So radiation safety for radiation for patient and staff are very much necessary for working in radiotherapy department. I'm basically discussing why RTT vigilance matters, how LINAC accidents really happens, how small mistakes become big accident. So radiation safety is not just wearing a yearly badge, it means making sure that right patient receives the right dose in the right position at the right site every day. So this topic will be dedicated to all the practical problem where radiation accident may occur. So this is the like that. So first thing, electron applicator setup. So when SSD is set first and applicator is mounted later, there is a high risk that the applicator will hit the patient. So this is my practical finding in our institute. So like this is the way that you are therapist, yeah, or we when use RFA we set applicator. How we will set applicator? We will set SSD first and they will try to put applicator. But there is a problem. There is very less distance between applicator in and our RFA, water phantom, or patient. How much difference is? 5 centimeter. If you try to put applicator in this tight situation, then there are chances that you will hit patient. So what is correct way? Correct way is lower couch, mount applicator, then raise the couch. This is the correct way. But attention, there is another problem here. If you try to do that in this way, what I told you, so if you look on only screen table value, then there are chances that you will hit the patient. You will keep on shifting table, and then table will hit patient. So you have to be very much cautious. And second practical problem, what you might face at your center. This is very much important for all the therapists, especially students who have started working. So electron cutouts. Improper placement of heavy add-on or lead strips over the electron applicator may slip or fall, causing potential patient injury. How we make cutouts? So basically, how we make cutouts are that we get seroband material and customized cutout for each and every patient. But most of the cases, what happened that suppose from applicator we can open 10 by 10 field size, 15 by 15 centimeter field size, dedicated field size. But what will be there if a consultant will say you that okay, open 10 cross 8 field size. So what we will do in those cases? We will try to block 2 centimeter from lead strip. So we will put lead strip over applicator. So putting lead strip, what will be there? There are chances that this lead strip may fall down over patient body and cause patient injury. So what you can do? So you have to fix this lead strip with applicator firmly so that it will not slip, even though you rotate your gantry or you shift your patient or you will do anything, this should not fall down. In subsequent fraction, lead strip shift or incorrect repositioning may fill the patient PTV. Or what second error can happen there? That this lead strip you will place at wrong position, 10 by 8 field size, or you will make it 8 by 10 field size. You will put blocking in different direction. So these are the two errors with applicator what junior therapist can do. So how to avoid these errors? Just prefer customized cutouts, not cutouts like lead strips or any add-on blocks over applicator. So second error, radiation safety, I will be discussing here the prescription MU error. Generally what happened in PAL, I have taken example of PAL 3D CRT. So suppose there is a 30-in-10 fraction. So think for a moment what can go wrong with this prescription entry. What if prescription entered as 30 gray in one fraction? So from TPS what we do? We just do a planning for 30 gray and we do a plan evaluation with consultant and physicist, and then we export these data to our machine for treatment delivery. So this prescription should be 30 gray in 10 fraction, but what was there? Their prescription was 30 gray in one fraction. So can we see in TPS dose during the dose evaluation, can we find this error? We cannot find this error because plan is for 30 gray and we will see for 30 gray isodose line. So total MU will, so what will happen? 30 gray in 10 fraction if will be there, then total MU will become 3000. If MU will be 300, from 300 it will become 3000. So will system allow 3000 MUs in a single beam or bilateral beam or trilateral beam? So no, 3000 MU in a single beam is not allowed in Electra setup. In a single beam, you can only treat 999 MUs. So your system will not allow. But what if the plan? So answer is no, but system answer is maximum MU per unit 999. So now think about the importance of, okay, so suppose there is four field box plan. So there will be 4 beam and each beam MU will be less than 999. So it will be allowed. So what a therapist should do here, if such type of incidents will happen in your department under your vigilance, what will you do? Because 30 grade 10 plan converted into 30 grade single fraction, and MU from 300 it became 3000. So what you should do? You should check very much carefully what is the consultant prescription and what is the plan prescription and how much is MU. Is MUs are coming just like usual MUs, like 300, 400 MUs or 3000, 4000 MU. This you should not miss. You should never miss, because you are the last pillar of radiation safety. So your near miss situation, so if you will be vigilant, near miss situation can be avoided. So another example I will give you, wrong cow shift. Suppose the therapist gets sub-millimeter 2 to 5 mm shift from TPS. What happens if shift applies in wrong direction? It will be very hard to detect. So generally we physicists, I never prefer to give sub-millimeter shift like 5 mm, 6 mm or less than 1 centimeter shift. I never give. Suppose I will give 3 mm shift. What will happen? Therapist apply 3 mm shift in a wrong direction. If he will go for CBCT, can this error be detected? Yes, he will find 3 mm shift. Whether he can apply that shift? No, because most of the center, in our center, how we have made, okay, 3 consecutive days you have to take CBCT. If errors are not more than 3 mm, then you have to average 3 days shift and then apply. So 3 days, if wrong shift, 2 to 5 mm shift, it will be 3 days patient will be treated wrongly. But if you will more than 5 mm shifts, so CBCT will show, then we will shift patient. So another issues, another problems, wrong headrest, wrong waist selection. So what happens if therapist put wrong entry in simulation sheet? The patient will be misaligned for the entire course. That is not a small error, that is a 25 fraction mistake. So this is our simulation sheet. Can you just see that bolus is there, and our headrest is number 3, and 20-degree wedge we have used. Suppose during simulation someone have used headrest number 2 and wedge they have used 15 degree. So what will happen now? And there is a wrong entry, 3 degree and 20 degree. So when the therapist will try to fit 3 degree and 20 degree, number 3 wedge and 20 degree wedge, then there will be a rotation. How much rotation? 2 to 5 degree rotation. He will get rotation, and nobody can find out why this rotation is coming. So where was the error? Error was during the simulation. That simulation was performed on different wedge and headrest, but written different wedge and headrest. And this error will never be found out by any therapist because there was no note. And in the end, what will happen? If error will continue for 3-4 days, daily a therapist will he will say that, okay sir, we are getting daily 3 to 4 days error, 3 to 4 degree rotation. So what I will do? I will go for re-RTP. There is no any other way to correct this. So you have to very vigilant what you are simulating and what you are writing on your simulation sheet. 3 degree, what type of headrest you have used, how much degree wedge angle for inclination you have used, and whether you have used bolus or not, and contrast. Just see, this is our simulation sheet. Just I'm showing you. Okay. So another problem, wrong mold selection, wrong mold selection. Another problem what therapist can face, that you have 2 patients, similar appearance and similar site and similar name, like Maya Devi, something like that. So you will ask one patient to come, and you will use different patient, different mold. There are chances. How to avoid such situation should be verified by 2 therapists. So this, if you will use different mold for different patient, what will happen? Yes, you can you find it during CBCT? Yes, you can find during CBCT. You will get some shift, and you cannot apply that shift. So during CBCT, if the margin, the error will be, shift will be less than 5 mm, you will think that, okay, we have done a wrong shift, a wrong simulation. So in that way you cannot find out. So what you can do, you have to verify your RT number. Our department practice unique ID like 26RT8041, where 26 stands for year, RT radiotherapy, 804 is sequential patient number. In that way you should verify each and every patient. And a second thing also can happen, that you use different site for different patient. Like you have 2 patient, pelvis mass you are using, and one patient is for pelvis, one patient is for head and neck. You are using head and neck mass for pelvis patient. That can also happen, but this will be also caught during CBCT. Okay, another problem, another safety error what can happen, this manual recording or incorrect dose. So in our mosaic system, if there is a communication error between LINAC and mosaic, so any fraction cannot be recorded. So suppose 20 fraction plants are there, so it will be recorded only 19 fraction, one fraction will miss. So if you will not take care carefully, then you will overdose that patient, maybe 21 fraction you will give. So SBRT lung loose nozzle clips, I will show you one example that during treatment what happened, that nozzle clips may loosen after using several times. So what will happen, if patient will take breath, it will breath, then this can result in target displacement leading to partial or
Excuse me,
complete
Dr. Rupen, we are running out of
okay
time.
okay last time. So and next is the remold, yeah, re-RTP problem. If you are using remold, then you should discard that mold, you should not again use that mold. So what are the common factors? So I will take home message. Every radiation accident in history started with some small error. I will complete, and thank you to our vigilant therapist team. So my this class was dedicated that what you should do and how you can avoid all small error which can further converted into radiation accidents. If you follow my steps, if you will be vigilant what is there on chart and how if you compare MU, if you do proper simulation, then you can avoid such type of error. Thank you very much.
Thank you, sir. As we conclude our session 1, I respectfully invite Dr. Ajit Singh, President ARTTI, to please come forward to facilitate our wonderful speakers of the session. Mr. Yogesh Ninave.
Just 1 minute
Okay,
for
sir.
the previous speaker. I
Okay,
would
sir.
like to say one thing. You have done very well topic that error. We were talking about the error. Now I will ask Dr. Rajiv, chief therapist, that suppose if we are interested in really more being confident in our area, then if possible, weekly therapist discussion if you can organize in your department. जिस दिन खाली हो, Saturday का दिन अगर खाली हो, तो उस दिन you can keep therapist discussion among yourself. That is the most important point. And हमेशा कोशिश ये रहे कि सारे चार्ट जो है आप ड्यूटी लगाएं थेरेपिस्ट की कि everyone should see all chart reviewed by them, कि भाई जो लिखा है एड्रेस, सेटअप इंस्ट्रक्शन, डोज, वो सारी चीज़ें ठीक ठाक हैं या नहीं है, अगर पेशेंट की रिएक्शन आ रही है वो कैसी है, दैट कैन बी डिस्कस्ड इन योर वीकली काइंड ऑफ थेरेपिस्ट डिस्कशन. That will also add more minimizing the setup errors and more confident in delivery of treatment.
I invite our speakers of the session, Mr. Yogesh Ninave. Mr. Naveen Dubey. Dr. Biplab Sarkar. Mr. Dandapani Ipli. And Dr. Upendra Giri. I now request our Honorable Chairpersons, Dr. Ajay Chaubey, to please come forward for felicitation. Dr. Subodhi Zafar. And Mr. Ashwani Jaiswal. Thank you, sir, for your gracious presence and honoring our speakers and chairpersons.
I would like to thank the organizers for giving us this opportunity to chair the session. Thank you all.
Now, after strengthening our foundations in session 1, it's now time to turn our focus to the future of radiotherapy. Welcome to the session 2, where technology meets innovation, planning meets perfection, and precision meets intelligence. This session takes us from planning to delivery, from conventional to cutting edges, and from today's practices to tomorrow's possibilities. To guide us through this high-impact, future-focused journey, we have an esteemed panel of chairpersons, Mr. Rakesh Kaul, Chief Radiation Therapist, Max Healthcare, Sake; Dr. Udal Yadav, HOD, Radiation Oncology, Chandan Hospital, Lucknow; and Dr. D.P. Pandey, Associate Professor, Medical Physicist, Sham Shah Medical College, Rewa. A big round of applause for our respected chairpersons. So everyone, keep your curiosity switched on, because I invite Mr. Subrato Roy, Senior Radiation Therapist, Max Nanavati Hospital, Mumbai, to kindly come on stage and guide us through his topic, From Planning to Delivery, Precision Workflow.
A very good morning to all. Myself, Subrata Roy, Senior Radiation Therapist from Mumbai. So today I am going to go through it, take you from the journey to planning to delivery, precision workflows that reduce errors, toxicity, treatment, and times. So before just starting, I'm very thankful to the organizing team to giving me this opportunity over here. So this journey will become very exciting, and also will be very meaningful and effective for the radiation therapist. So precision foundations in modern radiotherapy, I will be discussing patient simulations, contouring, image guidance, treatment delivery, safety, workflow efficiency, clinical impact, and also the future directions. So before ending of this presentations, you will be completion of the explain how the standard simulation, IGRT adaptive workflows improve the treatment delivery, apply the practical RTT level techniques, and utilize the structured verifications, integrate evidence-based workflow-driven approaches you are going to relate. So what we will understand that practical techniques that RTTs can apply to reduce the geometric uncertainties, prevent the treatment times without compromising the safety. So most importantly, that we are going to include that precision foundation is very important in this modern radiotherapy. So what we can check over here, that the evidence-based treatment planning grounded in anatomy imaging, quality, and risk-benefit balance. Of course, that advanced immobilization is an integral part, and the patient setup ensuring the reproducibility, reducing the geometric uncertainties. The third pillar we can consider it as that imaging system. We have that image verifications, which is called as a CBCT, MBCT or SGRT, which is a real-time precision, can have added benefits to achieve this precision foundation in modern radiotherapy. Of course, the new things are come up with the adaptive radiotherapy, readiness, response, anatomical tumors and motion changes is also included. So as a RTTs, our role is not limited to the executions. We are the guardians of reproducibility, consistency and the safety across the entire workflow. So why this precision has impact, or why it is matters? So we can see that it improves the safety of complex cases like SBRT, SRS and re-irradiations. Also it is minimizes the dose to the OARs, lowers acute the toxicities, and also it decreases the treatment time and the patient comfort and department efficiency. So it has a variety of role. Precisions has no longer optional with complex treatments such as SRS, SBRT and SRS. So better precision allows the tighter margins and reduce the dose to the organ at risk, and the treatment times, and improve the patient comfort while also improving the departmental efficiency. So then my second step is for patient simulation and imaging workflow excellence. So how we can get these things done in the starting of our step, what is called as a simulation. My previous speakers has also enlightened so many steps like how you can reduce the errors. So the standard simulation protocols to ensure the reproducible high quality setup for all the treatment sites, as well as that precision immobilization, which is the core part, and the positioning reduce motion variability through optimized devices and comfort planning. And high fidelity imaging acquisition exemplates the seamless workflow from image import, contouring, plan initiation to avoid the delays and the errors. And RTT-led workflow optimization also enhancing the efficiency through protocol adherence and communication and other troubleshootings. So RTT plays a central key role over here by following the protocols and also identifying the issues early and ensuring the seamless workflow from simulation to planning. We prevent downstream delays and also the errors. Second part is the contouring and the planning accuracy. So what it does, it's accurate planning also starts with the accurate contours. Standardized GTV, CTV and PTV identifications reduce inter-observer variability, while multimodality imaging and other targets fusions improves and target clarity. Automation and AI tools should support RTTs and the clinicians. So clear target delineations with standard CTV, GTV definitions to reduce the inter-observer variability. High quality multimodality imaging fusions also can enhance the tumor organ contrast, improve the boundary and the clarity. Plan quality optimizers with robust dose objectives, OS pairing and adaptive make a difference. So what we can take keynote from this. So these all steps are included in the workflow. So how we can re-optimize the workflows and get the things done in a very minimal time with an efficient way. So outcome driven planning to ensure the accurate contours lead safer dose delivery, reduce the toxicity and improve the tumor control. Second is, this slide is very important for radiation therapists. Like this is the boundary where we are verifying the guidance and the verification of the precision. So as my previous speakers already have discussed that IGRT is the RTT's strongest safety tools. Daily high quality imaging confirms anatomy, isocenter accuracy and target to OR and the relationships. The first thing is the high quality onboard imaging, daily CBCT and KBCT, which is helping us to confirm the anatomy, isocenter and the target relationships. So there are verifications process are still going on. So manual and automated matchings will definitely help us to take the decisions on the critical targets and the imagings. And also the clear criteria when the image resetup or consult to the radiation physicist or the radiation oncologist when there is a critical structures or the targets are involved. Also the precision outcomes by ensuring the safe margin reduction, improving the localization and preventing the geometric miss. For the treatment delivery, during the delivery, precision must be maintained in a real time. So there are pre-treatment verification, final checks, patient IDs, and the setup plan to be checked, CBCT surface guidance also to be taken into an account, adaptive corrections during treatment delivery, immediate getting, and hold couch adjustments, motion exceeds the tolerance. So RTTs are situational awareness and continuous observation is mandatory. Rapid decision making skills also to be incorporated in this way. So now I'm going to discuss about the workflow efficiency and reduced treatment times. The efficiency doesn't mean that rushing to that means removing unnecessary delays. Standardized pathways, automation, and also it has helps to build up our confidence in a real time. So standardized clinical pathways, taking points, streamlined protocols also will help us to minimize the delays. And the automation and the smart tools are available, fast coordinated handovers between the imaging and contouring, lean scheduling and resource utilization, auto contouring, AI assisted plans and automated QA significantly cut the manual workloads. RTT led operational coordination, faster workflows will definitely give impact on this way. So the clinical impact is also enhance the patient outcomes, and that's technology, human factors such as communication, situational awareness, and decision making remain central to the safe radiotherapy. So the technology is also supporting us, replacing the expertise, AI automations and real-time tools, augmented clinical judgment, high prevalence and human oversight. So the future-ready practice models, adaptive radiotherapy, motion planning and data-driven workflows will define the next generation radiotherapy. So whatever the discussion we have done as of now, so what we can conclude that errorless workflow is eventually not practically possible. So there are always things RTTs can learn from the errors. So always they are verify the basics, never skip the IGRT review, communicate early and clearly, standardize before you personalize, and also document every deviation. So recording the small issues builds the patterns that improve safety culture and future workflows. So clear communication is very also important, and strict adherence to the protocol is also important. So there are errors which may occur in any department. So there is a clear error reporting system defined by the ILORA. So these all radiation facilities in the country are required to intimate the occurrence of any unusual incident in the source within 24 hours to the ARB. So to enable this information, usually incident providing follow-up actions to be taken by the ARB, incident reporting system. So these are the things like I can include, like who can and when and how the reporting should be done. So the licensee employer of the facility can report these incidents, and it should be in 24 hours to the detection of unusual incident involving the radiation source. And it is possible by the ILORA login system to navigate the systems, and incident form filling and reporting can be done. Now I am going to include little journal evidences related to the precision workflows that reduce error and toxicities. So there is a journal called, this publication is also clearly defined that the recent studies that structured adaptive workflows in significant reduce manual corrections and maintain the acceptable treatment times. This supports the feasibility of RTT lead adaptive radiotherapy when proper training protocol and QA systems are in place. There is another publication they have done that it's a longitudinal evaluation of workflow optimization of radiotherapy, a 4-year retrospective study. So this study is also defined that the workflow design using the AI assisted contouring and standard planning automated QA has reduced the planning to treatment time nearly 30%. So this demonstrates that the safety and efficiency can also improve together when workflows are well designed. Another study, automation and artificial intelligence in radiation therapy treatment planning. It also shows that global data that AI-based contoured and can reduce the active contouring time by over 50% and even more complex sites. For RTTs, this means that shift role from manual tasks to the supervision, quality assurance and decision support. In cumulative way, that global data is also shown that AI-driven segmentation efficiency can gain workflow challenges in radiotherapy. A large world data is also shown the same. So this is a picture worth with the 1,000 words. So the compassionate and care is also should be in with the radiation therapist as a primary thing. That the precision to delivery, this data shows that the implementation of AI-based contouring and structured workflow intervention has a real measurable impact on reducing time, planning to treatment, goal to the treatment, and the other words. So I have gathered a few do and don'ts for the RTTs with research articles and other publications. So there are so many things, but I am generalizing few points where they can correlate themselves. To perform consistent protocol driven in IGRT verification, do apply for the PTB margin reductions when high quality image guidance supports you, do conduct comprehensive RTT level end-to-end QA checks for SRS, SBRT and dry runs, and do utilize the validated automation AI commit shortcut comprehensive RTT QA checks or some dry runs. When there is complex SBRT, we are just simply skip the dry runs, and when the execution time it leads to a different problems and problem. So don't depend on the solely of unveiled automated or AI generation blindly. Don't allow workflow inefficiencies such as poor image export, import, or very poor delineation of the images. We should not rely on those. So this I have gathered from this few publications over they have published. So finally, I am concluding these international studies provide a strong benchmarks for Indian and global practice RTT-led workflows, supported with a very high workflow accelerate when workflows are included. So online adaptives and other things also going to improve. Advanced imaging and IGRT, ART enable tighter margins, reduce toxicity and shorter treatment courses, improving the both patient outcomes and departmental efficiency. So as the workflow accelerate, robust QA and safety checks are essential to prevent the errors. These international studies are valuable benchmark, strengthening the RTT focused workflow, improved and support the Indian radiotherapy practice. Thank you everyone for bearing for these long sessions over here.
Thank you very much, Mr. Subrat Roy. And the topic was that journey of a radiation therapist from the simulation to the treatment delivery. We should be delivered efficiently and safely. This was the crux of your topic. And in addition to that, what I want to convey that a technologist should have a knowledge, and it should have also skills and the efficiency. All the three, because knowledge to every procedure, explanation to every procedure is very must. But without the skills, you can't have only the knowledge.
Yes, exactly.
So skills has to be maintained, and skills can be maintained to have a proper protocols, department-driven protocols that they have made, and checklists that then only you can achieve your goals. That your goal is the clinical goal, that is the clinical outcome of the treatment. That should be the main central core of the topic. And by following all the imaging, because ultimately the imaging guide us when to deliver, when not to deliver, should be there.
Yes.
We should inculcate in our day-to-day work, and also the cure.
Additionally, I want to tell one message. Like recently, there are so many AI-driven protocols and AI-driven things are coming up with that advancements. But for the radiation therapist, I can purely say that they should not blindly just believe that AI deformation or other things. That mastering that other things, they are just helping us this tool. But finally, we have to decide like whether we need any other modifications of that image verification or not. Because we have the decider and we have to do it in practical way. Thank you very much for it.
One more question. Hello. Have you reported any incidents till in ERB Ellora site?
In my practical, this clinical year, I have not figured any of the incident. Maybe it's a fortunate or way, but I have seen my colleagues, they have reported a small incident from some other centers. So basically I came to know that this is the severity of this, like we should learn from the errors.
No,
and
asking your center.
No, my center, no.
You are always correct, right?
No, not in that way, but the incident can happen in anywhere, in any moment, but we should know like what is the exact protocol for that.
Okay, no.
Now, when anatomy refuses to stay still, MR radiotherapy politely asks it to cooperate, and that too in real time. Our next talk takes us to a space where radiotherapy becomes more smarter, faster, and far more adaptive. To guide us through this exciting and rapidly evolving technology, we have Mr. Ravindran Gopal, Chief Radiation Therapist at Fortis Gurgaon, who brings with him a rich blend of international clinical experience and technical expertise. Sir, please take the stage and enlighten us with your presentation on MRGRT, New Era of Radiotherapy.
Good morning, everyone. Thank you very much. Okay, so today I'm gonna discuss with you all what we are doing in MR Linux. So, what is MRI guided radiotherapy? Why we are calling it a new era of radiotherapy? Because we all have shared responsibilities and certain policies and protocols we all follow in the same manner what you and me are doing. And so what is MR Linux? MR Linux is a technically hybrid machine which is having MRI as well as Linux combined together and having a different workflow. So before starting Unity MR Linux, people were started using a true beam machine along with MRI. MRI was moved inside the Linux room with robotic couches. Patient is lying stable, and then they've taken MR, and that was taking around 2 to 3 hours for the whole procedure. And then they moved on to Meridian. Meridian was having a 3.5 Tesla, 0.35 Tesla MRI, and then Unity, because these two they've stopped working now. So some workflows, I have some small clips of videos you can just go through. So this is how the MRI was bringing into the Linux room, and then they've taken acquired images, and then images are pushed back to Monaco or ARIA and Eclipse planning system, and then the patient is moved back to the treatment head. Once the plan is ready, then the treatment is delivered. And then VBray came with MR. They've included split magnet system accordingly. Then the gantry assembly, and then patient positioning couch with the 2 in-room couch controls, and then 3.35 field Tesla MRI. And then they had schematic Linux components and cylindrical ferromagnetic shields. From there, Electa, Philips and Electa, they moved on, and then they made a Unity, so which is a 1.5 Tesla MRI, and then they fixed Electa head into the ring gantry, which works with the ring gantry process. Then you can see the beam is fixed there, and then you can see MRI is there, and then on top of that we have linear accelerator. Linear accelerator is having 3 different parts. One is imaging part, which is only for QA process, and one is beam generation, and one is chiller image. So this is our machine. So some specifications: this 1.5 Tesla with the high energy Linux is mounted on the ring gantry, and then we have cryostat, and then we have 7 triple FMV. Bore diameter is around 70 centimeter. Then we have radiation field SSD 57.4 into 22, and we 143.75 is a SAD, and it starts when we start firing from the top. It starts with 600 MU per minute, but when we are getting dose output on 143.5, it is just 400 MU per minute. And then MLC direction, it moves craniocaudally, and the table movements are fixed. Vertical level, one certain type it go, certain height it goes and then stops, and then only craniocaudally patient moves. So why we need all this technology? Because our clinicians always wanted to have very good treatment, dose escalation. There should be proper dose escalation, reduce overall treatment time, margin reduction, guarantee daily PTV coverage, control daily OR, deliver dose, and reduce toxicity. This is what everybody is looking nowadays, and this was from the beginning, but now we are more into this. So from morning, everybody talked about the motion management and everything. We are really seeing live, and we are treating also on this. So some of the advantages of MRI guided radiotherapy. So you can see this in CT, diagnostic CT we are missing, and in MRI we can able to see the soft tissue very clearly. So that's the major advantage, and you can see, you can able to visualize the tumor or any soft tissue in very clear manner, and there is no absence of associated ionizing radiation. So when I'm treating the patient, I'm continuously acquiring image. I'm not giving any extra radiation to the patient, and we can do intrafraction movements and continuously monitor the motion, and hence it allows early evaluation of tumor response and adapt or change the radiation plan while the patient is on the table, and do that in real time. So this is the beauty of MR-Linac, and improve tumor control and decrease toxicity. So what our clinicians wanted. And MR onboard imaging, it allows target and critical structure localization and tracking based on gold standard anatomy rather than the fiducial marker, because previously we were doing like even we are putting gold fiducials near to the tumor, and we are tracking with the exact track, or still we are following RPM based gatings also for DEBH, DIBH we are doing for lung and liver also. So MR-Linac has the ability to track targets in 3 planes. All 3 planes you can see clearly, and then if the target moves outside the pre-specified envelope, the treatment beam will be automatically gated. So now we started working with the CMM, like I think one of the physicists were talking about CMM in the morning. And functional imaging allows dose painting and high risk tumor volume, greater tumor control. So these all the future. So as you can see, all the organs are moving while treatment. So we have taken images in cone beam CT, and then we started treating. We don't know what's happening inside because we are not tracking anything. So with MR-Linac, with adaptive, we are tracking live. So as a RTT, we have some certain add-on responsibilities, because we have to follow MRI safety as well, because it is warning for everybody. Until unless we know the safety and warning, and we cannot handle this MR-Linac. So we made MR screening and assessment before taking the patient. We just go through all oncologists, physics, and RTTs. We have at the end, we are the one who are allowing the patient to go inside. If the patient is not ready for MR or the claustrophobic or anything, we have to counsel them. If we are not doing, then the patient may not be lying down and there for almost 30 to 45 minutes. So we have MR safety in our center, like wall mounted detectors are there. It shows us 3 colors. If it is green, then we can enter inside. If it is yellow, then we have to check ourselves. If it is red, do not enter. So go out and then check fully. If everything is clear, then enter the room. So what it has done, it has changed the entire workflow in radiation oncology from today's pattern. So patient positioning we are doing, but here we are doing with a little bit different, because we are not using any kind of orbit cast or anything, and lower part of the body. Only for brain, GBM, and some head and neck we are using orbit cast. And then image obtention is different here, and then recontouring part is different here. Replan, because these all things happens live. So when we acquire a 3D MR and initiate gating and tracking, what we call it a CMM now. So in our center, we follow the workflow. We, after doing planning CT, we take the patient with the same setup. This is a MR different layover, and then we take any same T1 or T2, or for brain we take a flare, and fusion of multimodality imagings and contour, and then the planning happens. And RTTs, we do plan import and we do verify, and we also check the prescription and approve the prescription along with the oncologist. And secondary dose calculation and dosimetry we have to do, and patient specific QA our physics desk, and then we verify. So this is just one part of a workflow. So very important part is pre-treatment chart verification. Whoever using Monaco, you all are aware that we do verify a treatment chart, but here without this step you cannot follow anything. And then daily MR assessment. This is add-on workflow again. So unless you complete this assessment, you cannot proceed further. And then select treat readiness check. Once you see the patient, you ask the patient is free with any kind of ferromagnetic, and your password only, the patient treatment pop-up will be there, and then perform patient verification again, and then go with the patient positioning. Then while walking, you check all the with the detectors, and then you position the frame and coil, and patient, we need to instruct the patient because there is a one-way communication. Either they can press the call button, or otherwise they can shout, but sometimes we may not be hearing that. And perform safety checks, confirm patient setup, and then you are coming out. So you have to follow these many steps inside the room. So this is how we place the patient, because we don't have anything, only sagittal laser we have. And then these are the MR coil. This is the green zone where we can irradiate the patient, and then this you can lift and drop down, and then accordingly we have to fix in cable tire, otherwise it will harm. So MRI, it gives a lot of noise, so to reduce the noise we give a patient headphone and then earplugs also. And then there is a call bell system where the call bell is given, and then we ask the patient to keep it a hold, and if in case of any issue, just press the bell. And we should avoid looping because of eddy current. And then if we find anything, any body part is touching, so we need to have some sandbags or foam pads. So, and then after setup, we acquire MRI image, whatever the sequence, and then we import the images, and deformable registration we do with the previous set of MR, or the day one we do check with CT, and then we verify with CT images, and then proceed with there are two types of plan. One is adapt to position, the other one is adapt to shape. So adapt to shape is whatever we've done in CT, and we've taken an MR and we go through, and if we find all the anatomical movement or structures are changed, then we have to recontour everything, and then again we analyze with again acquire one more MRI image, analyze, and then re-verify, recalculate, and then treat. So this whole procedure takes around 45 minutes from in and out. So this is one of our prostate patient. This is the CT of the day one, and this is the treatment MR. So we found almost everything was good, but we can see things very clearly here. Here we are missing. So when we saw here the node point where we need to give SIB, so we clearly noticed that area. On second day, we found it was shrunken. On the end of the treatment, we found almost it's nothing. So when we are giving 5 fraction with 37.4 K, and MR Linux is best. So this is again a pancreas patient we treated, and on CT we marked our contouring was done like this, and then when we saw on the treatment time, everything was here and there. So we had to move everything. The bowel was coming inside, and then you can see the GTV1 was a little bit moved, and then GTV2 was also a little bit moved here. So we have the second workflow. It is we call it ATP, adapt to position, because only brain we've seen few patients we couldn't able to do ATS because day 1 to day 5 everything was matching perfectly, but some GBM we've seen up to 4 to 5, even 11 fractions we've noticed gradually the tumor was increasing, and then after 12 fraction it stopped increasing, and there was no decrease also. And when we saw on 27th fraction, the tumor was totally regressed, almost 3 centimeter difference we saw on there. So this is day 1 of treatment, and then this is day 10 of treatment. You can see there is no change in this patient. So these patients take around 12 to 15 minutes max in a single fracture. So CMM, what we are doing it now for pancreas. So once the patient is set and everything is ready, and then 3D imagings are acquired, and because pancreas, everybody tries not to treat pancreas because of this motion, because it moves in any direction. So all the images are acquired, and then some 2D cine images are acquired in digital plane, and then continuously tracked and monitored by AI again, which from morning people are talking about true tracking. So this is a true tracking, and if it goes and there is any drift happens, and then it will show here as. So we have given a getting envelope. Now we started giving with the 2 millimeter for pancreas. So if you see, if I've kept around V95 is 95, if it goes more than less than 95, it will not treat, and then if it is there and up to 99, it will treat. Otherwise, the beam will be auto hold. So this is our real patient. With our patient, we've taken this. Sorry, I couldn't play this one. So here the drift was happening almost. It was going up to 3 mm. So it was holding the beam, and then we couldn't able to perform the beam hold. So this takes around 1 hour for full treatment. So what is the summary? MR guided radiotherapy is a new era of technology. It offers, and it allows us to do all this improved tumor visualization, daily imaging, and intrafraction real-time imaging. There is no added radiation exposure from any kind of imaging, because we are not doing any KV X-rays, and there is unprecedented accuracy. Adjust plan and dose according to changes in tumor anatomy on treatment table. This is everybody is doing, but with the KV X-rays we are doing, and with this we can avoid extra radiation here, and there is a better outcome and lesser toxicity, what we wanted. And my main request to all therapists, to please pay attention and recognize yourself, who you are, and get trained yourself, because with very minimal knowledge we can't do anything. We have to improve our skills, and we need to do more learning part. We have to concentrate here, and then we go for implementation, because in India what we follow, we implement first and then we think why we have done. So we have to change this mindset and plan. Thank you. Thank you for the opportunity, Apex.
A nice presentation, Ravindra. I know very well in India is a very limited center that have EMR guided linear, and I know very well in tissue delineation, regarding point of tissue delineation in number of specific site. As a radiation oncologist, we can better visualize the soft tissue delineation like GTV, CTV, so we can achieve the better dose distribution, homogeneous dose distribution, and escalate the dose to the tumor site, and simultaneously we reduce the dose the normal healthy surrounding tissue. But just I want to know, what are the specific challenges, or what are the specific events that you have faced during the RT planning or during the delivery of radiation therapy, because this is the totally a new evolving system. I have no any experience.
No. Actually, there is a lot of challenges actually.
So specific challenge that you have faced.
See, we follow same protocol what we are doing for CT Linux also. We acquire 4D scan and we check the movement there, but we also take a 4D cine MRI image, BTFE, to make sure both are giving us same answer for us. CT Linac 4D CT, it gives around 7 to 8 mm unidirectional movement, but in BTFE we see only craniocaudal, it is going up to 7 mm. The rest of the things are just under 5 mm. So we don't take any marginal action there, because anyway we're going to do live. So when we have applied the V95, it takes care of everything. So, but it takes time in overall beam on time because we have less dose rate because it is just 400 ml per minute. So here the glitches comes because it goes for SBRT it is 3000 monitor units. So it takes around 18 minutes to beam delivery, only beam delivery. So rest of the things are very fast. Planning takes only 4 minutes, contouring takes, and we've set a clock for that. Planning we give only 8 minutes or 10 minutes, and calculation time 3 to 4 minutes. Patient has to lie down. So that is a major part. It is a torture for patient. Sorry.
Thank you.
One more question because there's a like pancreas or liver and lung, they're continuously moving, or prostate is continuously moving. How often you are doing the adaptive radiotherapy in a single patient?
Sir, MR-Linac daily adaptive.
How often if you are doing, suppose you have done adaptive, that maybe after few minutes it has again moved. So
sir, it is continuous.
Continuous
monitoring.
Continuous monitoring and
continuous monitoring.
Adaptive.
If we set V95 as a 95, it means if it is going more than 95, the drift comes 5 mm, more than 5 mm, because we have given 3 mm. If it shows 5 mm, 3 mm plus 5 mm, it is 8 mm. So we have to push back the planning section, and then we move the images to planning. It takes hardly 30 to 40 seconds to recalculate, and then it again pushes the beam, and then we apply the drift correction there. Almost we've applied now 5 mm extra. So the beam again it will start. Again before beam on you can monitor whether we applied the correction, it is okay, or we need to again monitor. So continuous MR.
Continuous tracking.
Yeah, continuous tracking.
Sir, as you already mentioned that that MR-Linac is already deal with the real-time adaptive. So if you have a patient of CA prostate and given some certain bladder protocol, and as we are also monitoring the things in a real time, but if the patient is given some certain moderate bladder protocol,
yeah,
and we are taking the treatment time of nearly 35 to 45 minutes. So if in between the patient having any urge to like go washroom, or he could not able to hold the bladder for the certain time, like how we can resume the treatment after that?
Valid question actually. For prostate we are doing almost in this 1 month we have done around 18 prostate patients. Only one patient had this problem, but we have to stop the beam, and then we have to ask the patient to go void urine, and while entering into the room we've given 100 ml of water, because our MR sequence itself it takes around 4 to 5 minutes for MR sequence. So we give only 200 ml 20 minutes protocol, because we know at the end after 45 minutes the patient will be coming out. So we prepare patient accordingly.
Thank you so much.
Yeah.
A small question. The recent data, whatever it is coming in the literature, this shows there is a minimal changes in the toxicity profile, long-term toxicity profile, or mid-term toxicity profile actually. But with this heavy adaptation, do we expect a further increase in the toxicity? The survival data it will take several years to come. That is not a immediate process, and this is recent only. That is not more than 4-5 years it is going on. Maybe
our study is one and a half year study, and till yesterday we have treated 72 prostate patients and 18 pancreas and 14 liver patients. So in this only one liver we had a problem with severe reactions because of electron return effect, and 2 prostate patients we had a problem. Otherwise rest everybody is doing good.
So is it at par with your CM-Linac or any other linear accelerator? I mean, is it lesser than the standard practice, standard SBRT practice?
No, we are giving high dose per
36.5, right, in 5
with 36.5 in 5, and now we started giving 40 in 6 also. One patient we treated 40 in 6,
that is
because some trials are going in NHS, so we implemented that.
36.5 in 5 is the standard.
Yeah, standard. So we didn't face any problem with this SBRT patients.
Right. My question is the toxicity is lesser than the standard?
Yes, toxicity is lesser because after I think 3 months patients had they didn't give any complaint, and after completion of treatment also they were not having any radiation induced toxicities. Yeah,
Thank
we'll
you.
check. Yeah. And yeah, please.
Advanced modality. Being an RTT and the technologist perspective, you told about the learning and the implementations. So what are we are going to practice in India, that is the implementation first and then to learn. So what, being an RTT perspective, what add-on skills should I need to learn first to work on MR-Linac?
See, current trend is allowing us to learn more, and if you Google it, you get all the details. At least you try to read first, and then we can have a proper training sections. Like all the hospitals are providing trainings nowadays. So you just go have your training, have observation, and try to study, and then train yourself, get yourself skilled, carry on with your profession. Rest everybody is doing, only RTTs are not doing. So it is my request to everybody.
In the present scenario, you are forced to learn first. You can't do implement. Because
Thank you. Thank
with
you for the
high-end
opportunity.
technology, you can't directly implement. So you have to learn, gain your skills, and then implement.
What skills?
Yes, yes.
देवियों सज्जनों, फॉर लाइटर नोट्स मैं आपके सामने एक शेर अर्ज करना चाहूँगा। आज विज्ञान भी नतमस्तक है इस धरती के नाम, जहाँ उपचार में करुणा है और करुणा में विज्ञान। इन्हीं शब्दों के साथ अब मैं डॉक्टर गौरव गोस्वामी को मंच पर आमंत्रित करता हूँ उनके अगले व्याख्यान के लिए। तालियों के साथ स्वागत करिए डॉक्टर गौरव गोस्वामी जी का।
This dais is my nemesis. Actually, each time I come, it seems to put me on a higher pedestal than I'm actually. So I'll put my desk down to earth. And I've been listening carefully here for the last one and a half hour almost. I was a bit late. I was busy with my rounds. So a lot has been said. A lot has been said. I'll skip this slide. This is useless. A lot has been said on what we should do. What is being done, what should be done. The question is, why is it being done? That needs to be addressed. Look, I can tell a boy that 2 + 2 is 4 and you just memorize it and you don't need to put your brains into it, and the moment you see 2 + 2 you just shout 4. But the thing is that you must understand why 2 and 2 is 4. So this session, ladies and gentlemen, I request you to just focus for 15 minutes. There's nothing going to be of note here on the slides. Purposefully, I kept the slides to a minimum so that I gain all of your attention. So radiation has come a long way. We have gone from 3D to IMRT to IGRT. We have gone to IMPT. We have gone to heavy ions. We have even got flash and everything. So I would draw your attention. The name for this session was the clinical perspective of advanced radiation therapy. So modern radiotherapy started all the way when it started with 3D CRT. 3D CRT was the beginning of a modern era. Before that, it was all box, it was all surface marking, and we moved from ortho voltage to mega voltage, and things did not seem to look up till such time we had volumetric 3D imaging. Now what did that provide? That provided us with actual verification of tumors, visualization of those tumors on the treatment room and corrections thereof. Also, having 3D volumetric imaging provided us with algorithms by which we plan precisely for delivery of the tumors and protection of the actual organs at risk. So we have gone from volumetric, we have gone from 3D to volumetric, and volumetric VMAT, that is, and the changes and the advances have not only been in terms of the software, it has been also in terms of the hardware. We have gone from physical blocks where they were custom made. Even today we use gamma knife. Gamma knife uses fixed kind of aperture things, and from them we have gone to MLCs, micro MLCs. So I think the progress has been both software and hardware led, and as my last speaker has very aptly put, it has to be knowledge led also. So you cannot just have software in place, you can't have the hardware in place, and you have the knowledge lagging. Everything has to keep pace. What are the outcomes with whatever we have done, 3D, IMRT, VMAT, whether that is proton or not? There's improvement in the therapeutic ratio, there is increase in the use of curative and organ preserving RT. We all know that initially that laryngeal cancers, they played pivotal role. Same goes with bladders, same goes with the lung. Even with lung we are doing curative intent RT. So what I wanted to say is that since we have progressed a lot. So the intention and the aim of the treatment should always be for the patient's benefit, and for that the RTTs plays a very curative, very comprehensive and very pivotal role. So since I have got hardly 15 minutes, I will draw your attention to only 3 points. Why do we give PTVs, CTVs, ITVs and GTVs, and why do we give that? Secondly, why do we have adaptive RT? And thirdly, why do we have an image based verification system? So we'll start from one. As I said, these slides are useless. If you listen to me, 15 minutes is all you need. Ladies and gentlemen, I need your 15 minutes. You learn a lot. You'll learn a lot today. You'll learn why we do MR. As Biplab sir said, that what is the improvement with the toxicity, with the immediate midterm. Data is still, it is still raw, it is still immature. So we must understand that what are we seeking? We must understand what are we looking for. I can do a daily IGRT and maybe it may not make a difference. Why did Dr. Upendra, what did he say that the first 3 days we take CBCT and see whether it's 3 millimeters or more? Why do we need to do that? Centers which have a robust IGRT, they do first 3 days, get the shifts, apply those, then next week they verify are we within the safe limits. So once you have a robust IGRT, then only you can precisely deliver your therapies, whether it is 36.5, whether it is 1620, or whether it is 79 in 39, 38. So it doesn't matter. The purpose of giving a CTV is threefold. One, we need to address the microscopic extent of the disease. We need to know what is the GTV, where is the actual disease. We need to know what is the interfractional movement of the disease, and there is something which is known as systematic error. What is a systematic error? You all must have heard this, because you have, as I see this gathering here, I know that there is something that you have attended and everything, and you know there's something, there's a systematic error, there's something known as random error. So the purpose of this CTV is to include the microscopic extent of the disease. The purpose of the ITV is to include the organ movement during treatment, and purpose of PTV is to for the systematic of the setup errors. Secondly, as I said, adaptive RT. We have spoken regarding adaptive RT in real time. We have talked about MR. We have also talked about, as you saw in the morning sessions, they talked about why do we have these shifts. So adaptive RT is something which has become something so fantastic, but let me tell you, ladies and gentlemen, you have been doing this thing for the last couple of years. Our technologists are, not our technologists, I feel that every good advanced center has been following this practice. the clinicians, the technologists, the physicists have been working day and now to do this adaptive. What is this adaptive thing all about? Today you hear adaptive, today you hear AI. But ladies and gentlemen, you have been doing this AI. That time you did not label as an AI. I had like around a month back, we had a session on targeted therapy in, there was a nursing conference, and as I invited a speaker and told them it's Purani Sharab in Nayi Botal. Why? Because the moment you see on your CBCT, the nasopharyngeal mass has reduced, the lung has expanded. Then you see that the mass in the retroperitoneal space has shrunk. The RTT has noticed, he informs the clinicians, the clinician verifies, and the plan is put on hold till such time we obtain fresh images, fresh plan, and delivery starts again. So adaptive is not something which is done. And AI is a tool which has been around for at least 10 years. It did not come yesterday. At least 10 years. Only the language has changed. Initially used to call it LLMs, machine learning. Ab aa gayi hai. What you call is AI. Auto segmentation has been there for at least a decade, if not less. It was all there. Do not be scared. ऐसे जैसे उन्होंने कहा है, सर ने कहा है, he said that either you learn or you perish. आज के दिन वही, I told the nurses the same thing. Do not be afraid of immunotherapy. You have been doing immunotherapy for the last several decades at least. I showed them examples, direct examples. They have been using it in their medicine wards. So never be afraid of something which is new. Why do we need to do adaptive? Because the moment the tumor changes, the dosimetry changes. You got a soft tissue has reduced, the ORs have moved. Yes, the spine will not move, but the degree of freedom the spine has to move now has changed. So adaptive is because radiosensitive tumors, especially nasopharynx, paranasal, pediatric RMS, these have a tendency to be radiosensitive. They shrink rapidly. As my last speaker has said, the GBM did not move for 10 days. But on the 25th day, there was a 3 centimeter shift, ladies and gentlemen. You need to track that because the GBM mass is close to the brainstem, something which is very crucial to your motor-sensory system, to the cardiac system, to the respiratory system. So adaptive because radiosensitive, because also resistant, because the patient will lose weight. The patient is not a machine, the patient is a human being. He feeds, he breathes, he drinks. So the moment he stops eating, drinking, he'll have a weight reduction. He'll have a loss in the subcutaneous tissue, in the fat. The orphan becomes loose. The patient becomes move. So we might not be having the 5-minute wala planning therapy nahi hai hamare paas. But every resident, every RTT, every physician, every physicist has in their power, they have the ability to recontour, to rescan, replan. Yes, हमारे 5 मिनट नहीं लगते, we might take 12 hours, but we do have. So the margins, why do we need? Adaptation, why do we need? Now let's come to the third part. We may have the ultra modern therapies we have. Was ortho voltage radiation, was it useless? No, it was not. It did save lives. When we had mega voltage fixed beams, fixed gantries, was it useless? No, it did save lives. When we had isocentric treatment it was revolutionary. So whenever we see a new you see a new technology, you hail it as the holy grail, but it is not. I tell you one thing, अगर आपने देखा होगा, see, cancer medicine has evolved from going from basic bombardment. If you just go back to the history of chemotherapy and oncotherapy, you see, you know how these basic drugs they were kind of, how they were discovered, because during World War I they were actually discovering medicine, they were discovering chemicals to kill the enemies, and incidentally they diagnosed that this is something which like kind of dried up the bone marrow of our the opposite side soldiers, and so lo we got a new drug for chemotherapy. So अब हम वो randomly bombardment नहीं करते. We don't do carpet bombing. We don't drop nuclear bombs of tons and tons. We do precision guided therapies in the form of immunotherapy. So RT क्यों पीछे रहे? Why should RT stay behind? You got your MGIRT, you got your SBRT. So when you got your SBRT, it is not only sufficient to have that therapy with you. अगर आप एक मिसाइल एक मिडिल IQ वाले इंसान को दे दे, वो मिसाइल कोई काम की नहीं है, वो अपने सर पे ही फोड़ लेगा, सही है. बट इफ यू गिवाइड अ okay type of weapon to someone who is highly intelligent, give it to a sniper, he will give you a first shot, he'll give you a first kill. So it's not only important that you have the technology, it is important that you deliver it. Now how are you going to deliver it? आप बोलोगे सर हमारे पास एपिड है, we got CBCT, you got MV, we got KV, we got MV, we got MR nowadays which is doing real, and we also got CBCT on rails. The only difference is the cost, the time, the resources, the radiation which we are exposing to the patients. So at the helm, at the everything हमने सब कुछ बना दिया. The delivery has to be done by the technologists. So to get yourself accustomed to, you do not forget, I tell you, and I tell you repeatedly, do not forget EPID. आज के दिन, आज just go back 5 years. अब just go back 5 years, and that time the treatments, the most modern treatments, what you call the cyber arm, the cyber knife, they were 2D images. आप देख लो, ठीक है, कोई MR इमेज नहीं ढूंढता था, रोबोटिक आर्म पे किसी ने MR नहीं लगाई थी, and we are delivering precise treatment, and we got long term data. हमारे पास है long term data to prove that cyber knife works, acceptable toxicity, good cure rates. Once again I'll summarize. ये हमारी सुविधाएं थी. इनवर्स प्लानिंग, वी गॉट VMAT एडवांटेज इन फास्टर डिलीवरी, फास्टर मॉनिटरिंग यूनिट, इंप्रूव कन्फर्मिटी, एनेबल्स डोज एस्केलेशन एज MR उन्होंने कहा था. MR हैज गॉट 2 advantages. One is that you increase the delineation of the tumors. Secondly, you have these specific perfusion images. We can tell you that these tumors are hypoxic. And as he said that you got SIBs, you got dose painting. Specific areas you can target and you can escalate the dose to such doses that they become tumoricidal with accepted OIR doses, accepted treatment toxicities provided. करेगा कौन? करेंगे हमारे RTTs. So that is why vigilance is very important. Training is very important. I can give you all the technology in this world, but it is useless until unless you know that why are you doing it and how to do it. So what has all of this translated into? Reduced treatment in toxicity. We had actual deaths. We had deaths in curative intent patients treated with head neck. They died, CL larynx. They aspirated and they died. That person was supposed to live. We had patients who were curative breast cancer patients. They could have lived years. We gave radiation to the heart. 10 years down the line, they developed cardiac disease. They died. Just look at this is ये जीने मरने की बात नहीं आती है. Just look at the quality of life. When we improve with the therapies, we started sparing the parotids. We started sparing the thyroid. We started sparing the ball. I think that I know several centers they use scalp sparing radiation therapy. So the technology has become robust. It has become time tested. It has been proved and proved again that it is safe. It's only a matter of delivery. आपने xerostomia कम किया, आपने cardiac morbidity कम की, better cognitive profile. Patients who are there with us for months, we give whole brain radiation therapy, but आज हमें पता है कि mementing से अगर we do hippocampal sparing, the patient is better cognitive. He recognizes his parents, he recognizes his children. So technology is, जैसे उन्होंने बताया था, I think Mr. Subrata, the last slide he said that is compassion रहना चाहिए. It's not only about technology. आप टेक्नोलॉजी सब ले सकते हो, लेकिन उस इंसान को रत्ती भर उसके आत्मा को शांति नहीं मिली. आपने होल ब्रेन रेडिएशन करके उसको शायद आपने 45 दिन और एक्स्ट्रा दे दिए थे, लेकिन उस 45 दिन में 23 दिन उसने अपने परिवार को नहीं पहचाना. दैट्स यूजलेस. इसीलिए हमारे पास वाई एंड नॉट इट ओनली नीडेड डेटा. वी हैड द टेक्नोलॉजी. हिप्पोकैम्पल स्पेयरिंग हैज बिकम द स्टैंडर्ड ऑफ प्रैक्टिस. So as I said, CBCT, EPID, CT rail is there with us. Also with tumor regression and active online adaptive based planning is there at a helm. It's only we have to understand that why do we need it. Very important. आपके पास 100 करोड़ हो सकते हैं. You wouldn't know what to do with it. You wouldn't know what to do with, you wouldn't know you would cause harm to yourself. मैं आपको दिखा सकता हूँ, you know, you read the papers, you know very well. कोई किसान को जैकपॉट लग गई, उनकी खेत के पास some project came up, he got several lakh, उसने कुछ नहीं किया, उसने गाड़ी खरीद ली, लेके ठोक दी, मरीज चले गए अस्पताल में. So you wouldn't know. If I give you all the technology in the world, you wouldn't know. So the most important thing to do is understand that why does 2D खराब नहीं थी, 2D खराब नहीं थी, हम लोगों ने उस पर सुधार किया है. We must go from being from 2 to 4 to 40. इसीलिए अब आ गए हम लोग पार्टिकल थेरेपी पे, आज आ गए हम हेवी आयंस पे आ गए, फ्लैश रेडियोथेरेपी पे आ गए हैं. सो अब फ्यूचर क्या है? द फ्यूचर इज जेनोमिक आरटी, दैट मीन्स यू एनालाइज द ट्यूमर्स ऑफ द पेशेंट्स एंड टेल देम दैट व्हाट डोज डू दे नीड. Are they as sensitive as the rest of the population? Can we give any other targeted, any sensitizing drug along with the radiation therapy to improve the outcomes? ये पता है. And also, as you also know that biological effectiveness जो heavy ions की होती है ज़्यादा होती है. So with improved biological effectiveness, we are able to deliver not only higher doses, more effective doses at a safer way. So once again, advances in RT improve therapeutic ratios and outcomes. Technology plus tumor biology is equals to precision. Access to basic RT can significantly reduce. See, that's a purposely put in this line. आपको पता है, जब when we started off, we started with cobalt. Patients are alive today. They're well. They're doing well. आप कह सकते हो कि हमारे CS सर्विक्स के पेशेंट जो आज हम ट्रीटमेंट करते हैं, they never develop cystitis, they never develop proctitis. हमारे यहाँ पे होती थी on treatment, they has to develop diarrhea, they has to get admitted. But they are still alive. What we have improved twofold होना चाहिए. Priority हमेशा is always on life. The second should always also be on the quality of life which you're going to preserve. Advanced technology should be used selectively after cost effectiveness, because as you say, हम वो लोग विकासशील देश है, विकसित नहीं है. We are not a developed nation till now. Yes, it's good to have advanced. हमारे पास कितने proton beam centers है? It's good to have. Because अगर नहीं रहेगा, you never know that how you can benefit your own population. And appropriate triaging of patients is crucial along with appropriate training of the future of a country. Because मैं जितना भी विद्या मेरे पास हो, मेरे पास जितने करोड़ रुपए की मशीन मेरे पीछे हो, the person who is going to deliver is seated on those seats. He has to realize हम जो कर रहे हैं हम क्यों कर रहे हैं. So that is why again, ladies and gentlemen, 3 points. Why do we need to take these margins? Why do we need to be sure that we are going to do adaptive RT? And thirdly, अगर हम deliver कर रहे हैं, how precise is going to be a treatment? We have got everything at our hands. We have got everything at our disposal. Last जनाब ने कहा था कि you just Google and they'll tell you. I'm telling you, ladies and gentlemen, there are free courses who are going to train you. They can be industry led. They can be hospital led, but they will give you free training. They'll give you a certificate telling that I trained you for 3 months in this particular technology. It's only you yourself who's holding you back. So with those words, I'll take your leave. I hope I'm within my 15 minutes. We're already running a bit late. Thank you and namaskar.
Very nice presentation, Dr. Gaurav Goswami sir. Especially, I want to just add some things in advanced radiation therapy. Especially, sir, I have very nicely presented about the advanced radiation therapy. Advantage is in advantage, the disadvantage is also hidden. For the advanced radiation therapy, we should have the skilled doctor. We have skilled all the technologists, and whole department should be very skilled, and the resources well equipped department should be also present at that particular hospital and department. If any link is weak, then we cannot achieve the best outcome, because like suppose in historically, if a disease present in left buccal mucosa about 2 to 3 centimeter and lymph nodes, neck node are without, in historically the patient are treated by the conventionally 2-dimensional 2D and 3D. Basically 2D is bony landmark, basis on the bony landmark, so we can achieve the better locoregional control, but therapeutic index is compromised because we given the high toxicity to that particular patient. But we can achieve the locoregional control. But in new era, currently, that is the era of image-guided radiation therapy, or the advanced radiation therapy, GTV, CTV, and PTV. But we have select the appropriate the target. That is what area we should select. If suppose in historically 3 into 3 centimeter disease in left buccal mucosa, but we treat the bilateral and fill bilateral whole fill and in the line. But currently we no need of the frontolateral radiation therapy, but in some scenario we treat the frontolateral side with disease approaching other things. But overall my conclusion is the target department should be very skilled. Every resources should be very skilled. If any points are missing, then we cannot achieve the best outcome. Thank you.
Thank you, sir. May I take a brief moment to acknowledge the gracious presence of our Honorable Chief Guest, Dr. Satyajit Pradhan, our esteemed guest of honors, Dr. Ashutosh Mukherjee and Dr. Sunil Chaudhary, who has just joined us. We extend you a very warm welcome and thank you, sir, for honoring us with your presence. Kindly enjoy the ongoing session. Treating the entire marrow while protecting the critical organs. This is where engineering meets elegance. A perfect example that even a complex geometries can be delivered with precision. Please welcome Mr. Ajay Churi, Senior Radiation Therapist, Apollo, Navi Mumbai, for a talk on TMLI on stand-based gantry. Please welcome him with a round of applause.
First of all, namaste everyone, and I am Ajay Churi from Apollo Hospital, Navi Mumbai. Before starting my presentation, I want to say thank you to Organizing Secretary Dr. Rajiv Singh, Co-Organizing Secretary Mr. Kamal Kaushik, and entire Apex Super Specialty Hospital team for organizing such a wonderful conference in a capital city of the spiritual capital of the India. So let's jump into the topic. My today's topic is total marrow lymphatic irradiation on the stand-based gantry. We can treat TMLI by using the C-shaped gantry, that is stand-based gantry, and the O-shaped gantry, that is ring-based gantry. Now key areas of topics are what is TMLI, then purpose of TMLI, then indications, positioning and emulations, then CT image acquisition, contouring, and treatment planning and prescription, treatment preparation, setup verification, treatment, then dosimetric verification, then last advantage and disadvantages. First of all, what is TMLI? Total marrow lymphatic irradiation is a form of radiation therapy primarily used in the treatment of the hematologic cancers such as leukemia, aplastic anemia, lymphoma, then multiple myeloma, autoimmune diseases. It involves irradiating not only the bone marrow but also lymphatic tissue, which includes spleen and lymph nodes, aiming to target residual cancerous cells while sparing other organs. Then purpose of TMLI. Total irradiation helps to prepare patient for the bone marrow transplant. It restores cancerous cell in a bone marrow, in the nervous system and other difficult to reach areas. It reduces the patient bone marrow to space for the transplant and safely suppress patient immune system to bone marrow transplant is more likely to be successful. Now indications. Preparation for hematologic stem cell transplant. TMLI is used as a part of conditioning regime before stem cell transplant, especially in the patient with hematologic malignancies like acute leukemia or lymphoma. Treatment of advanced and refractory hematologic malignancies like acute leukemias, the acute myeloid leukemia or lymphoblastic leukemia in patient with persistent or relapsed diseases. Then the chronic leukemia, like the chronic lymphocytic leukemia, and we can use in Hodgkin's and non-Hodgkin's lymphemia. Then in multiple myeloma in case where the conventional treatment have failed or the patients undergoing for the stem cell transplant. And now then graft versus host disease prevention. In some cases TMLI may be employed as a part of conditioning regime to reduce the risk of GVHD after allogenic stem cell transplant. Then chronic lymphocytic leukemia in a TMLI can be used to control CLL. especially when the disease involves extensive the bone marrow or lymphatic infiltrations. After doing patients coming for the consultation with hemato-oncologist and the radiation oncologist, after that patient is coming for the simulation. Before simulation, we have to do counseling of the patient regarding simulation procedure. If patient is very small in age or not cooperative, that time we have to send a patient for the anesthesia department for the anesthesia fitness. Once everything is in place, so we can start our procedure. That as for positioning emulation, as you can see the image, you can emulate the whole body by using the thermoplastic mask and the headrest. For the positioning, we are making the mask for the neck to toe level to fix position. For head region, we are using the thermoplastic mask. While making mask and cushion, we have to keep the vertical level of the entire trunk and head should be same, so that there is a minimum shift during the treatment. And we have to take care of the while simulation. We have to take care of this neck curve so that we can reproduce at the time of treatment. And we have to keep hand fingers straight and strap it with the micro pulse so that we are reproduce at the time of treatment. And we have to mark its position on the backlog during the simulation. And we have to keep both legs quite near to each other so we can cover in a single field at the time of treatment. And we are marking reference point at the head level, then thorax level and the pelvis level. And by marking this, we are trying to remove the roll and yaw at the time of treatment. Now CT image acquisition. After positioning, we are taking for each patient, we are taking the two CT image sequence that with the sequence slice thickness of 3 to 5 mm. And as CT scan, maximum length we can cover is 160 centimeter. So we are taking the head first supine position and then again feet first supine, that is caudal. And for the accomplish the whole body treatment of the patient's length. That for pediatric patients, they having the length less than 105 centimeters. So we can take the only head first supine position. Now contouring. TMLI involves targeting both bone marrow and lymphatic system. And in bone marrow is distributed throughout the body, includes the cortical bone, trabecular bone and bone marrow within the bone. For bone marrow irradiation, oncologists include the structures such as cranial, thoracic, then pelvic bone, proximal, femurs, limbs and ribs. And the lymphatic system, they include the supraclavicular lymph nodes, cervical lymph node, then axillary, mediastinal, mesenteric and inguinal lymph nodes. During and organelle tricks, we have to consider organelle tricks very carefully, and we will try to keep minimum dose to the organelle tricks. So we are trying to achieve minimum dose to the lung, heart, then kidneys, oral mucosa and bowel. Now treatment planning and prescription. There are various fractions for the TMLI treatment. Out of that we are using the 4 gray in 2 fractions and 12 gray in 6 fractions. We are delivering 2 fractions per day with minimum of 6 hours interval, and we are using the 6 mV photon analogy for the treatment. For the lung, we are trying to achieve 10 gray or 6 to 65% of the prescribed dose. For that, therefore, we are using additional helping structure inside the lung with the low constant value to steer optimizer for the lung sparing. Now, these are the PTV which include for the treatment. There is a brain, bone and lymphatics. We try to achieve the 95 to 100% dose to the PTV. And for the OR or physicists try to achieve 20 to 30% low dose as compared to prescribed dose to the PTV. So ORS include the lungs, then kidneys, eyes, heart and mucosa. Now treatment field arrangement. Splitting of planning system is head first supine and feet first supine necessary because couch longi position also. So first we have to optimize for the 2 fields carry out separately with the additional helping structure inside the lung as I said earlier. Then for most proximal 4 segment for head to upper pelvis or mid thigh, we have to treat patient with the head first supine position. Then the patient was rotated 180 degree to treat feet first supine for the mid thigh to extremity. All arc had an overlap of at least 2 cm to neighboring segment to avoid hot and cold spot at the junction areas. We are trying to keep flash margin at fingers level for the anesthesia pediatric patient and the patient under anesthesia, so avoid any dose missage. In this case, you can see we are trying. In this case, you can see we try to achieve minimum dose to lung and kidneys, and these are the arc arrangement for the same patient. Then treatment preparation. Before preparing the patient, we have to keep proper coordination with the anesthesia department to avoid any delays during the treatment. And treatment room should be sterilized prior to treatment. Emulsion devices which are going to use during the TMLI and couch should be cleaned properly. The relation staff which are going to involve in the procedure, should wear PPE like OT gowns, face mask, head cap, shoe cover and gloves. Dedicate one therapist, one nurse who are going to handle patient during the procedure, and dedicate one physicist to calculate shift and implement during the procedure. And 1 day prior to treatment, we have to take dry run with emulsion and check all fields and MUs. These type of PPE we are wearing during the TMLI procedure, and before calling patient for the from BMT department to our relation department, we should always activate the green corridor to avoid any type of infection to patient. Then setup verification. Do the setup as per simulation, match all the reference marker during the simulation. Before treatment setup, patient was verified on the basis of the bony alignment, and we are using for that we are using KV imaging. We are taking first at the CBCT at the level of palms and finger levels, and we are adjusting we are checking it's getting properly covered or not, and we are adjusting procedure according to that. Then during each image verification, we can apply vertical, lateral and roll if needed. As Biplot sir says, if there is a whole body treatment, then we should avoid translational error. But in this case, we are using only roll for that for the TMLI treatment. If patient separation is more, that is in pediatric patient, there is a lateral separation is less. But in adult patient, there is a more separation. So in that case, we are applying only vertical shift. Then after imaging, we are marking upper and lower border of the treatment field. And this is online image verification. As I said earlier, we are taking first CBCT at the pelvis and at palm and fingers level. So matching with the bony anatomy. If we are satisfied with the setup, then we can go ahead for the treatment. Now treatment. We have to verify plus plan name and multi-units before each field treatment delivery. Then always check overlapping of treatment field during each couch shift to avoid hot and cold spot. Before rotating the patient 180 degree with vacuum cushion, mark lower border of field to check overlapping with next one. If patient treatment is under anesthesia, then we should be more cautious about time. And the patient is without anesthesia, then we should positively interact with the patients, but it's not meant to crack joke with the patients, so otherwise he will get moved. And now in first image, you can see that this patient is under anesthesia and head first supine positions, and the second image you can see this patient is without anesthesia and feet first supine position. Now dosimetric variation. We are using the diode detectors for the dosimetric verification. These are the very small precise dosimeter, can be placed on the patient's skin to provide real-time dose readings. They are very excellent for detecting axial dose responses 99.5 to 105%. And the placement of dosimeter. Dosimeter can be placed on the skin surface over the treatment to measure the dose. In the case TMLI, dosimeters can be positioned on the skin near key areas of the bones such as the sternum, pelvis and femur. Then a point should be chosen to verify dose coverage as critical structure of the body. During all fraction, placement of dosimeter should be same. So at the very first fraction, we are marking position of the dosimeter so that there is no dose variation during the reading. This is a patient setup with the dosimeters. We are using here IVD for dosimeters, and here you can see that we are getting real-time dose reading for the each fractions, and the need of for your dosimeter to document patient dose delivered during each various part of the body in each fraction. This is the dosimetric verification table for the 6 years old patients. In this patient, we give 12 gray in 6 fractions. We place diode at his forehead, then the sternum, then right lung and umbilicus, and these are the dose reading for the consecutive fractions. For the mean dose for the forehead is 56.52%, for sternum is 88.72%, for right lung is 71.43%, and for umbilicus is 93.9%. The intent of in dosimeter in dosimeter to verify the delivered dose during each fraction. Our physicists validate the TMLR dose with the help of their TLD placing at the various location of the anthropomorphic phantom, and these are verified with the TPS dose. And after that only we have started TMLR treatment in our hospital. Now advantages. Total malradiations target the entire skeletal and lymphoid tissue while sparing organoid risks such as parotid, oral cavity, lens, thyroid, lung, heart, bowels, kidney and breast. Then TMLR post-treatment side effects are less than the total body radiation by the stand. The decreased risk of relapse and improve outcome of the bone marrow transplant. Now disadvantage. It takes long time for the treatment, that is 1 to 2 hours. If treatment is under anesthesia, then more anesthesia dose is needed because of the long treatment time. For the consecutive fractions, the anesthesia requirement for the same patient is increased, so it's again added the anesthesia dose to the patient. In a nutshell, in TMLR treatment, patients have less post-treatment side effect than the TBI due to dose sparing of critical structures. Then the chances of radiation-induced secondary carcinoma is less than TBI. For lesser, we have to take more efforts. Infection control protocol should be in place and implement properly to avoid infection to the patient. We should keep proper coordination with the departments such as bone marrow transplant, infection control and anesthesia department to avoid any type of delay or avoid infection to the patient. And these are our team of radiation oncologists, physicists and therapists and nurses, and because of them we can deliver such a comprehensive treatment. And thank you everyone for listening with me patients. Thank you. Any question?
Nicely covered, I think, several things about the TMLI indication, dose fractionation, and the advantage in comparison to the total body irradiation. Thank you. Any questions from the audience side?
Thank you.
Thank you, sir, for such an informative talk. We now come to a topic where physics gets creative and technology gets personal. Traditionally, mold room taught us patience, adjustments, and a lot of fine-tuning. But today, physics has upgraded its tool and 3D printing has entered the mold room. This is where digital design meets dose accuracy. To take us through this exciting innovation, we have Dr. Ninad Patil, Assistant Professor, Radiation Oncology, MPMMCC, to kindly take the stage and share his presentation on the perfect fit 3D printing in the modern mold room.
Good afternoon, everyone. I hope the PPT is visible till the end. So this is the overview of the presentation. 3D printing comes under the broad spectrum of additive manufacturing, and I'm sure that some of the seniors in the room would be experienced already with old techniques like CNC machining, which used to come in subtractive manufacturing. So both of these are in-house fabrication techniques. So it is nothing new. So technically we should have workflows, experience, process validation, commissioning experience with the whole domain since 1960s, since the CNC machining entered our mold rooms. Since it is a cost intensive effort, maybe it has not entered everyone's mold room, but then I'm sure that people who are now in procurement phases would be thinking of additive manufacturing. So what is the scope? Scope is tremendous in medicine overall. What is the scope in radiation oncology pertinent to mold room practices we'll be seeing? What are the available technologies and machines? We'll have a few snapshots of a few workflows. We'll take a look at safety and regulatory compliance. What are the implications if you're considering it? And if you're really interested, after the thank you slide, there are 4 more slides about a deep dive if time permits. So we'll see one clinical use case in detail. So this is from a review article. What is the, they did a review of publications in 3D printing in 2020 and what was the utilization of 3D printing in radiation oncology. So you can see most of it was imaging and dosimetry. Actual treatment where brachytherapy molds, compensators, immobilizers were what was involved. So what is the scope? You can create bolus. So it is a supplement to traditional mold room techniques and some avenues where it gives unique advantages. So you mold and bolus or tissue compensators manually also, or you can create it with a 3D printer. Now, advantage of 3D printer and our traditional CNC machining, it is an inverse design. So you get to design it before you actually fabricate it. You get to tailor the design. You get to do the dosimetry of the actual device before you manufacture it. You get to tailor it. Same advantage in surface molds or brachy applicators. Same advantage in electron cutouts and boluses. Electron cutouts, one massive advantages is you can replace the toxicities involved with low melting alloys. Training aids and models can be created instead of purchasing from outside, and maybe sometimes you don't have training aids and models in rare cases, rare applications. There you get to make your own. You can make personalized positioning and immobilization accessories. You can make accessories that are not available commercially. If you are of an inventive mindset and you think this does not exist at all, I want to start making it, I want to probably patent it, a 3D printer is the perfect accessory to start prototyping and reach a level of product design that is now viable to send forward. So the first thing, bolus or tissue compensator. So most of my images are taken from the internet. We do this in-house also, but since patients were involved, I am not sharing our images. Bolus or tissue compensator, whatever is made traditionally with wax or with gel boluses can be made with 3D printing also, with the advantages that now you get the opportunity to tailor your bolus within the software for the dosimetry desired. Electron intensity modulation, so something that is not possible without the rapid prototyping, additive manufacturing or subtractive CNC machining. So traditionally electrons have been treated with open fields, and whatever beam intensity you get throughout the field is what you accept. Versus if you have the ability to create a compensator where you are able to tailor the prescription isodose line to conform to the depth of the target, now you get even better OR sparing with electrons. So this is the advantage of a 3D printer. So if you see, this is the pointer. So this is the traditional way of making a bolus for electron therapy. You would make the lower surface conform to the patient's anatomy. ठीक, ऊपर का for electrons you would want it to be ideally flat so that you get a uniform dose distribution. Advantage of 3D printing, you first design this in software, you see how the dose is, and then you decide what depth dose you want. You iteratively change the bolus within your software, within Eclipse itself. So my experience with Eclipse, you iteratively change the upper surface also, and now the upper surface is also modulating. So this is a dual bolus. The tissue, it is acting as a tissue compensator as well as an intensity modulator on the upper surface. Plus advantage of 3D printing, we already have modeled our in vivo dosimeter. So उसके नीचे के साइड पे एक TLD chip का slot लगा दिया है, या एक in this case is a OSLD slot. So all of this is what is unique to 3D printing, how it supplements your traditional manufacturing. Shielding devices. So since morning, I think 2 or 3 talks have covered the concept of electron shielding. One talk on radiation safety very rightly pointed that when you want a regular rectangle also, you should not ideally keep a lead strip or a bar of Ceroband. You make a cutout. Now making that cutout is something that takes around 2 to 3 hours of one person's manual intensive work in the mold room entirely. Versus if you have a 3D printer, you simply make that outside mold of the cutout in software one time, and whatever aperture you want is hardly 5 minutes work. Then that 3 hours is taken up by the printer automated. So एक आदमी को रूम से 3 घंटा आपने निकाल दिया. So he is now available for routine clinical work. ये काम मशीन कर रहा है अब. This is a basic plastic shell filled with lead ball bearings. This is nothing innovative. This paper has come in 2023 with extensive experience from Stanford. Now we are also actively doing this in PMCC. Surface molds by 3D printing. Again, advantage of 3D printing. Traditionally, how we have been creating surface molds, we clinically see the disease, we indicate where we want our catheters to be placed, we give an adequate margin, we tell ki catheter should be at so and so height, and then the mold is fabricated manually. We accept it, we go to simulation, we plan the patient, whatever dose we get is what we get. If your mold was not made properly, that is still what we get, and we have to then rely on optimization. In 3D printing, you first fabricate it in, you first design it in software. If you have designed it in software, now you have to do the dosimetry first. Then you see whether your mold, your catheter placement is appropriate or not. You verify that, and then you fabricate it. That is the advantage of 3D printing. So this also. So I thought that I underestimated the power of this conclave. I thought the classroom will be smaller, so I am carrying a very small sample here. So I'll pass this around if you want. This is a commercial fiber flap. We have in-house manufactured a replica of it, not a replica, we have optimized it for 3D printing. We use this for basic dosimetry of our in-house process commissioning. So you can create this generic applicator also. You can use it clinically after you have process validated. We'll come to the validation and regulatory aspects later. So one important caveat is we'll come to the regulatory aspect later, but try to ensure that your channels for brachytherapy are not 3D printed. So rely on the clinically validated, commercially available channels. What we are just doing is we are creating holes for the brachytherapy channels. This is another publication available where they've created a patient-specific vaginal mold where tissue tumor was at a very high depth over here in the paracolpos, and to address that, creating a using any commercial brachytherapy applicator would not be possible, because the depth was so much that the perineal bones would have, the pelvic bones would have prevented entry from the perineum. So this kind of a divergent geometry necessitated 3D printing. So this is one aspect where 3D printing can do something that cannot be done by commercial applicators. All of you might be aware of the Vienna 1, Vienna 2 to Venezia journey. 3D printing was involved at every step in this journey. If you have any background with Astro or TMH, so every prototype was 3D printed, every prototype was tested, clinically validated, and then it went to manufacturing. So this is the clinical journey of, so anyone has seen a Vienna 2 so-called? So Vienna 2 is basically a Vienna 1 with a 3D printed cap behind it. It never got manufactured. It never went to manufacturing. The vendor converted that concept into a Venezia. So this is the Vienna 2 ka prototype. So this is another avenue where you get to make templates specific to a patient's needs. This is something that we have not yet done. This is a extreme, someone adventurous will have to attempt this. But then you can create a template where you have a pre-planned volume, pre-planned geometry, and then you have a needle insertion guide to help you with brachytherapy. We have done this. So this is basically a penile brachytherapy implant template, and our ventures with ISBT have gone up to adding our regular gynec brachytherapy needles into the regular Fletcher ovoids. So upgrading a Fletcher into something that is like a Utrecht or a Geneva applicator. You can do in-house fabrication of setup accessories. These are basically indexers for your vacuum cushions. One common question is, what about the radiologic properties of this? So up to brachytherapy it was fine. Brachytherapy we are anyway relying on TG 186 for TG43 for conventional applicators also. Here in EBRT we are now concerned about CT density, what is the scatter properties. So in 3D printing also, although we are creating objects of plastic or hollow objects, we get to modulate some of the aspects by doping them or by creating hollow objects and filling them with foam like our traditional neck rest. So 3D printing need not always create the end product, it can create an intermediate in the steps to an end. So here a silicone bolus is created with by casting silicone into a 3D printed mold. Coming to the types of 3D printing, types of additive manufacturing. So we won't focus on the whole slide, just the most common and the easiest entry points into the field. There is fused deposition modeling where you melt a plastic, or there is a stereolithography SLA where you photopolymerize a resin. We'll come to the details of that. If you are considering a printer, what should you consider? What is the technology, those FDM or SLA? What are the clinical use cases that you have. So that will decide what build volume you want, kitna bada printer chahiye. What material variety does the vendor approve? Does the vendor give? Whether it is approved for third-party material use? You need to think about what are the workflows in your department where you would want to adopt 3D printing. So the higher end you go, iPhone लिया तो simple रहता है, Android लिया और वही काम करना है तो ज़्यादा दिमाग लगाना पड़ता है. So the more expensive you go, the easier to use, but then the more locked in the ecosystem becomes. Resolution, accuracy depends on what is your use case. Speed, throughput, same thing. iPhone, Android wala comparison. So other than the printer characteristics, what you also have to be concerned about is the material selection to the use case. So if you are doing something interstitial brachytherapy, you will need biocompatible. If you are creating a indexer bar, does not need to be biocompatible. So there the material selection comes into play. If you are doing something that comes into patient contact, needs to be sterilizable, needs to be autoclavable, let's say, that is a different material selection altogether. So these are some of the 3D printers by technology. We'll come to this is the FDM 3D printer, prototype FDM 3D printer, prototype MSLA printer. So FDM is basically, these are the spools of material. This filament goes over here, melted and deposited. Here there is a resin vat in which there is a liquid resin. That liquid resin has a laser from here, which UV laser. That UV laser जब contact में आता है तो it photopolymerizes that liquid into a solid. So by scanning that laser across the bottom, or this is a projection based DLP printer. So by projecting that image at the bottom, it creates the solid material which sticks to this plate, goes down, the first layer sticks, comes up, next layer sticks, वैसे layer by layer बनता है. The differences between both technologies. Ideally, a holistic 3D printing setup would include two of these technologies. They are very low cost to entry because both of them have a different gamut. They don't have much of overlap. So one would be more appropriate to a high precision small volume print, one would be for a large print. This is the basics of SLA DLP. So there is one misconception that I can print an iPhone. No. So you can probably print the plastic components of an iPhone. You cannot print the end product without significant processing of the end product. So जब आप print करते हो तो हवा में print नहीं कर सकते. There has to be a few support structures. So वो support structure आपको हटाना पड़ेगा. वो जहाँ पे print को contact कर रहा था वहाँ पे rough रहेगा surface. उसको थोड़ा घिसना पड़ेगा maybe. So if you are trying to print something that is not optimized for 3D printing, then there will be a significant amount of post processing. Otherwise, it has to be something designed by you where you have that thought since the beginning कि मुझे ज़्यादा post processing करना नहीं है. मैंने खुद से ऐसा डिज़ाइन किया है कि it is optimized for 3D printing. That is why that surface flap was optimized for 3D printing, minimum post processing. FDM में post processing is much lower. FDM printers in general are much larger in volume, less precise, faster. Although now DLP is also catching up. So post processing में usually support निकाल दिया, थोड़ा सा घिस दिया, हो गया. MSLA, your resin printers are more precise, but then वो पूरा print जो बनता है वो liquid resin से, and that resin is sometimes carcinogenic also. So it is dripping with that. So you need to first wash that. You need to put it in a UV chamber to fully harden it, and then it is ready. If you need to then remove some support structures, and if you need to polish the surface, that is a separate step. So in general, this is more precise, smaller volume, but more labor intensive. So how do you integrate this into your workflow? So there are a few commercially available platforms which are end to end. आपका Eclipse या Monaco में एक end plugin किया, दूसरा end printer में plugin किया, and it is nearly invisible to the end user what is happening in the background. You create a bolus in your virtual bolus in your software, you give the print command, it gets printed. So that is obviously going to take more cost. In an Indian scenario, it is more feasible to go with a step-by-step process, learn the each and every step, learn what are the free tools to use. So if we get time, we'll discuss this in detail. There are two main domains. One is a CAD-CAM based design where you have a parametric design, itna by itna centimeter ka rectangle, itna bada, itna. So you have first given the parameters and the design is based on that, or patient based. So ये सीधा patient के ऊपर model किया हुआ है, उसको print कर दिया. Two different workflows or a hybrid of them. So like we have been seeing our electron applicator. So इसका बाहर का part parametrically designed है in this CAD CAM software. And जो aperture patient specific aperture है, that is the one part that came from the TPS as a image. So now we'll see a few considerations for material selection, safety, regulations, etc. So whenever this question comes up, my go-to is dental, because compared to radiation oncology, dental has a very vast and extensive experience with 3D printing. Dental fabrication labs में 3D printing is now standard and basically essential. So dental has a very good selection of materials also. If you are not confident, you go with a dental approved material. So when you go to material selection, you enter the field of material sciences slightly. If you want to now do cost-effective solutions without relying on a direct approved material, you need to have these considerations. So how are you planning to sterilize the material? How long the material is coming in contact with body? What level of biocompatibility do you want? So regulations वगैरह इसमें. So don't worry about the slides. I'm sharing the slides with everyone anyway. Regulatory compliances. So additive manufacturing is a rapidly evolving field. It was not included in any rules until 25th November 2025, 2 months ago. So 2025 में medical devices rules were revised, and radiation oncology was given a complete different annexure. 3D printing will come as a custom made medical device in this annexure. There are no exemptions for safety. You are basically, as long as what you create is being used in a patient, you are a medical device manufacturer, small scale, not for sale. But then you are a medical device manufacturer. So you have to think in that workflow. As a medical device manufacturer, what are the safety requirements? If something is just a physics jig or a phantom, not for clinical use, you are just in the intermediate process of a machine commissioning, you can still classify it as a lab equipment. But I would say the bulk majority of everything we do comes in class C of this. So if you are entering that field, then I would urge you to read what is the class C requirement for a medical device rules in 2017. Class D, very rare, permanent implants, neuro implants, or vascular breaking. What is needed? You need to define the workflow, define intended use. All fabrication processes are to undergo user validation from design to dosimetry. Ensure equipment commissioning and periodic QA records for the equipment itself. Materials are approved as per use case. Individual print also has to have a basic QA workflow in your department. Maintain QA logs and track failures. That is the CDSCO requirement. Achha, so the next thing is, what about three major concerns from people who want to enter the field. What is the equipment cost? What is the skill build cost? What is the consumable cost? So this is the first 3D printer that we started off in MPMCC. It was a self-procured 30,000 Chinese printer. Right now it would be available at 12,000, 15,000, something in that range. And that is where we started gaining experience with the process validation, the print commissioning. Right now we have upgraded to this. This is thanks to Sir's initiative, probably a state-of-the-art setup, where we are able to cover almost everything that is possible in the radiation oncology. So this is a FDM printer, this is a MSLA printer. Both are full open source printers with third-party materials. This is a research printer where we can do, we can almost break it with our material tailoring, and it is still robust enough to run. Software side pe, as I told, there would be end-to-end solutions where you need to do nothing, it is invisible to you, or there is, in a research setting, free and open source software where each step would require a different software, each step would require a process commissioning, and you would need to do commissioning of the whole process initially, and then each and every print would need some basic QA because you are doing something completely in-house. But then I would like to again show this ki inke paas kitne printer the? Zero. He is not a techie, but he won one prize in literature, one Nobel Prize in literature. Iske paas 5 printer hai, techie hai, 0 prizes, 0 Nobel Prize. So the technical skills can be built up. Equipment can be outsourced. So printing requirements can be outsourced. What you need to work on is the workflows in your department. That is more crucial. Expensive tools don't define innovations. Thoughts define innovations. So thank you. You can download the PPT from here, and if we have time, we can delve into one workflow. I think we don't. We are already running late.
Thank you so much. Very excellently presentation about the 3D printing. Basically, this is the computer design based technology, and just our issue is the cost effective or expensive?
Depends on what you are making. If it is patient specific, you need to find a pathway to get reimbursement for that from the insurance schemes, or you need to find a way to get patients to pay for it. But let's say you are designing your vacuum cushion indexers. One will cost 20,000 from a manufacturer, one will cost you 150 for production by your side. So the ROI on the printer would be immediate. I would say within 6 months you can get the ROI if you are doing something that is otherwise expensive.
And about the durability of 3D printing produced the immobilization or positioning devices in comparison to the conventionally manufactured devices. So what are the durability of this 3D printing produced the material?
It depends on material selection. Like if you see literature, physics would love to do everything in PLA because PLA पे सबसे ज़्यादा data है. But PLA is fragile. So since day one we have been using PETG, which is our plastic bottle का PET. And till now, out of 12 indexers we have printed, 2 have broken. Compared to that, since 3 years now, and compared to that, the vendor supplied indexers में 50% break in 2 years. So it is better than the vendor supplied. Depends on your material selection and how thick you make the prints.
And any specific disadvantage or challenges that you have faced during the manufacturing?
Yes, a lot. So we have had so many occasions where the print looked okay in your hands, but when you went to the patient, it started giving, so catheters get stuck, or it has a moving part which is getting stuck. So all of this is part of your initial process commissioning, where you are able to fine tune your tolerances. You are able to print something that does not fail in the end in the patient. So the end-to-end software that I told, that has all of this commissioned in the beginning. If you do it step by step with free open source tools, then you need to have a robust process commissioning on your end to prevent these kind of failures.
Thank you.
That my question is because in the previous years we used to have a good molding. This was established in every department. Now this mold room has confined to the making of the only the casts. So how we, because in the previous years we used to do the lung shields, kidney shields, compensators, tissue compensators, everything, even surface molds were used. How we look in the present scenario in terms of the education and knowledge?
So in a educational institute, I would suggest that even cobalt is a necessity. A conventional simulator is a necessity. It becomes difficult to teach students about concepts of radiation oncology if all you have is a CT sim and a IMRT IGRT machine. You're not even doing CT CRT. So in that setting, you need the whole gamut of everything. उसमें mold room तो चाहिए sir. In a department that is not a teaching institute, that is just pure clinical practice, maybe you are not going to use the mold brachytherapy. If you are also having electron therapy, you might focus on electron therapy, but उसमें भी इसका application है sir. So you can have this as a supplement to your mold room in any clinical scenario, and I would suggest in a in a teaching and a research hospital, this is a necessity. Thank you.
Ladies and gentlemen, as we conclude our session 2, I now respectfully invite our esteemed patron and organizing chairman, Dr. Ankita Patel, to kindly do the honor of felicitating our respected chairpersons and speakers. Mr. Subrato Roy. Mr. Ravindran Gopal. Dr. Gaurav Goswami. Mr. Ajay Churi. and Dr. Ninath Patil. I now request our respected chairpersons, Mr. Rakesh Kaul, to please come forward for felicitation. Dr. Udal Yadav. And Dr. D.P. Pandey. Thank you, sir. Thank you, ma'am. Ladies and gentlemen, after an intellectually engaging session 2, we now pause for a moment, not to stop learning, but to begin this conclave in the most meaningful way as we step into the inaugural ceremony of ARTTI Conclave 2026. May I request our hall management team to kindly prepare the stage for inauguration ceremony. In Indian tradition, every auspicious beginning is made complete by seeking the blessings of Lord Ganesha, the remover of obstacles and harbinger of wisdom and success. So I humbly invite our nursing team to kindly come up on stage for Ganesh Stuti. Please give them a warm round of applause.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. Pasa pasa गणनायकाय गणदेवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि. पासा पासा आत्मने गानो सुखाय गानमत्ताय गानो सुख मन से गुरु पूजिताय गुरुदेवताय गुरुकुल स्थायिने गुरु विक्रमाय गुह्य प्रवराय गुरवे गुण गुरवे गुरुदैत्य गुल क्षेत्रे गुरुधर्म सदाराध्याय गुरुपुत्र परित्रात्रे गुरुपाखंड खंडकाय गीत साराय गीत तत्वाय गीत गोत्राय धीमहि गूद गुल्फाय गंधमत्ताय गोजय प्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि Thank you.
What a soulful performance by our nursing team. Light symbolizes knowledge, clarity, and hope, the very values that guide us in our profession. I now have the honor of inviting our Honorable Chief Guest, Dr. S. Pradhan, our respected guest of honor, Dr. Ashutosh Mukherjee and Dr. Sunil Chowdhury, our eminent chairman, Dr. S.K. Singh, our dynamic patron and organizing chairman, Dr. Ankita Patel, and our esteemed leader and president of ARTTI, Dr. Ajit Singh, for the ceremonial lighting of the lamp. Please welcome Dr. Sarup Patel also. May I now request our organizing secretary, Dr. Rajiv Singh, to grace the dais and extend a warm welcome to our chief guest and guest of honors.
Thank you so much. I would like to request Mr. Gurvinder sir to come on the stage and have a seat. Thank you, sir. Respected chief guest, guest of honor, respected dignities on the dais, estimated faculty members, dear delegates, colleagues, and friends, thank you so much. It's a very good morning, good afternoon, sorry for the things. On behalf of organizing committee, myself, Dr. Rajiv Kumar Singh, it's a give me an immense pleasure to welcome you all the ARTTI Conclave 2026 scientific session organized by Apex Hospital and PGI Varanasi. This conclave is dedicated academic initiative aimed at strengthening professional skills, encouraging innovations, and enhancing patient-centric radiation therapy practices. So, ladies and gentlemen, the scientific program for the today has been precisely designed to cover the skill development and clinical context, technology advancement and innovation in radiation, clinical practices, RTT, identity and patient safety, emerging trends and departmental expertise. A thought-provoking panel discussion is also there on academic growth of radiation therapies of India. We are confident that the deliberation today will be intellectual, enriching the clinical relevant for all the parts. With these words, we formally begin the felicitation ceremony of ARTTI Conclave 2026. Moving ahead, it gives me immense pleasure and a deep sense of pride to stand before you today on the special occasion of felicitation. Today, we have gathered not merely to celebrate an achievement, but to acknowledge dedication, perseverance, and excellence. The truth inspire us all. The person who we are honoring today has constantly demonstrated commitment, integrity, and passion in their work. Through hard work and determination, they have set a benchmark of excellence and proved success is not an accidental. It is the result of continuous effort and unwavering focus. This achievement is not only a personal milestone but also a moment of pride of our entire organization and humanity. It motivates each one of us strive harder, dreamer bigger, and believe in our own potential. We now move ahead as a mark of respect and appreciation for our estimated dignities. It is my honor to invite Dr. S.K. Sir, Chairman of Apex Super Specialty Hospital, Varanasi, to kindly come on stage and felicitate our Honorable Chief Guest, Dr. Satyajit Pradhan Sir, Homi Bhabha Cancer Hospital Director, and Mahamana Madan Mohan Malviya Pandit Cancer Hospital, Varanasi. Thank you so much, sir. Thank you, Dr. S.K. Singh sir, for this gracious honor And thank you, Dr. Satyajit Pradhan sir, for kindly accepting our felicitation. We are deeply honored by your estimated presence with us today. Thank you, sir. Moving ahead, I request Dr. Ankita Patel, ma'am, who is our organizing chairman also, and director of Apex Super Speciality Hospital, Varanasi, to kindly come on stage to felicitate Dr. Ashutosh Mukherjee, HOD of Radiation Oncology Department. Thank you so much, Dr. Angita ma'am, for this honor, and thank you so much, Dr. Ashutosh Mukherjee sir. For the next felicitation, I invite Dr. Ajit Singh sir, President of ARTTI, to kindly come on stage and felicitate Head of Department BHU, Radiation Oncology Department, Dr. Sunil Chaudhary sir. Now I would like to request Dr. Neha Gupta ma'am, HOD Radiation Oncology Department, Apex Hospital, to felicitate Mr. Gurvinder Vadhavan sir, Chairman of ARTTI. Thank you so much, ma'am. Thank you so much, sir. Now I would like to request Dr. Satyajit Pradhan sir to have some words to our peoples.
Good afternoon, all. Dr. S.K. Singh Saab, the chairman of Apex Super Speciality Hospital and TGI. Dr. Ajit Singh, the president of ARTTI. Dr. Kulvinder, the chairman of ARTTI. Dr. Ankita Patel, the organizing secretary, and Mr. Rajiv, Dr. Rajiv Singh, the organizing secretary, Dr. Ankita Patel, Dr. Ashutosh, Dr. Sunil Chaudhary, and dear friends. It's really a great honor and privilege for me to be here at the ARTTI Conclave 2026, which is being held at Varanasi in Uttar Pradesh for the first time. And I congratulate the local organizing committee and the office bearers of the ARTTI for giving Varanasi the opportunity to hold this conclave this year. I hope you all must have been to the banks of the Ganges. If not, you will soon be there. And especially in the early morning, what you see is that you'll see, apart from the sunrise, you see few kids and elderly, they are in the water. Some are swimming, but the majority of the people there, they are on the banks. I mean, some might be knowing how to swim, and the majority would not be knowing how to swim. And those who are actually swimming there, they did dare to take a plunge. And they did dare to have a dream. And that is what has been the story of Apex Hospital, that we are here. And Dr. Santosh Singh has been a contemporary with us at our alma mater at BHU, IMS BHU. And maybe he is amongst the few people who dared to dream and who dared to take a plunge. And what do you see of an effort, the dream that was there, say, 3 or 4 decades ago? What you see here is the outcome of that dream that he had, the twinkle in his eyes that he had then. So, because he was dreaming of something big, and it just didn't end with just setting up a private hospital or setting up a practice. It went beyond that. And he brought many of the new innovations in medical care to Varanasi. Some of the first few gadgets, high-end gadgets that were available in Varanasi has been there at Apex Hospital. Then he didn't end there. He thought that it's more beyond service, you have to go beyond service, and that is what he aimed for, excellence. And not only excellence, he went into academics, say developing the manpower that is needed. He has started the PG Institute, then he had the paramedical courses running here. Now we have even DNB, radiation oncology running here. So this has been a long journey, maybe which has not been very, simple or easy. He must have faced so many hurdles, and I must congratulate him that he has been successful in his dream to bring state-of-the-art care, medical care, and even cancer care to Varanasi in the private sector. And he has not stopped there, and I am sure he'll bring in many more new innovations, not only in medical care, but cancer care. You must be thinking, why am I just, praising him so much? Okay, he has made something possible. But when he made his journey, I also made a similar journey. At that time, radiation oncology is not what it was, what it is today. We just began our training on a cobalt unit. We had a brachytherapy, maybe manual afterloading brachytherapy. Then subsequently we had a remote afterloading LDR, MDR brachytherapy. And in those days, because the techniques were not that difficult, most of the centers in the country were using cobalt units. Only a few of them, like the AIMS or TMH or Adair or Kidwai, they were some of the first institutes that could get a linear accelerator. And it was not very common for a center to have a linear accelerator. Then subsequently what has happened, the technology has advanced, and in the current period we have so many high-ending technologies and treatment techniques in radiation oncology, and it's not easy for the technologists of the earlier years to handle these machines now. So things have advanced, and even the technology has advanced, and that is the need that we need to have good and adequate training programs for our technologists and radiotherapists. So that is the need, and that has been the reason that we have certain highly specialized training courses running across the country, and the technologists of the current day is much more than simply operating a machine. The entire process of radiotherapy, as I must say, is basically a team effort. So as they say, the weakest link of a chain is the strongest strength of the chain is as weak as the weakest link. So suppose there are so many steps involved in a radiation delivery of radiotherapy. The clinician may see a good patient, work them up properly, then maybe you do a good simulation, the physicist does a good planning, and then subsequently the treatment has to be delivered. Unless our technologists or radiotherapists are adequately trained or they are knowledgeable, maybe whatever we have planned may not be, ultimately it may not translate into the plan that we have developed for the patient, and that execution, if the execution is faulty, maybe whatever effect result we are aiming for, that may not happen. So that is the reason that we not only have to be trained properly, at the same time we have to update our knowledge, and then because technology is advancing fast and we have to update ourselves, be technologically sound, and then at the same time, apart from knowing your job well, what is needed for a technologist or a radiation therapist is empathy. I'm not talking of sympathy. There's a difference between sympathy and empathy. Sympathy is when you feel bad for something, but empathy is when you actually get the feeling of the person and try to see what the person is going through and how best you can help through, feeling as if you are part of the system, part of the family of the sufferer, and you try to help them out. That is what is empathy. And then other thing that we need to take care is you have to be innovative. I'm just reminded of Kamal Kaushik, who is supposed, he's one of our staff, not because he's our staff, I'm trying to praise him, but he has been quite innovative. Like we have the center at Homi Bhabha Hospital, where we basically treat all the children. The pediatric patients are treated there. Now many times it's quite difficult to put them on the machine and in the bunker and get them treated properly. Now he has devised that the thermoplastic mask, he has himself painted them as a Superman, Spider-Man, and sometimes these children, they are quite happy to wear those masks and get the treatment, and they don't create a fuss. So it's not only having a empathy, but also you have to be innovative, and you have to take your job not as a job, but as a journey where you are there to help out the people. So I am happy that the theme of the conference is precision in practice, advance in radiotherapy and patient care. We have to keep abreast of whatever is happening. We have to be precise in the treatment delivery. It's not simply that, as somebody presented, that we should not be doing the things. I think Dr. Ajay was telling that you should not be just taking up the patient and then while you're talking with somebody, you set up the patient and do things. You have to be very careful while you're doing the setup and the execution of the treatment. And if you have to stay extra 10 minutes beyond your duty hours, it's actually, I must say, it's worth it, because you're trying to help out somebody. It's not a government job like I have to be here at 9 o'clock and leave the patient on the couch and leave at 5 o'clock, or I can say, okay, kal aajo, aaj nahi ho payega. I can stay that extra 10 minutes or 15 minutes. Maybe that extra time that I give to the patient might help them, and also it gives me a satisfaction. So I wish you all the best in your career and your development of the specialty, and also taking care of the ailing humanity. Thank you all.
Now I'd like Dr. S.K. Singh sir to have some words. Or some.
Thank you, Dr. Raju. First of all, I would like to compliment whole team engaged in organizing this ARTTI 26, especially Raju and Kamal, the team from Apex and team from the PMMC. Over that, I feel very happy whenever I meet Dr. Pradhan. Why? I will tell you later. So, welcome all the guests from Varanasi, Apex, DHU, and Pan India. I don't know the name of many people, so I will not take the name of any people. So, it is a really very pleasant moment to see the first ARTTI event organized here. Focusing on the science, as Dr. Pradhan said, science means we have to operate the machine. No, we have to have the empathy to help whosoever is needful. So our attitude should be helping as soon as we enter the hospital and going out of the hospital. Empathic attitude doesn't need only in the RT room. It starts from the parking or entering the gate. If one of the patient is walking in the hospital, he is painful, he is helpless, he needs some support, please give. Your supportive staff will always follow you. I have been a student of orthopedics. My teacher Professor Tuli सर मिल चुके हैं. ऑपरेशन थिएटर में जो डॉट टाइम होता था, पेशेंट अगर गैलरी में है तो आते थे, तो अपने नहीं आते थे, वो पेशेंट की ट्रॉली भी खींच कर साथ लाते हैं. तो उनका ये पैशन था कि हर चीज़ टाइमली होगा. तो टाइम डिसिप्लिन इज अ वेरी इंपॉर्टेंट इन गिविंग द ट्रीटमेंट. वी कीप ऑन मीटिंग द पेशेंट, रिसीविंग द कॉल, सर बड़ा टाइम लग जाता, सर जरा फ़ोन कर दिए, थोड़ा प्रायोरिटी हो जाए, थोड़ा ये हो जाए. तो यू हैव टू लिसन देम. व्हाट इज देयर पर्सनल नीड, यू हैव टू एकोमोडेट. रिगार्डिंग इनोवेटिव, सर ऑलरेडी बोल चुके कि आपके डिजाइनर ड्रेस से बच्चों को हम प्लीज़ कर लेते हैं, तो आपको एक बुजुर्ग को भी प्लीज़ करना है, यूथ को भी प्लीज़ करना है, और आपको अपने काम को प्लीजिंग एटीट्यूड, प्लीजिंग एटमॉस्फेयर में. सर ने कहा कि आप मशीन पे कर रहे हो, बातें किसी और से कर रहे हो, कुछ हमारे पास वो भी कंप्लेन आते. सर एक एनेस्थेटिस्ट लेडीज पेशेंट थी, तो सब करके फीडबैक हमको दे गई कि सर वो पेशेंट को पोजीशन वोजीशन करने पे सब बातें होते बहुत रफ करते हैं, कई साल पहले का. तो ये चीज़ इम्प्रूव करते रहना है कि हम क्या बात कर रहे हैं. वो पेशेंट फर्स्ट टाइम लाइफ में आया है आपके उस टेबल पे, तो उसे हमें गाइड करना है कि बाबा यहाँ चलना है, या 2 स्टेप चढ़ना है, 1 स्टेप चढ़ना है, आप लेट जाइए, सिर इधर करके पैर के, मतलब आपको गाइड करना है उस भाषा में कोई समझ सके और फिर अपना रिफ्लेक्स तैयार कर सके. अगर वहाँ आप चूक करते हैं तो मैं खड़ा रहता हूँ रास्ते में, स्ट्रेचर लेके जाते हैं तो कहीं खट 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 आवाज़ करती है किसी जगह कुछ जगह है. तो मैंने GDO स्टाफ को ट्रेनिंग दिलवाई है कि नहीं, आपको पहले बताना है कि आप यहाँ चलेंगे तो थोड़ा आपका स्ट्रेचर हिलेगा, आपको घबराने की जरूरत नहीं, कोई आपका नुकसान नहीं होगा. मतलब आप एज ए गाइड काम करो तो उनका मेंटल टेंशन जनरेट ना हो, और वो आपके ट्रीटमेंट को, आपके प्लान को सब एक्सेप्ट करे और आपके बारे में हैप्पी फील करे. सर एक मिनट और लेंगे. अभी नेशनल यूथ डे था, वहाँ एक प्रोफेसर ही आए थे, नाम नहीं लेंगे हम, और नेशनल यूथ पुरस्कार प्राइम मिनिस्टर से रिवार्डेड है. ही इज ए प्रोफेसर. उन्होंने बोला कि हम संस्था का भी नाम नहीं लेंगे कि यहाँ की नर्सेस, उनका वर्थ 90% पेशेंट से रूड बिहेव करते. तो आपका बिहेवियर वो होना चाहिए जो कि पेशेंट को इमोशनली स्टेबलाइज करे, और जो आपका टेक्नोलॉजी है निश्चित रूप से आप डिलीवर करेंगे, उस पर कोई क्वेश्चन नहीं करता है. तो आपका इमोशनल नेचर वो हमेशा कांस्टेंट रहना चाहिए, भले ही आप किसी भी स्ट्रेस में हो, अपने पर्सनल या डिपार्टमेंटल या कोई. और लास्टली, कोई चीज़ करने की बात सर ने कही, ड्रीम करने की बात. तो ड्रीम हमेशा पॉजिटिव आदमी को देख करके, उनकी बातें सुन करके वहीं से आती है. और हमारे इस प्रोजेक्ट में ड्रीम करने का एक रीज़न सर है. सर मैं बता दूं, डॉक्टर एल सारंगी, जो भाभा के पहले जो रेलवे कैंसर इंस्टीट्यूट था उसके डायरेक्टर थे, वो हमको एक बार आके कहे, यार यहाँ पर ये बहुत प्रॉब्लम है बनारस में कि कोबाल्ट नहीं चल रहा है और हो नहीं पाता, बहुत दिक्कतें हैं, और हम किसी को कह नहीं पा रहे, तुमसे कहने आए हैं कि तुम कर सकते हो, इस चीज़ को विचार करो. और फिर सर का इनिशिएटिव था. सर ने डॉक्टर हुक्कू साहब, सर ने आप लोगों के डिपार्टमेंट के बहुत सीनियर प्रोफेसर हुक्कू सर से बोले, बात करा के कि इस पर विचार करो, कर लोगे. तो वो 2 पॉइंट थे जो हमको इंस्पायर्ड किए, क्योंकि हमसे सर का रिलेशन नहीं था, हम लोग एक एलुमनी रहे हैं, इस डिपार्टमेंट का रिलेशन नहीं था, लेकिन कहीं ना कहीं पेशेंट कंसर्न था कि ज़रूरत है और इसमें होना चाहिए, और वो चीज़ आगे बढ़ गई. और होते होते सब आप सभी पॉजिटिव लोग मिल रहे हो कि ये इस मुकाम पर पहुंच रहा है. और आगे AI आने वाला है, बहुत कुछ चेंज होगा, तो आपका इनोवेटिव माइंड हमेशा ओपन रहना चाहिए, एक्सेप्ट करें क्या डेवलपमेंट हो रहा है, उस पर स्टडी करें और जहाँ भी ज़रूरत है उसको स्किल प्रैक्टिस करें। इन्हीं शब्दों के साथ आप सभी डेलीगेट्स को मेरी तरफ से बहुत धन्यवाद कि आप सब ने थोड़ा इंटरेस्ट लेकर के इस टॉपिक में यहाँ पर आए हुए हो। ये आपकी बिगिनिंग है और आप एकदम निश्चित रूप से बहुत ही एडवांस आगे जो आ रहे हैं चैलेंजेस, स्किल, टेक्नोलॉजी, उसे एक्सेप्ट करते जाएंगे, उस दिन रियलाइज करेंगे दैट वाज द गुड बिगिनिंग। थैंक यू वेरी मच। थैंक यू वेरी मच।
Thank you so much, sir. I would like Dr. Ajit Singh, sir, President of ARTTI, to have some words.
Good afternoon to all and Happy New Year to all. Honorable Chief Guest, Dr. S. Pradhan, Director, MPMML HBC Varanasi. Guest of Honor, Dr. Ashutosh Mukherjee, HOD, MPMML HBC Varanasi. Dr. Sunil Chaudhary, HOD, Department of Oncology, IMS-BHU. Dr. S.K. Singh, Chairman, Apex Specialist Hospital and PGI. Patron and Organizing Chairman, Dr. Ankita Patel, Director, Apex Super Specialist Hospital and PGI. Organizing Secretary, ARTTI Conclave 2026, Dr. Rajiv Kumar Singh, Apex Super Specialist Hospital and PGI. I welcome to all in this ARTTI Conclave 2026. I am thankful to organizing committee and management of Apex Super Specialist Hospital and PGI. Sir, our association is collaborate with Easto, Portuguese and Bangladesh for assisting with the ARTTI for academic purpose. I always keep my support for any kind of academic activities for the development of RTT profession via CME और कॉन्फ्रेंस. सर, इसके बगैर पॉसिबल नहीं हुआ है. अगर आप हमें हमारी टीम को जो भी हमारी ARTT बैनर के अंडर करती है, अगर आप सबका सहयोग नहीं मिलता तो हम ये CME और ये कॉन्फ्रेंस को सक्सेसफुल नहीं कर पाते. आगे भी सर हमारा यही हमेशा आप सबसे निवेदन रहेगा कि सर आप जिस पदों पे बैठे हैं उस पे सर हमें हर एक उसके अंदर टीम वर्क के साथ लेके चलें, ताकि हम जो आने वाली टेक्नोलॉजी है उसको भी आगे बराबर से करके और देश के लिए जो कैंसर फैला हुआ है पूरे देश के अंदर, उसमें एक अच्छे नागरिक का और टेक्नोलॉजिस्ट थेरेपिस्ट का हम रोल अदा कर सकें. ये हमारा आप सबसे निवेदन होगा. और सर मैं ऐसा विश्वास दिलाता हूँ आपको कि मेरा टेक्नोलॉजिस्ट रेडियोथेरेपिस्ट एक ऐसा भी है जिसका 42 साल का एक्सपीरियंस है, एक ऐसा भी है जिसका 35 साल का एक्सपीरियंस है. उन्होंने कोबाल्ट और सीजियम से ट्रेनिंग लेके आज आपकी MR और प्रोटॉन तक पहुंच गए हैं और उसमें पूरी भागीदारी से और मरीजों का पूरा इलाज करते हैं. पर लेकिन साथियों, इस बात का आप सबको ज़्यादा ध्यान करना है, हमारी एडमिनिस्ट्रेशन की बजाय आप सबको ध्यान करना है कि हम जो पेशेंट को इलाज करते हैं वो हम ही डॉक्टर पेशेंट हमें ही कोई डॉक्टर समझता है कि वो 2 महीने तक आपके साथ लगा रहता है. और आपको सबसे पहले अपने बिहेवियर, डॉक्टर सिंह ने बताया, उस पर बिल्कुल हमें ध्यान करना होगा. और ऐसे हम आशा करते हैं हमारे सारे अच्छे से ही करते हैं, अगर कुछ है तो उसमें हम आगे सुधार करें, आगे बढ़ें उसमें. और नेक्स्ट association are work on the NACPH Act, National Commission for Allied Health Care Professional with Ministry of Health and Family Welfare, Government of India, न्यू दिल्ली। सर हम इस पे काम कर रहे हैं। साथियों निराश ना हो, एसोसिएशन हमेशा अपनी तरफ से काम करती है और सर हम एसोसिएशन के लिए हमेशा एक बात बोलते हैं, एसोसिएशन एक चीटी है और हमें तो सरकार से मिल के आगे करना है और सरकार की हमेशा मंशा ये रहती है अगर आप लोग आगे बढ़ के उस पर स्टेप पे आते हैं तो 32 स्टेटों में ये एलाइड हेल्थ बिल एक्ट जो पास हुआ है ये लागू हो जाएगा, जिससे कि सर ये हम आपको कहना चाहते हैं जिससे कि हमारा जो कोर्स सिलेबस नोमेनक्लेचर सभी एक प्लेटफॉर्म पे आ जाएगा, उससे अपग्रेडेशन और होगा। जो नई टेक्नोलॉजी से हम डट के मुकाबला करेंगे साथियों, करेंगे। यस, थैंक यू सर। रेडियोथेरेपी जो मैं 35 ईयर्स से करता आ रहा हूँ एम्स न्यू दिल्ली से सर, और हमने फादर ऑफ रेडियोथेरेपी एक नाम दिया प्रोफेसर जी के रथ सर को, जिन्होंने हमें हमेशा सिखाया कि टीम वर्क के साथ काम होता है और रेडियोथेरेपी एक टीम वर्क ही है। उस टीम वर्क के अंदर सबसे बड़ा जो उन्होंने हमें एक सिखा के गए कि अगर एक डिपार्टमेंट में कोई सेटअप के लिए पेशेंट आता है तो उसमें डॉक्टर, मेडिकल फिजिसिस्ट और सीनियर मोस्ट टेक्नोलॉजिस्ट जो सुपरवाइज करता है और जो ट्रीट करता है, वो चारों अवेलेबल होते हैं तब वो सर्टिफाई वेरीफाई होता है और उसके बाद ही इलाज शुरू होता है हमारे एम्स के अंदर। उन्होंने ये हमें सिखाया। तो ऐसे ही हम हर सेंटर पे सर करें, अगर टीम वर्क के साथ इस चीज़ को करे जाएं तो हम पेशेंट का ज़्यादा से ज़्यादा बेहतरी कर सकते हैं उसको। और सर ये टीम वर्क अगर वीकली या मंथली एक मीटिंग कंबाइंड तीनों ऑन्कोलॉजिस्ट, मेडिकल फिजिक्स और टेक्नोलॉजिस्ट के साथ अगर होती है तो उसमें सर बेटर ही होगा, बेटरमेंट आएगी हर चीज़ के लिए। अगर कभी भी इस चीज़ के लिए नहीं हमें पीछे हटना है कि हमें अगर ये नहीं पता तो पूछ लेना ज़रूरी है, और अगर ये चीज़ हमारे ऑन्कोलॉजिस्ट से या मेडिकल फिजिक्स से छूट गई है उसमें ये कह सकते हो सर मुझे ऐसा लगता है कि ये हो सकता है, तो वो आप बात अपनी रख सकते हैं। और जैसे कि सर हमारी सदियों पुरानी हमारे भारत की प्रथा रही है वासुदेव कुटुंब, जो कि अभी हमारे ऑनरेबल प्राइम मिनिस्टर ने G20 के अंदर समिट के अंदर लेके आए। द वर्ल्ड इज़ ए फैमिली वेयर ऑल हैव कम टुगेदर अंडर वन रूफ टू शेयर नॉलेज एंड एक्सपीरियंस। और सर यही नॉलेज और एक्सपीरियंस हम सब मिलके नेशनल और इंटरनेशनल लेवल पे सर हम कोशिश कर रहे हैं और आगे बढ़ रहे हैं सर। सर कहते हैं कि मिल ही जाएगी मंजिल, भटकते भटकते गुमराह तो वो हैं जो घर से निकले ही नहीं। साथियों आप तो घर से निकल चुके हो कोबाल्ट से और आज यहाँ तक पहुँच चुके हो, मंजिल मिलेगी और आगे बढ़ोगे आप। थैंक यू सो मच, बहुत बहुत धन्यवाद आप सबका।
थैंक यू सो मच सर। मैं चाहता हूँ कि डॉक्टर आशुतोष मुखर्जी सर आके कुछ हमारे लिए।
Thank you. Dr. Singh, Dr. Ankita, the organizing team here, the national organizing team and the local organizing team. So I would just take very less time. I'll start with Julius Caesar only. So Julius Caesar was as good as his Legio Hispana और Legio Gallia। मतलब जो उसके स्पेनिश और फ्रेंच सोल्जर्स का जो ग्रुप था उसके सबसे पुराने ग्रुप थे। एंड दीज वर द ट्रूप्स हु हेल्प्ड हिम कैप्चर रोम, डिफीट पॉम्पे जो इसके प्रतिद्वंदी थे, एंड दीज वर द ट्रूप्स हु एक्चुअली ओन्ड हिम। वो उसके तंबू में घुस के उनके साथ डिस्कस करते थे कि सर आगे ऐसे करना है हमें। सो उसी तरह रेडिएशन ऑन्कोलॉजिस्ट इज एज गुड एज हिज ओल्ड टीम, and it is you people that my patients see daily. So if you are great, it makes me great also. So as I said, we are all a team and my team is as good as everyone in it. Also in my institute we have a rite of passage of all the doctors. So all of them rag the doctors. As they enter the department for the first time, they rag the doctors. And the doctor has to earn the respect of our RTTs. So today, if they respect our doctors, that means our doctors have earned that respect. And that is how I feel also. Everywhere it should be. I mean, ragging is bad. I'm not promoting ragging. I'm just saying you have to earn the respect of everyone in your team. And everyone from up, down, right up, they have to respect each other. We have to all go together. And it makes me very happy to see this august body having such a good discussion here. I mean, I saw the topics. They were really thought-provoking. And as I say to all my fellow RTTs, the technologists, even the physicists, the interns, my PGs, keep asking questions. My people, they keep asking questions and I keep studying for that. I spend at least, I think I keep 1 hour a day for looking up new things because I know tomorrow they'll ask me something. So keep asking questions, keep everyone on a tight hook, but stay happy together. Our team is also one of the cricket giants in our institute. They keep winning the cricket tournaments and they have this bad complaint with me that I am not attending their matches. I'm sorry. I'll get in shape first for that. So thank you again for calling me, and it is very happy to see this August gathering and very happy to see this topics also being discussed. Thank you.
Thank you so much, sir. Thank you so much. Now I would like Dr. Sunil Chaudhary, sir, to give some good words to us. And
thank you, Dr. Rajiv. Dignitaries on the dais, off the dais, delegates, esteemed resource persons, students, ladies and gentlemen. I'm really humbled and overwhelmed for being invited as a guest of honor. Thank you so much. The topic that has been chosen for this conclave is very apt. We all do everything to achieve the best therapeutic ratio, and to achieve that we need to be very accurate and precise. These scientific events, they help us at improving ourselves, updating ourselves, and it's very important we keep on organizing such events. So I congratulate the entire organizing team, Apex, TMC, those who have come together to organize this event. And when you gather together, it's not just listening to the deliberations. It's coming together, listening with each other so that you collaborate for further advancements. And you are in the city, I can say it's a city of joy, where you can find some time going to the ghats, taking the boat ride and enjoying your evening. So thank you so much. Have a wonderful day ahead. Thank you.
thank you so much, sir. We are running late. And also we want to ask and request Dr. Gurvinder sir to have some word for us.
Good afternoon, dear all. I am honored to be the part of this inauguration. And after listening the thoughts of the dignitaries on the dais, Chief Guest Sir, Guest of Honor Sir, patrons, and the management of Apex Hospital, I am very much overwhelmed. The thought and honesty which is reflecting in their speech is very much helpful in encouraging the team of Radiation Oncology Department. and I think it is a Apex Hospital has done an excellent job for opening this continuing medical education first time in Uttar Pradesh. So I very much congratulate Apex Hospital for giving the floor to association, for sharing us and discussing for the patient benefit. Thank you very much.
Thank you so much, sir. Now I request organizing chairman, Dr. Ankita Patel, to have some word for us also.
Thank you, Rajiv. As we are running 1 hour late, so I'll wrap up in few words. I feel privileged to welcome you all the dignitaries, all the faculties, all the students, to holy city of Varanasi, to the most spiritual and historical city of Varanasi. I extend my warmest welcome to our chief guest, S. Pradhan sir, our guest of honor, Sunil sir, and Dr. Ashutosh Mukherjee sir, and entire head board of Association of Radiation Technologists of India, President, Chairperson, Chairman, Secretary, and entire Executive Council. Thank you for giving us opportunity and honor to organize this conference. And believe me, radiation technologists, they are the backbone of radiation oncology. With innovations, you are not only into implementation, you are equal partners in patient safety, quality assurance, all the innovations and implementation. Last but most important, I would like to thank entire RT of Varanasi, including all the institutes, guided, mentored by Rajiv and Kamal. Kamal is Secretary of North Zone. Great work done for their meticulous planning, implementation, and putting all their efforts. So kudos to you guys. I hope this conference is going to be a benchmark and a platform for academic and knowledge exchange, skill development, and interaction and motivation. So happy learning, a comfortable stay in Varanasi, and if you get time, 4 or 5 a.m. in the morning, do try to visit Ghats. All the best, and we invite you all for lunch.
Thank you so much, ma'am. Thank you so much. We are forwarding to a felicitation part. I request Dr. Ankita Patel, ma'am, to facilitate Dr. Ajit Singh, the ARTTI members. Excuse me, ma'am. One more is there. I would like Mr. Govinda sir on stage. Thank you, ma'am. Thank you, sir. Thank you so much, ma'am. I request Dr. Gaurav Goswami, sir, Senior Consultant, to felicitate General Secretary of ARTTI, Ashok Reddy ji. Okay, we'll go with the next part. Sir. Same thing, I will request Dr. Gaurav sir to felicitate Mr. Kamal Kaushik, Zonal Secretary of ARTTI. Thank you so much. Thank you so much. Now I am hand-overing my dais to sorry. Same thing. I request Dr. Gaurav sir to felicitate our scientific chairman, Mr. Manoj G. Pillai. हमारे बीच जनरल सेक्रेटरी ऑफ ARTTI अशोक रेड्डी जी बता रहे हैं. सो गौरव सर, once again kindly felicitate Mr. Ashok Reddy, General Secretary ARTTI. So on behalf of ARTTI, Mr. Dr. Ajit Singh and Mr. Gurvinder sir is
कमल कौशिक जी, आपसे निवेदन है कि हमारे ARTT की तरफ से जो मैम हमारे जो एपेक्स की मैनेजमेंट कमेटी है उसका जो हम सम्मान लेके आए हैं वो हमें देने का जरूर वो करें. जन सेक्रेटरी साहब आप और प्रधान जी, रेड्डी जी प्लीज़. प्लीज़ आए. हमें ARTT की तरफ से मैम का उनका सम्मान करते हैं हमारा मूवमेंट.
हम एज ARTTI नॉर्थ जोनल सेक्रेटरी, मैं शुक्रगुजार हूँ अपेक्स का कि उन्होंने हमें ये प्लेटफॉर्म दिया जहाँ पे इतना अच्छा एकेडमिक फीस्ट आज हुआ, और यहाँ से जो नॉलेज हम लोग लेके जाएंगे उससे हम लोग पर्सनली और प्रोफेशनली अपग्रेड करेंगे और कैंसर पेशेंट्स के लिए उसको समर्पित करेंगे. तो अभी मैं आग्रह करता हूँ डॉक्टर अजीत सिंह से, गुरविंदर सर से, अशोक सर से कि वो ऑनर करें डॉक्टर अंकिता पटेल को, जो कि ऑर्गेनाइजिंग चेयरमैन हैं इस फीस्ट की. मैम ने पूरी तरह से इस कार्यक्रम में सहयोग दिया है, और एक छोटी से छोटी चीज़ जो कि आपने बाहर भी देखा होगा कि सेल्फी पॉइंट बना हुआ है, वो मैम ने एकदम डिटेलिंग कि ऐसा होना चाहिए, ये होना चाहिए. तो मैम ने बहुत ज़्यादा डिटेलिंग पर ध्यान दिया है और काम किया है हमारे साथ. और पीछे से हमारे एपेक्स के चेयरमैन सर डॉक्टर SK सिंह सर खड़े रहे हैं सपोर्ट में कि किसी भी चीज़ की आपको ज़रूरत हो तो मेरे पास आओ. टाइम टू टाइम पूछते रहे हैं कि आपका क्या क्या काम हुआ, क्या नहीं हुआ, क्या आपको ज़रूरत है, कुछ रहा तो नहीं, कोई भी ज़रूरत है तो मुझे बताइए. तो मैं आग्रह करूँगा ARTTI की टीम से कि वो डॉक्टर SK सिंह को भी ऑनर करें. थैंक यू सो मच सर. थैंक यू सो मच. हम ऑनर करना चाहते हैं डायरेक्टर ऑफ अपेक्स डॉक्टर स्वरूप पटेल। सर अभी हैं नहीं, उनका भी बहुत सपोर्ट रहा। ये जो आप प्रोजेक्टर देख रहे हैं, कल तक इसकी स्थिति बहुत ख़राब थी, बहुत ख़राब थी, मतलब अलाइनमेंट इसका ख़राब था। सर आए सर ने एक एक चीज़ लोगों को डांटा, फटकारा, काम करवाया, ताकि जो कि मेन हमारा पर्पस है, हम एकेडमिक फीस्ट के लिए यहाँ पे हैं, तो जो प्रेजेंटेशन से टॉक है वो सबसे मेन है। तो वो पार्ट सर ने बहुत देखा और सहयोग किया। तो वी आर वांट टू ऑनर डॉक्टर स्वरूप पटेल। अगर उनके बिहाफ पे कोई ले, मैम, अंकिता मैम। हम लेट चल रहे हैं तो मैं अपने शब्दों को यहीं विराम देता हूं और मॉडरेट और अजीत सर को मंच देता हूं।
जब से हमारे कमल कौशिक की टीम ने ऑर्गेनाइजिंग ये टीम के साथ मिलके काम किया, वो आप सबके सामने है। और ARTT ने इन्हों को जब नॉर्थ जोनल सेक्रेटरी बनाया, मैडम मैं आपको बताना चाहता हूँ, सर आपको बताना चाहता हूँ कि नॉर्थ के अंदर अभी रेगुलरली एक मंथ में रंजन डे हमने सेलिब्रेट किया। बहुत सालों से नहीं हो रहा था, वो एम्स में हमने कोशिश की उसको। रंजन डे के बाद 27 दिसंबर के बाद अब हमारा 18 जनवरी को है। 18 जनवरी को आप लोगों के सहयोग से हो गया और नॉर्थ जोनल सेक्रेटरी की वजह से और राजीव जी की वजह से। और 22 फरवरी का शायद हमारे दिल्ली में फिर हो रहा है। 21 फरवरी को दिल्ली में होने जा रहा है। रविंदर जी कहाँ हैं? रविंदर जी कर रहे हैं हमारे। और एक रिक्वेस्ट हमारी पंजाब से भी आई है, फरीदकोट से, वो भी करना चाहते हैं। तो आपने एज ए जोनल सेक्रेटरी अच्छा काम किया, थैंक यू एंड थैंक यू टू ऑल।
आदरणीय मुख्य अतिथि महोदय, सम्माननीय अतिथिगण, सभी वरिष्ठ प्रोफेसर्स, वैज्ञानिक वक्तागण और मेरे प्रिय सहयोगी रेडिएशन प्रोफेशनल, आज कॉन्क्लेव 2026 की इस गौरवशाली मंच पर हम एक ऐसे क्षण के साक्षी बनने जा रहे हैं जो न केवल इस सम्मेलन को बल्कि रेडिएशन साइंस के इस शैक्षणिक इतिहास को भी समृद्ध करता है। आज हम एक अत्यंत उपयोगी, व्यवहारिक और समयानुकूल एकेडमिक कृति के विमोचन के लिए एकत्रित हुए हैं। पुस्तक का नाम है रेड एड। इस उत्कृष्ट एकेडमिक प्रयास के पीछे दो समर्पित विद्वानों की दूरदृष्टि और अनुभव निहित है। सर्वप्रथम डॉक्टर राजीव कुमार सिंह ऑन्कोलॉजी के क्षेत्र में सतत योगदान देने वाले विद्वान साबित हुए हैं, और दूसरे श्री सुब्रतो राय, जिनकी गहरी तकनीकी समझ और शैक्षिक स्पष्टता ने इस पुस्तक को व्यवहारिक और उपयोगकर्ता अनुकूल बनाया है। इन दोनों लेखकों ने अपने अनुभव को शब्दों में ढालकर पूरे रेडिएशन समुदाय को एक अमूल्य शैक्षिक उपहार दिया है। अब मैं विनम्र निवेदन करता हूं हमारे माननीय मुख्य अतिथि, सम्माननीय विशिष्ट अतिथि और पुस्तक के लेखकों से कि वे कृपया मंच पर आएं और पुस्तक के अनौपचारिक विमोचन को प्रारंभ करें। देवी और सज्जनों, जैसी यह पुस्तक आज विमोचित हुई है, यह केवल कागज़ पर छपी एक कृति नहीं बल्कि ज्ञान, सटीकता और रोगी सुरक्षा की संकल्प बन गई है। काशी ज्ञान की इस प्राचीन नगरी में इस पुस्तक का विमोचन होना अपने आप में एक प्रतीक है। जहाँ वेदों ने शब्दों को शक्ति दी, वहीं आज विज्ञान ने शब्दों को जीवन दे रहा है। हम हृदय से धन्यवाद देते हैं डॉक्टर राजीव कुमार सिंह और सुब्रतो राय को। अब हम डॉक्टर राजीव कुमार सिंह को आमंत्रित करते हैं कि वो श्री सुब्रतो राय को एक मोमेंटो देके उन्हें धन्यवाद ज्ञापित करें। मिस्टर सुब्रतो राय से अनुरोध है कि वे मंच पे आएं और कुछ शब्दों से इस बारे में अपने विचार प्रकट करें।
I am very grateful to all of you and for this honor and जो बुक हम लोगों ने लिखा है ये 2.5 साल का जो अक्लांत परिश्रम हम दोनों ने किए है और हमारे जो कॉमन विजन्स थे वो बुक के बारे में वो हम उसमें करने के लिए कोशिश किए हैं। आगे के दिन में भी हम जारी रखेंगे, कुछ ऐसे इनोवेटिव चीज़ें करते रहे, एकेडमिक चीज़ें जो रेडिएशन थेरेपिस्ट फील्ड में उन्नति को बरकरार रखे। थैंक यू एवरीवन।
कॉन्क्लेव में अब लंच का टाइम आ चुका है जो दिमाग को रिफ्रेश करता है। बिना इसके अगले सत्र में डोज कम लगेगा। सो वी ऑन मूव नाउ फॉर लंच। आराम से तरोताज़ा होकर लौटो। लंच का समय आधे घंटे निर्धारित किया गया है। सो अगला सत्र हम 2:15 पे प्रारंभ करेंगे।
गुड आफ्टरनून एवरीवन। फिल्म की इस महफिल में आपका स्वागत है, जहां अनुभव बोलता है और विज्ञान मुस्कुराता है। आदरणीय अतिथिगण, सम्मानित चेयरपर्सन, माननीय स्पीकर और मेरे सभी सहयोगी एवं श्रोताओं, आप सभी का इस कॉन्क्लेव में फिर से एक बार स्वागत है। और आज के ऐतिहासिक ज्ञानवर्धक कार्यक्रम में होने वाले सत्र में एंकर के रूप में उपस्थित होना मेरे लिए गर्व और सम्मान की बात है। सीखना अगर रुक जाए तो हुनर थम जाता है और सीएमई वही मंच है जहाँ प्रोफेशन बिखर जाता है। देवी और सज्जनों, अब हम आगे बढ़ते हैं सेशन 3 की ओर। तो आइए जोरदार तालियों के साथ स्वागत करते हैं अगले चेयरपर्सन का, डॉक्टर मुकेश जैन, चीफ रेडिएशन थेरेपिस्ट, एकेडमिक इंचार्ज, AHP SMS जयपुर, एंड डॉक्टर नेहा गुप्ता, HOD रेडिएशन ऑन्कोलॉजी, अपेक्स सुपर स्पेशलिटी हॉस्पिटल PGI वाराणसी, एवं मिस्टर नरेंद्र वत्स, सीनियर मेडिकल फिजिसिस्ट, MP MMCC एंड HPCH वाराणसी। कृपया जोरदार तालियों के साथ स्वागत करें सटीकता के इन सुपर हीरोज का। मैं स्टेज पर स्वागत करती हूँ इस सेशन के स्पीकर का, मिस्टर फायक अहमद, CECT बोलस ट्रैकिंग इन रेडियोथेरेपी सिमुलेशन पर अपना प्रेजेंटेशन व्याख्यान देने के लिए आमंत्रित करती हूँ। कृपया करके जोरदार तालियों के साथ स्वागत करें।
Today I will be talking about contrast enhanced CT bolus tracking in radiotherapy simulation. So what is contrast enhanced CT? As we all know, contrast enhanced CT simulation is routinely used in radiotherapy to clearly differentiate the tumors from surrounding normal tissues. By enhancing blood vessels by highly vascular structures, contrast helps us in accurate delineation of GTV and CTV. Overall, it helps to reduce geographical miss and improves overall treatment accuracy. Generally, for CT simulation, we use iodinated IV contrast agents, and in our institute, we use iohexol. IV contrast we use is iohexol. So, simulating perfectly every time is our goal, irrespective of the flow rate and the IV contrast volume. We use generally in cancer patients we use slow flow rate in cancer patients because of the chemotherapy. Can weaken veins, making them fragile and prone to leakage. Also, due to which we use a small gauge cannula. Therefore, a slow flow rate is chosen to avoid extravasation, pain, and vein injury. Second is less contrast. The amount of contrast generally we use is less because of the compromised renal function due to the chemotherapy or dehydration, and also the poor general condition of the patient. So, giving high volume iodinated contrast can increase the risk of contrast-induced nephropathy. So, why bolus tracking? Basically, bolus tracking is an automatic technique which are used at time of CT scan exactly when the injected contrast agent reaches a specific blood vessel and triggers the scan at perfect time for optimal enhancement. While performing CT bolus tracking, the basic formula in general we use is general formula for deciding the contrast volume is body weight into dose. The dose is generally between 1 to 2 ml per kg. But in our institute we use based on the BMI body mass index. If the BMI is in the normal range, then we give a maximum up to 50 ml of contrast. And if the patient weighs more than 50 kg, if the patient is below 50 kg, then we can achieve the better contrast enhanced image at up to 35 to 40 ml. So this is the typical workflow for triphasic scan. First we set up the patient, position the patient on the simulator couch in their treatment position, either by using the backlogs or the thermoplastic task. We use the IV contrast injector machine. And the placement of the ROI is very much important for bolus tracking. Because at that place the low dose monitoring scan, because the machine takes every 1 to 2 seconds a low dose monitoring scan, where we fix the HU. In general condition we fix the HU at 100, where the machine auto triggers the scan after achieving the HU value. So the monitoring and triggering, the scanner repeatedly takes low dose snapshot at the monitoring level. It plots the time attenuation curve in real time, showing the HU value inside the region of interest as contrast arrives. Once the attenuation within ROI reaches the preset threshold, it confirms the strong contrast bolus has arrived. Automatic scan, whenever when the HU is achieved during the contrast, when the contrast is pushed, then the automatic scan it auto triggers the scan, and typically the scan delay is 3 to 5 seconds. This delay allows the contrast to fully perfuse the target organ after it has passed through the major artery being monitored. Basically, bolus tracking is more beneficial for GI or GI cases like gallbladder and liver. This is the process in our institute for doing the performing the bolus tracking. After registration, the patient for triphasic scan. After registration, the patient we have the preset protocol every multi-phase for triphasic scan. Then we add the bolus tracking by clicking on the arterial phase on the right side. Then we add bolus tracking. As you can see, the bolus tracking is there. So in pre-monitoring, then after confirming the bolus tracking, then we set pre-monitoring. Pre-monitoring is the area where we decide where the region of interest should be there. So in pre-monitoring, we decide the area where we have to take a single scan. So for head and neck cases, in generally we use T5 T6 junction. For thoracic T3 T4, and for liver T11 T12 junction. For gynae L2 L3 junction. We select the ROI. For triphasic scan, there are a few things that are very much important. First, setting up the HU. Because setting the proper HU, as we all know, while pushing the contrast, the HU increases, then it decreases. So setting the HU to auto trigger the scan is very much important. And the second part is the monitoring delay. As the machine defaults in default setting, the monitoring starts after 10 seconds. So again, after performing the scans, we know that the HU will not be achieved till 20 to 30 seconds. So we change the monitoring delay. We increase the time of the monitoring from up to 20 seconds or 25 seconds. For triphasic scan, the arterial phase auto triggers as after the HU is achieved. And then we keep the portal phase 20-25 seconds delay after the completion of the arterial phase. The venous or delayed phase is 70 to 80 seconds after the completion of the portal phase. So this is for the arterial phase. This is the portal phase. This is the venous phase. So why bolus tracking is important? Accurate timing ensures scanning start at peak vascular enhancement, no guesswork, independent of flow rate. Patient to patient variation, accounts of difference in cardiac output, age or IV flow. better image quality, optimal vessel ossification and tumor contrast, dose efficiency, avoids need for extra repeat scans due to poor timing. Conclusion. Bolus tracking ensures that CT scanner starts capturing images at just the right moment when contrast is brightest in the area of interest. In radiotherapy CT simulation, where precision is essential, bolus tracking bridges diagnostic imaging and treatment planning. By individualizing contrast timing for each patient, it provides optimal soft tissue contrast without compromising dose calculation accuracy. By capturing images during peak vascular enhancement, bolus tracking improves target delineation and contributes to more precise treatment planning. Ultimately, radiotherapy demands precision. It depends on safety and it carries responsibility. Thank you.
What is the role of flow rate while doing bolus tracking and amount of contrast?
The basic bolus tracking importance is that's what basically bolus tracking में हमें वो वॉल्यूम जो कॉन्ट्रास्ट वॉल्यूम हम पेशेंट के लिए यूज करते हैं वो हम कम कॉन्ट्रास्ट में अचीव कर सके, बेसिकली वो इम्पोर्टेंट है बोलस ट्रैकिंग का. अगर हम नॉर्मली अगर कॉन्ट्रास्ट का जो हम फॉर्मूले के हिसाब से निकालें तो पेशेंट वेट के हिसाब से देंगे. अगर पेशेंट वेट करता है 80 kg के अराउंड, अगर उससे क्रेटिन भी ठीक है, पर हम वही सेम चीज़ अगर हम कम कॉन्ट्रास्ट के दे के भी कर सकते हैं ताकि क्योंकि फ्यूचर में उसको आगे कोई प्रॉब्लम ना हो, तो कॉन्ट्रास्ट इंड्यूस नेफ्रोपैथी की वजह से, इसी वजह से हम वो वॉल्यूम भी कम सेलेक्ट करते हैं और उस कम वॉल्यूम की वजह से वो हम चाहें कि वो सेम इफिशिएंसी कॉन्ट्रास्ट का वो स्कैन ले सके जो हम वो हाई वॉल्यूम ऑफ कॉन्ट्रास्ट देते हैं. हाउ टू अचीव वैल्यू इनिशियली तो हमने पहले डायग्नोस्टिक वाले जो थे उनसे पहले हमने पूछा, फिर वो जब हमने एक्सपेरिमेंट जब हम कर रहे थे प्रैक्टिकली तो फिर धीमे धीमे हमें वो पता चला. तब हर डिजीज़ के लिए फिर हमने मतलब हर साइट्स के लिए DMG वाइज फिर हमने वो डिसाइड किया कि किसमें कितना रखना चाहिए ताकि फिर हम ऑप्टिमल जो हम स्कैन है वो ले सकें. बोलस ट्रैकिंग बेसिकली सबसे बेनिफिशियल तो ट्राइफेजिक मतलब लीवर और जीबी के लिए है, पर हम चाहे तो किसी में भी कर सकते हैं. हेडेनिक केसेस हो या थोरेसिक इशूज, लंग, लीवर, किसी में गायनी पेशेंट किसी में वो डिपेंड करता है. अगर हमें जैसे किसी पेशेंट का होता है जैसे एज एन एग्जांपल मैं यूज़ करना चाहूँगा, एक पेशेंट थे हमारे जो थोरैक्स पेशेंट थे वो उनका काफ़ी एजेड थे, तो उनका हमने फ्लो रेट नॉर्मल हम जैसे 1.2 1.3 रखते थे, पर वो 1.3 में भी वो पेशेंट बेयर नहीं कर पा रहा था, तो इसकी वजह से हमने फ्लो रेट रखा 0.9 के आसपास, जिसमें एटलीस्ट जो पेशेंट रहा कि ड्यूरिंग स्टिमुलेशन वो एटलीस्ट स्मूथली लेटे रहे, मूवे नहीं. तो इसकी वजह से अब जैसे ये अलग सिचुएशन है जिसमें हम फ्लो रेट कम रख सकते हैं, पर प्रॉब्लम ये आती है कि अगर हम फ्लो रेट कम रखते हैं तो स्कैन हम कितने देर पर डिले ले या नहीं ले. बोलस चेकिंग का यही पार्ट है कि हमें वो चीज़ से इंडिपेंडेंट कर देता है कि अगर हम 0.9 भी फ्लो रेट दे रहे हैं या 1.5 भी दे रहे हैं तो वो कब लेना है वो ऑटोमेटिक HQ से डिसाइड करके वो स्कैन ऑटो ट्रिगर हो जाएगा, तो वो उस पार्ट से हमें इंडिपेंडेंट कर देता है. इन जनरल जो डिपार्टमेंट मतलब जो हॉस्पिटल में हमारे यूज़ होता है वो 22 नंबर्स का रहता है, तो वो उसके वजह से ही हम ज़्यादा फ्लो रेट नहीं रख सकते, उसका एक लिमिट है उसी वजह से. थैंक यू.
एक क्वेश्चन है कि आपने पैंक्रियाज का बाइप्सी किया सेम ट्रिगर करके आपने
पैंक्रियाज के लिए. हाँ सर, वो इसमें स्पेशली पैंक्रियाज कह के तो नहीं किया, पर लीवर के केसेस में हमने जो ट्राइफेजिक का था वो किया भी ऐसा नहीं था.
धन्यवाद मिस्टर फायक अहमद, आपने हमें बताया कि कैसे ट्यूमर को वेस्कुलर मैप से ट्रैक करना IGRT से भी ज़्यादा कूल है. लंच ने सबको थोड़ा स्लो कर दिया, कुर्सी ने मानो हमसे वादा ले लिया, पर अब नींद को बाहर का रास्ता दिखाते हैं और ज्ञान के सेशन को जोरदार बनाते हैं. मैं इसी के साथ अगले स्पीकर्स को आमंत्रित करती हूँ मिस्टर सुमित शर्मा, चीफ रेडिएशन थेरेपिस्ट, SCG अहमदाबाद, इवोल्यूशन ऑफ SRS पर अपना प्रेजेंटेशन व्याख्यान देने के लिए आमंत्रित करती हूँ। कृपया जोरदार तालियों के साथ स्वागत करें।
Very good afternoon, everyone. I hope everyone is awake, or if you want me to start my presentation with any joke, so I'm ready for that also, because from since morning I'm listening so many presentations, and you must be feeling bored. Otherwise, I'll start my presentation right now. So I'll not waste my time for introduction because they have already given a wonderful introduction. Thank you. And first of all, before I start my presentation, I would like to say thanks Dr. Rajiv, Mr. Kamal Kaushik, and entire Apex Hospital family for inviting me here as a guest speaker, and definitely I will try to justify my place here. And once again, very good afternoon everyone. This is Sumit Sharma, and we are going to talk about evolution of stereotactic radiosurgery, because today our theme is precision and practice. So whenever we'll think about precision and practice, first thing come in our mind is SRS, SRT, and SBAT. Sir, this is not any study, but this is a general topic I wanted to share with all the therapists, because I feel my technologists, my juniors, and my colleagues are somewhere lacking in some things. So that's why I'm highlighting this topic today. And because it's a patient care, so that definitely I have think about patient care as well, and how we can make patient more comfortable and how we can give the best care to the patient. So as we all know that the gradual development is something called evolution. The same evolution we are going to talk about in SRS and SRT. So whenever we will talk about any technology, any big things, sometimes we forgot the basic, what is radiotaxi, from where it comes, and who invented. Sometimes whenever we'll thinking about very big things, but basics we are losing. So that's why I have covered these things, that the word stereotactics is derived from, it came from the Greek word. The word stereo meaning the solid or three dimension, and the Latin text meaning is to touch. The meaning of is thus the term literally means a three-dimensional arrangement to touch. And this is a Dr. Leclerc Shell, sir, and he given the definition: a single high dose of radiation stereotactically directed to an intracranial region in interest may be from X-rays, gamma rays, protons, or any heavy particle. But nowadays what we are following is that is a high dose of ablative radiation delivered to a target localized in 3 dimension with overall end-to-end precision and order to the 1 to 2 mm delivered over 1 to 5 fractions. So this is just basic. I'm not going in a detail in this thing, when he invented this the SRS, and when he performed in 1968 he performed the first gamma knife, and in LINAC we have treated in 1980s, and we have a very senior sir from AIMS Hospital, Ajit sir. So maybe he was the evidence of this, that India has started SRS and SRT on 27th May 1997. So why we are discussing about SRS and SRT? Because whenever we'll treat any cancer patients, we will see the 90% of the cases is malignant. But whenever we'll talk about the SRS, SRT, any cranial disease, so we are treating the malignant and non-malignant tumor as well. So that's why this is very important to understand the importance of accuracy, patient comfort, and so this is a routine workflow. So what we used to follow for every cases, nothing is different, but we have to be more precise and more accurate when we are dealing with the SRS and SRT, because as we all know, we are dealing with the high dose radiation in a less fractions. So this is a various way to deliver SRS and SRT. What is the purpose of showing all this technique? Because I'm not talking in any particular one topic or one study, but I'm going to talk about all SRS and SRT, and why this I have chosen this thing, because I have seen in many students and in my career that if I'm working with a particular machine, so I will be aware about that machine only. But we are a radiation therapist, and as a radiation therapist, we and you should all be aware with all the technologies, what machines, about the machines. If you have not worked, it does not mean that you should not have an idea on this. You can go through the literature, you can attend the CMEN conference, because in my personal experience I will tell you that I have never worked with proton therapy, I have never worked with radio cyber knife, but still as today right now from last 1 year I'm seeing the presentation from MR Linek. I have not worked in MR Linac also, but still I'm taking interest in all technology because it's a radiotherapy equipment. And I cannot say that because I'm not working and my institute don't have this machine, so I should not have a knowledge about this machine and technology. So that's why I will go. I'm not going in a very deep because you may get confusion, but we should understand how evolution came and from which machine we are treating most of the cases for SRS and SRT. So we'll start with this leg shell gamma knife. This is a dummy pictures of gamma knife, and you can see very clearly that how it is. Because if I'll explain each and everything, so I think 15 minutes is not enough for me to explain all the technology. So this is a evolution in gamma knife machine. They have you can see the A, B, C, and D model are there, and in one model 179 cobalt 60 sources rectangular collimator. In model B you can see the simpler sources changes, and U gamma knife is 201 cobalt 60 sources cone collimator. In model C it's allow 3D planning. When we were started stereotactic SRS and SRT in gamma knife, so first disadvantage we used to share with everyone that they don't have an imaging system. We have to treat without imaging, but now in the newer technology, now the imaging also possible in gamma knife. Because I was not aware this because we don't have this machine. But when I go through the literature, I have seen, oh, right now the technology came and now we can even treat with the imaging system. So this thing's a difference, this is a difference. If you go through the literature, if you will study, if you will attend some seminar, then only you can come to know about your things. So this is another upgradation of gamma knife machine, and this is a head upgradation. And one more machine, this is the second machine I'm going to talk about. This is tomotherapy. As we all know, tomotherapy rapidly rotates the beams around the patients and inside the housing of unit, thus allowing the beam and enter the patients from many different angles in succession. See, we have this machine in my institute. We have a true beam and we have a tomotherapy both. But whenever we will talk about the SRS and SRT, first my doctors and my preference first is with a Linac machine. Why? Because now tomotherapy also upgraded much, and you can take a KV CBCT with this tomotherapy machine, and treatment time also reduced much, and even the imaging time also they have reduced. But if you will compare with the SRS, if you wanted to realign 2 or 3 times patients, so it is very difficult to take direct MVCBCT, and if you want a good quality CBCT, it will take much time. And we we have to finish our presentation on our treatment on time. So that's why we don't prefer this, and it just take little much time compared to. And another machine is a cyber knife, and this is a very good tool to treat SRS, SBRT machines, SRS and SRT treatment, because few machines, what we were talking about the gamma knife, but gamma knife have a limitation to treat only cranial RT. You cannot treat SBRT in gamma knife, but this machine allows to treat you even a breath hold technique, intrafaction movement you can track and everything. So because of the lack of availability in India, this machine you cannot find in every city, or everyone cannot afford. And as per the literature, I have seen that only 1% of Indians can afford the treatment in this machine. So, but if you can, if someone can, so this is very good. It gives the more than 110 beams angle to treat accurately patients. This is a proton therapy. You have heard about Dhurandhar movie? One Step, Instagram, Dhurandhar. So this is about Dhurandhar. So everyone is talking about, everyone wants to work with Dhurandhar, and but maybe you have, if you will go in deep, so does it really required for every SRS and SRT? Do you think? Ashok sir and Mano sir definitely will say that every patient needs radiotherapy, but I will say no. Sorry. If you are treating a tumor which is less than 1 centimeter, if you are treating a tumor which is far away from the critical structure, you don't need proton therapy. I don't say no need, but the photon also works same, because the limitations are there if you are treating less than 1 centimeter tumor. And why Mano sir is laughing? Because as I told you, I have not worked with many machines, but when I go through the lecture and I have any confusion, I used to call him. I called 2 person for different machine. You are working there, so how you are treating? Tell me how you can do it. So sir, आपकी जाल में मैं आपको फंसा रहा हूँ, sorry. So the thing is that if you are treating optic chiasma, optic nerve, the tumor which is very near to the brainstem, that time you can say the proton is required for that patient, because the property of proton therapy And if you are aware with this brake pick, I'm not gonna going in a detail, otherwise they both will catch me. So there is no exit dose, so it is perfectly safe for the SRS sensitivity which is near to the, but the efficacy is same for proton and photon. The efficacy for proton, again I'm repeating this word because if tumor is more than 1 centimeter and it is far away from the critical structure, so you can treat better, not better but equally correct with the photon as well. And there is a huge difference between proton and photon because it's a very cost effective. Photon is a cost effective, easily available, and many of patients can afford the photon treatment but not in proton. So we have discussed about the all the technologies. So this is the evolution of this, all the equipments, how they have started and they have evolved, and this is the LINAC evolutions. We can see in the pictures how they have evolved, because when we were treating with when the Novalis came in the picture, so we were more confident because we got a very good imaging quality. And if you wanted to treat non-coplanar, so that non-coplanar also you can do the imaging laterally, and you can verify whether you have done the correct rotation or not. So the imaging, I would say imaging give us a confidence, technology give us the confidence to treat SRS in a better way. And when this triple F came, so they have drastically reduced the treatment time and image quality improved, and you can even track the tumor if you are not treating SRS. For SBIT it is better. So we have discussed about all the technology, all the machines and everything. I have one more thing added here in a ZEPEX. If you are aware with the ZEPEX is the most advanced technology for cranial RT. But why people are not preferring that cranial machine? Why it is not easily available? Because the same way, like gamma knife, you can treat only cranial RT in that machine, and it is not easily available. Otherwise, that is also I have added that. I'll show in next slide. So this apart from the various technology, let's discuss about the LINAC based SRS and SRT. So how many of you are doing SRS with frame still? Can you please raise your hand if your institute still you are doing SRS and SRT frame based? Nobody. That's good. So I have seen it. I won't say a name, but I have seen that still people are doing frame based SRS and SRT. And in my personal experience, I have done SRS frame based SRS in 2011. I was in Apollo Hospital, Ahmedabad. Then I have seen during treatment, one patient vomited during the treatment. So sir, it was very difficult to remove patient immediately, because if patient swallow the vomiting and it can go in the breathing tract also, that was a very difficult part for us. So that's why we thought that if we can treat this patient without frame, so it will be very, very good. So now technology and this evolution gave us the opportunity to treat patient as equal as perfectly and correctly without frame. So here we will discuss about workflow of radiosurgery frame based and frameless. And when we'll talk about the frameless, most over the things will be the remain same. Only the two things will different, which is very, very important, is the rigid fixation in head. So that was a very pathetic part for the patient point of view. Other all things are equally. But if you will talk about the frameless SRS, so all procedure maybe will be same, but this is a non-invasive fixation, and it is very easy to treat. And even if you wanted to realign patient 2 or 3 times, you can do very easily, and it is a fantastic for the patients as per personal experience. So this is about the stereotactic frame. Is based on the rigid connection of the stereotactic frame of the patient during CT and MRI angiography imaging. And this is the properties of frame, how they are fixing. I'm not going in a detail, otherwise it will be gonna late. And this is a type of frame. You should understand how many types of frame is available. This is a BRV frame, CRV frame, leg shell system, and brain lab system. So these are the different, and they have invented if you will see, so that how they have worked and how they have clinically worked for the SRS. And this was the fixation what I was talking about, that I have worked with. Then the prior craniotomy has to be done if you are doing frame based SRS, and neurosurgeon will come and he will fix the, and I have seen patient have to be NBM before the treatment and after treatment also. So this was a very, very long journey for the patient if they are treating taking treatment in frame-based SRS. So, but when you will treat with the frameless, nothing is there. So this is the type of frame, and this is the screw was I was talking about, the what neurosurgeon used to fix in the brain side. And these are the different things. But there are some pitfall and variation in ring, that like failure in image to top for the head, failure to image the target, pin artifact, the large head, and as I said, prior craneectomy has to be done by the neuro surgeon. So after that, this cone came, the conical cone collimator, better for the spherical and overall target sharp. It gets you get a sharp penumbra with this. But there is some certain, you will get the very less margin for the gantry rotation. You will get the very less means gantry rotation and all. You will get a very few. If you have treated patient with this this cone, then you can understand. Then it is very difficult to see the clearance, whether there is a clearance or not. So these are the frame, and if you are treating with the MLCs, you can change the shape anytime. But if you have chosen the cone, so if you have chosen a 5 mm or 1 centimeter cone, it will be stick with the 1 mm. Even there is no requirement in some going anti-rotation, but there will be there. So this is the planning of. And then when MLC came in the picture, when MLC came in the market, so the use of this cone was reduced. And I am the witness, because I have treated in cone also and without cone. So now we are treating, and this is now MMLC came in a picture, and they given a very good opportunity to treat without. So there is a few comparison between X knife and gamma knife, and I'm not going into detail. And this is the target localizations. So this is the nomenclatures of frame based and versus frameless stereotactic body radiation therapy. And this is my patient who is telling in Western style, he's telling no to the frame. You can see his symbol is Western style. He's refusing the frame for the treatment. So what is the advantage of frameless radiosurgery? It enhances the patient comfort, non-invasive frame, no swelling or bruises, reduce claustrophobia, no pressure to treat patient, because sometimes a patient is not comfortable but frame is fixed, so you have to treat patient even in afternoon or in evening time, but there is no pressure if there is no flow. So this is our treatment planning, and this is a dose prescription, and this may change as per the size of the tumor and location of the tumor. And if you are treating SRS SRT, then definitely you should aware how was the how was the response. So my oncologist shown me this picture. It gives the confidence that we are treating in a right way. So you can see the one I have for my personal interest. I put this picture here. So the conclusion was frameless radiosurgery is crucial as a frame based. Additional of real-time imaging further increase the accuracy of frameless radiosurgery. From no image to image guided, frame based to frameless, cone based to MMLC, and manual rotation to 6D couch. And this is not only my personal experience, but I have seen that, as I told you, that I have gone through the many literature, and they also saying in conclusion that in our experience, setup accuracy of frameless SRS good as frame-based SRS within ability of verification methods such as CBCT and hexapod couch, and accurate the precise treatment delivery is with the frameless technique. And one more paper I gone through, which is published in India only in Medanta, and they are also giving the same answer for this. So thank you so much for listening me, and once again thank you.
Thank you, Sunitji, for an excellent talk. And definitely, the concern about the evolution of SRS, you told about how the technology gradually changed. So evolution, I think that doesn't mean the replacement of the earlier existing system. It's a gradual improvement towards the technology, towards the competency of the persons holding the technology. So it emphasizes on the advancement of the technology, also brings the challenges for the executors to apply this technology. So I think there is concern you told about the or the 3D or might be the earlier cobalt one also. So they all are gradual improvement and maybe I think that it should be complementary to each other. How we need to add our skills gradually with the technology.
Sir, in my presentation, I always say one, जिसने मेरा presentation पहले भी बार देखा होगा, पहले भी देखा होगा, सुना होगा, that technology is like a knife. It's very important to have it, but you should know how to handle it. Otherwise, you can injure. Knife में तो आप खुद को injure करेंगे, but यहाँ पे आप patient को injure करें, which is very crucial part. So technology is very good, but you should understand how to handle it. Thank you so much, sir. Thank you once again.
One question.
See, still we don't have that much evidence whether we can treat, because there will be always intrafraction movement will be there for patient. So we have to study on this. Till now, no. I would say if you are treating this much crucial treatment, very small target, you should not treat without any immunization. Immunization is very important, because actually they have uploaded my old presentation. That's why otherwise I put a very good picture of present immunization and frame less how we can do very easy and in a good way. Patient will be comfort. Time is very, because nowadays आप जितना कम accessories use करेंगे, जितना simple उसको रखेंगे, patient उतना comfortable रहेगा, and it is very easy to reproduce. Because I have seen in so many centers they are using so many things, but they are not able to reproduce, and it is taking too much time. And nowadays everybody wants to treat 100 patients a day, so it is difficult.
Any other questions? So thank you so much.
Thank you so much.
Excellent and wonderful talk.
धन्यवाद सर। आपने हमें बताया कि एसआरएस ने सर्जरी को कहा बाय बाय, अब सिर्फ बीम्स राज करते हैं। सफ़ेद कोट में छुपा है हौसलों का आसमान, सफ़ेद कोट में छुपा है हौसलों का आसमान, हर दिन जिंदगी से होती है इनकी पहचान, थकते नहीं झुकते नहीं यही इनकी शान है, इलाज से पहले इंसानियत ही इनकी जान है, इंसानियत ही इनकी जान है। आइए इसी के साथ हम अपने अगले स्पीकर को स्टेज पर आमंत्रित करते हैं। मिस्टर अशोक रेड्डी, लेड रेडिएशन थेरेपिस्ट, अपोलो प्रोटॉन सेंटर, प्रोटॉन थेरेपी वर्सेस ट्रेडिशनल रेडियोथेरेपी पर अपना प्रेजेंटेशन व्याख्यान देने के लिए मंच पर आमंत्रित करती हूँ। कृपया जोरदार तालियों के साथ स्वागत करें।
Thank you, everyone. Actually, in the last moment, the topic has been changed since morning. We're talking about the preciseness and everything related to the therapist upgradations and quality improvements and everything. So I thought like I'll jump into the proton. So I just want to give a little brief about the proton. Why? Because in the upcoming future, maybe in India, there are a lot of centers is going to come up. So if we have some little idea about the protons, I think that will help each and everyone in the audience. So in that base, I just changed my topic into the proton. And thanks to the Apex team and thanks to the chairpersons to have me on the stage. So my topic is like proton therapy versus traditional radiation therapy expertise and the key considerations as a radiation therapist perspective. So the evolution, like since morning we are talking about the 2D to 3D, 3D to 4D from the MR Linac and the different changes in our modern technology what we used in early 1980s and what we are using today. So even my career started with a Cobalt 60 machine down the line in the 2004, 2005 in that time. So now I'm working in the proton therapy. So I crossed all the bridges and all the barriers. So presently I'm sitting in a proton right now. So I think after proton, I don't know what to expect for the future upgradations. Maybe carbon, but I don't think so. That will be there. I think I don't know that it's not going to happen before my retirement. So like everyone will have that assumptions in our own heart. Even it's happened to me as well before I went to a proton interview. So I just was everyone will have some own assumptions like okay, the car might be like that, this will be like that, so they do like this, they do like that. So even I have also had the same perceptions like the before training, like the proton is maybe super selective patients. We can't treat about all the patients, and it's only used for the hyperfractionation, just like in a cyber knife. But no, the low volume tumors, no, we are treating very high volume tumors. As Sumit said, the low volume tumors, we little bit think about it, how to either we to treat or not to treat. So at the same time, I thought like it will have the MMLCs, MLCs, other like usually we have the 0.3 MLCs. I thought like it had the 1 mm MLCs. So in that way, but there is no any MLC concept, or there is no any such kind of blocking or other concept in the proton therapy. So especially like explain in the easier way, like when your Diwali time, so you use them as rocket. So when you're just firing up the rocket, so it takes a minimal energy to reach when its destination. So when it reaches the destination, so it will deposit that complete, and it will give the high light over there, right? So this is like bombardment of that particular spot the same way. So it's a simple concept of that way. I just wanted to make you understand. So as compared with a photon, like when you have the photon, so if you're at the same time as that you use MLCs, MMLCs, and any kind of immobilizations or anything, there will be some exit dose where we can't able to control when you are treating with a 6 MeV or 15 or 12 or whatever other MVs. So, but when it comes to the proton, so the entry dose, as I explained before, so entry dose is less, and the deposition of the bragg peak, it will be very high. So I'll explain in my coming slides. So the entrance, so the dose. So the side effects may be results from the coincidence of the radiation to the normal healthy tissues. No dose equal to no toxicities, but there is some toxicities we see in the proton. Not might be in immediate manner, maybe after finishing of the half of the treatment. So we do see the toxicity, but the potential impact is less short toxicities as compared with the photon. But short, precise dose delivery reduce incidence of second cancers, and patient friendly, improve survival and improve quality of lives. As we've gone through few literatures where they are started in early stages of the proton treatments in somewhere in eastern countries and western countries. So according to that data, so the toxicities and the survival rate was a little bit higher side as compared with the photon. So again, the mass of electron is very lighter, but when it comes to the proton, it will be little bit high, and as in a mass wise, but when it comes to the carbon, it will be 12 times greater than the proton. So the biological advantages also, like it's potentially high. So the dense of concentration of DNA damages versus sparsely distributed DNA damage. So greater complexity of damage requires different mechanisms of DNA repairs. So protons may result in greater down regulations of certain genes that could impact metastasis. So in the intensity modulator proton, like radiation therapy, if you see the planning wise, if regularly you do see the DVHS and everything. So as compared with the regular AMRTs and the tomotherapy, so it will be superior than the dose distribution wise. So by seeing that, we feel, especially the oncologists feel very satisfied, and of course we too feel the same way. Why? Because the patient may come up with reactions when as this what I'm showing in this prostate treatment and cardomas, especially in the cardomas. So the reactions what we see is as compared with other techniques what we used to treat, it's just show especially in the reactions wise, it will be drastically changes there. So it's the physical advantages and the biological advantages of proton is like a bragg peak. So at the same time, the RB is 1.1, so no exit dose, but more double standard DNA breaks. So especially when it comes to the treatment of the proton therapy, we think like we can treat only for some particular cases, but we can treat from the brain to till the prostate. even soft tissue sarcomas and the cardomas will be very much highly benefited with a proton because of its high dense mass. So the era where it started from the technology evolution from the radiotherapy. So the tumor from the 2D era to the particle therapy. So it's completely evolutionary, we can say. So in the future also, in the proton itself, we have the upgradations from the double scattering to the pencil beam scanning. So usually in the double scattering, they used to treat same like on the previous how we do the 3D CRT with the cerebellum blocks and the same way, but now it's changed to the pencil beam scanning. So at the same time, whatever the technology, whatever the specialties, whatever the things I'm talking, an advantage to the proton, there are very high disadvantages when you are not using it in the properly. So there is a word we always used to say like photon is forgivable and the proton is punishable when you are not utilizing it in a proper way, when you are not looking into that particular each and every minute things which you are doing in a daily treatment by. So there especially that starts from the immobilization. So the immobilizations what we use in the regular practices and what we use in the proton, it's completely different. Why? Because there is a word called an uncertainty. So in entire my presentations, I may repeat this uncertainty word the multiple times. Why? Because in the proton, first thing we have to see is uncertainties is the most important thing, where we have to point out in each and everything, like when you are treating the patients, when you are doing the imaging, and when you are doing the resimulations and everything, every aspect there the uncertainties you have to manage in the better way. So regular radiations, like for the head and neck, we use our standardized headrest, but here we use this patient specific mold care, so that this one, like it's a unique one I didn't seen before, but when I come to the proton, we started using this because of the uncertainties what we used to face in with the regular immobilization device, so that we can completely avoid with the using of this mold care cushion. So this is a little bit interesting thing, like when you open it from the silver foil, so you have to make it in within 10 to 12 minutes of the time, otherwise it will become rigid and you can't reuse it, and the cost wise it's too high. So initially, of course, we done so many practicals and we lost so many mold care, but that's our practice session, so nothing happened. But I think presently we are in out of I think 100, we are not even damaging even one. Our Manoj sir is appreciates in that way, because the wastage wise it was a little bit higher in the initial stage, so we had to answer to the management, right? He had to answer to the management, not me. So there are the only role of immobilization in proton? No. So there are more aspects to be considered after your immobilization. So how you are placing that immobilization day to day, and how you are utilize that in the simulation time. So everything it makes matter. So good is not enough if better is possible. So the same concept we adopt. So when it comes to the setup uncertainties. So as I said since in the beginning, so forgivable and the punishable way. So if you make some little changes, either if you are not clamping, either because of the edema or something, if you are not placing the immobilization in a little bit the other way in a regular radiation, so that will forgive you at least if you are concentrating to hit the tumor at 100, it will reach at least 90 or 95. But when it comes to the proton, it will completely the cold spot and the hot spots. So either it's overshoots, either it will completely zero to the target region. So that things we have to be more concentrated in when you're utilizing these range uncertainties. So where the range uncertainties comes up. So there's a harmful unit, what we're taking HU units converted into the relative proton stopping power using a bilinear relationship. So bilinear relationship is to maximize the accuracy of anatomical materials and CT scanning process. So the immobilization materials that do not lie on the CT calibration curve will have an error associated with their assigned RSP. So inhomogeneities in the immobilization device can contribute to error in proton range. So even like when we use NG tube after some 15 fractions or 10 fractions, and the patient will have the swallowing issues, then we'll place the NG tube. So the NG tube, after you're placing it, so if you're not placing it properly in the CT simulation, or else when you're treating the patient, if your beam is perturbing from that end, so that's lead to the major uncertainty. So because the Hansfield unit get changes, so even like the proton, even small paper also can stop, proton can stop. So because of that, energies get varies in each layer. So here what we use, either be 6 MV or 15 MV in the regular radiation, right? But here when it comes to the proton, we use the energies that layer by layer it get changes. If an example, if I'm treating in a prostate from the on one angle, from the 270 angle, so from the tumor, from the distal end of the tumor will have this an example of 110 MeV. So when it comes to the next layer, it changes to the 100, 90, 80, 70. So the energy also get modified according to the layer by layer. So that is the concept. So if in this between this from the beam to the delivery, if I have some errors or any uncertainties or any Hansfield unit get changed and any other foreign particle comes to the picture, so instead of delivering this 100 MeV here, it may deliver here, it may deliver here. So your complete concept has been got changed, right? So that's what we should be more and more careful in that way. So and the mostly like pediatric patients are we used to treat almost our 30 to 40% of the populations is pediatric patients, because like when we are treating the CSI, craniosspinal irradiation, so obviously we have to give the anesthesia. Of course, like we have the very good staffing, and at the same time good infrastructure. We treated even like a 2.5 years kid without anesthesia. Of course, the most of the institutions, they are practicing with the making of mask colorful and making the room ambience in a different way, and we are adapting the different things to make the children's more friendly departments nowadays. The same way, like we do try to convert it, but if not, then we'll start giving the anesthesia. Of course, if it is patient is less than 2 years, then obviously we have to go for a straight away anesthesia. There's no point of making them engage in all these non-specific things. So here also we have the limitations. Of course, if you are treating an CSI craniosspinal irradiation, obviously you have to make a brain mask along with your backlog. So when we are placing the NG tube and anesthesia accessories for the patient, so that's lead to the, again they can't keep the beams and some particular angulations. So accordingly, again we will change the beam patterns. So backlog uncertainties. Can you able to see here? There is a gap between the table and the backlog and the patient. So this, if I'm reproducing from the day of implementation to till end, that's well and good. If not, then that's lead to the completely, if my physicists keep the beam from 180 angulations, or where this uncertainty goes in a different way. So this is, I think roughly it will be almost some 2.5 centimeter to 3 centimeters. At the same time, my tumor is almost only 4 centimeters. So 3 is, if it is underdosing, that will be overshooted in the abdominal region, and there is a high chance of uncertainties will come into the picture. So at the same time, even it's not only the major one, even minor one. So in this picture, if you see, there's a 9.64 mm and the other one is a 10.48 mm. Where the simulation was done with 9.64 mm and where we are treating, it become in a 10.48 mm. So that also, that 1 mm also it get varies in the treatment pathways. So that is the reason we will be more cautious about the things. And when we are treating the prostate patients in the proton, so we use the mandate of rectal balloons. So rectal balloon concept, it was not, we are not here before in the photon world, but when it comes to the proton, we have started using the rectal balloons to give the immobilization to the prostate, and with a full bladder and full rectum, the rectal balloon. So your prostate will be completely fixed off, and you will also reduce the superior wall of the rectum dose comes down. So we have started practicing it, and there is a good results with the using of rectal balloons. And we do the everyday morning before we start a patient. we discuss, and we'll discuss with the plant physics and the treating doctor and the lead of the treatment room. So we had the different treatment leads in the different treatment rooms. So we'll whatever the special instructions for that particular patients when we are doing the imaging, so the doctors will give us in a pre-auditing like instructions. So what are the things should be taken care. So we'll discuss thoroughly on each and every patient before patient get into the couch. Then only the approval will come for the treatment. So that's how we do the regular practices. And these are the 3 rooms. We are presently we are working with the 2 rooms. So the third room is to be started. Of course, when we hear the one more concept of the proton, like we think the proton room also same like in our regular LINAC room. No, it's completely different. Like we have the cyclotron on the 4th room. So this cyclotron will produce the protons from 70 MeV to 230 MeV, and it will supply to all the 3 rooms. So this is a cyclotron, and this is produces proton, and it will supply from this room, this room, this room. So if I am treating patient in this room, so the other room guys need to wait on the queue till I deliver the beam, then it will shift to the other room. So till then they have to wait, because the cyclotron which we are using the beam modification, it can do only at a time, not simultaneously it will do for the different room. So that is the reason the beam modifier is only one. So that is the reason we use the parallel treatments for each room. So and we have these protocols. This is our imaging adaptive insight which we use for the regular CBCT purposes, and we have the different presets on this thing. So you can't modify the presets until unless you get a software upgrade. So according to that presets, we take the images. So there is a source of uncertainties, there is anatomical changes, the imaging uncertainties, and setup and positional errors, range and beam delivery uncertainties, so verification challenges, so treatment planning and adaptive therapy and standard output. Like we prepared the SOPs, like as it is the first in India and the first in Southeast Asia. Even I didn't work, even any of my fellow colleagues work in the proton. So we got very minor training in the abroad, but still that's not sufficient for us. So we just started developing our own SOPs on a day-to-day basis. Of course, it's not in a straight away like I just started for SOPs in a single go. We started working on each and every patient, whatever the challenges we faced in it. So we made everything as in a point wise, and after finishing off in a 6 months or a period of time, then we prepared the site specific SOPs for each sites. So that is following right now in the throughout the world in some ways, the way they're starting the new center. So I must appreciate my team for preparing of those SOPs and to guiding and then nation and the international wide for the benefit of the upcoming proton centers. So these are the imaging modalities. You can able to see the 2 panels. We have the 2 imaging systems in the machine. So the data wise, if I go like head and neck patients, like adaptive radiotherapies, which we are talking in the morning. So adaptive radiotherapy is very mandate thing in the proton. Like if you see 100 patients out of 100, almost 80% of patients will undergo through the adaptive radiotherapies because of the day-to-day changes which I was talking about, the uncertainties, all these things is considered. So we had to do the plan adaptations in very fast manner. So especially in head and neck patients, roughly if you take 10 patients, almost 8 out of 10 patients will go at least twice or thrice an adaptive radiotherapies because of their tissue reductions in a faster way. So at the same time the breast as well, and for the left breast we use DABH techniques. We have the SGRT system to track the patients as well as the lung and GI patients. At the same time prostate, in the prostate is a very major challenge is like gases and rectal fillings, rectal balloon. So we do practice by assessing the patients the rectal issues. So on the assessment of 3 or 4 days, then we'll start giving enema on a day-to-day basis, sometimes maybe every day. So the conclusion, the accurate imaging is critical for proton therapy success. site-specific issues must be anticipated and managed. So advancing images, regular QAs, and adaptive replanning are essential for our better outcomes. Thank you.
Thank you, sir, for the excellent talk, and definitely it's a quite new technology for us and to learn many things of us, creating an SOPs, fighting the errors, and to review the process. That is a tremendous task we are going to do. In future, I congratulate to you for that. And one small query is that you told about the back peaks and coverage of the tumor volume. So in larger tumor volumes, how to get the flatter back peaks?
Yeah, that's what we are not using here any kind of 3D kind of thing. We are using as a pencil beam scanning. So here, if 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 you think that is especially like a cardoma, so we each layer of that angle, so have the different spots again. So each spot will placed by the in a medical physics team. So that spots when it changes again. So as I said, that uncertainties we have to take it into consideration. So we'll treat that as in a spot by spot on that layer, and the energy shifts, and again it will paint it, and it will shift to the other layer. That at the same time is not only the single angle, like what we used to treat in the Cobalt 60 era, that's four beam angles, 2 beam angles. So we proton therapy, the arc it's not about to start in the world, but it's I think the FDA got approval in the recent past year. I think the upcoming centers we're going to even like what we are going to have in Hyderabad and Delhi proton centers. I think they're going to have the arc therapies. Yeah.
Hello. But your question, spot size also will get changed actually after the depth actually. So when it will go to the depth, actually spot size should be the accurate 3 mm, but then it will come to the distal end, it will go to the 0.6 maximum. So according to that, planning system can take a plan actually, how it can get to it.
Yes, sir. No, no, we can start from the old, the like if you are out of some 600 MUs, you are delivered some 300 MUs, and you for any uncertainty or any scenario that you are able to stop the treatment because of the patient condition, because of the beam, especially like we have very complicated system like the generating of proton to delivering of the proton. So there is a high magnets called dipole and quadrupole magnets. So sometimes we used to face the glitches or the power issues or any cooling issues. So this happened. This used to happen very frequently in the early 2019 to 2020s. But after that, it got verified. But still, we had the issues of source issues and all. So in that case, we had to release the patient. It takes the source is down, then we had to release the patient at least for 30 to 40 minutes to takes to again start the machine. So in that case, we had the OS system. What we are using is the Mosaic system. Why? Because IBA they don't have their own OS, so we are using the world is using somewhere in the area, and we are using the Mosaic. So obviously it get recorded in it, and you can start from the various top. And there is a big announcement, not small announcement. The upcoming, the major event of ARTTA, which is going to held in, I think, yeah, the organizing secretary of 2026. Please come onto the stage once, please. So it is going to held in AIMS Rishikesh, such a beautiful and devoted place. And the first time, and I would like to thank Rajiv and Kamal for having us here. And on behalf of my ARTTI complete EC and BOT members, I would like to thank from bottom of my heart. First time the ARTTI flag is rising in UP. So this is going to rise again and again. So I would like to thank you guys and making this an beautiful event. Thank you so much.
Okay, good evening, everyone. Myself, Ashwini Jaiswal. So next coming ARTTICON 2026, we are organizing in Rishikesh. So most welcoming to everyone. We are so today onwards. I am going to opening registration parts is there. So please visit that site ARTTICON 2026. This registration open now for all. The ARTTICON 2026. Please visit that site ARTTICON 2026 and
Okay, see you all, and Rishikesh. I think there is a video he made it very beautiful way, but he couldn't able to play that. So he'll upload that in the social media so that everyone can see later part. So we'll eagerly to see you all in Rishikesh, and the registration got open from today onwards. So all you can go through ARTTICON 2026. .com, and you can do the registrations. The early bird registrations are till June. Till June. Yeah. Okay. Very sooner. So yeah, fine. So fine. Yeah. Thank you.
उत्तराखंड की शांत घाटियां बीचों बीच एक वहाँ है एक ऐसा शहर जो स्पिरिचुअल एनर्जी और शांति का एक सेंटर है। इस शहर का नाम है ऋषिकेश, जहाँ समय थोड़ा थम सा जाता है और आत्मा को मिलती है शांति। सुबह की पूजा की आवाज़ें और मंदिर की घंटियों की धुन से अगर हवा भर जाती है, गंगा नदी का हर कोई जैसे आपसे कुछ कहता है, तो समझ आप ऋषिकेश में हैं।
This is the Kumbh of this our event.
इस शहर का नाम है ऋषिकेश, जहाँ समय थम।
Sir, for today, no, already sir, that offers I previously once I am when announced in Hyderabad, then already I am given, sir. Now only early bird is open will till 28. So is there already, sir. I uploaded in social media, and it's for ARTTI members that is 3,500, and for non-ARTTI members that is 4,500, sir. And for student 2,000. Is there this place there? I think. Yes, sir. Yes, sir. You come. Sir. Already is offered only, sir. Yes, अब offer में yes, sir. ऐसा. Yeah. Yes, sir.
On the behalf of Ashwini Jaiswal,
मैं ये अनाउंस करता हूँ, घोषणा करता हूँ कि आज जो भी रजिस्ट्रेशन होगा उसको शेयरिंग एकोमोडेशन फ्री. इफ एनी हैव डाउट, शेयरिंग अकोमोडेशन ऋषिकेश में फ्री रहेगा जो आज रजिस्ट्रेशन, यानी लेकिन आज मीन आज के 11:59 के पहले 18 जनवरी एकोमोडेशन फ्री.
धन्यवाद सर. धन्यवाद सर. आपने हमें बताया एक गुड आरटीटी डज नॉट जस्ट डिलीवर रेडिएशन, ही डिलीवर कॉन्फिडेंस. इल्म की इस महफिल में आज कमाल होने वाला है. हर शब्द अनुभव से हर पल सवाल होने वाला है. जो यहाँ सुनाएगा वो यादों में बस जाएगा, क्योंकि ये कनक्लेव है साहब, यहाँ बदलाव होने वाला है. क्योंकि कहाँ होगा अगला कनक्लेव, वो इस मंच पे बताया जा रहा है. इसी के साथ मैं अगले स्पीकर्स को आमंत्रित करती हूँ स्टेज पर. मिस्टर प्रकाश उम्बरकर, सीनियर रेडिएशन थेरेपिस्ट, पीडी हिंदुजा, मुंबई. कृपया जोरदार तालियों के साथ उनका स्वागत करें.
Okay. So thank you for introduction and thank you for invitation, Dr. Raju and my dear friend Kamal. So I will start my presentation. My topic is patient safety in radiation therapy, RTT as the final safety barrier, because morning there are a lot of the technology, the technique, but we are utilizing this technique and the technology. But what are the driving the complete change of the process? We have to think about any mistake happen, how to calculate it and recalculate it to workflow in during the process of the treatment. So I will more focus about what are the learning from my experience in the radiotherapy treatment daily process. I will some highlighted example in as a radiation therapist point of view as a safety related, because patient safety is our first priority. So as of now, everyone knows our standard goal: maximum dose to the tumor volume, minimum dose to the surrounding tissue. That is our standard, the principle. But if your delivery is insufficient, wrongly, that is indirectly effect of the treatment delivery. So in this process, our speaker talk about there are the radiotherapy itself is inherent positioning, and then the challenges for the delivery, like we are involving the multiple steps, we are involving multi-professional for during the treatment process, and complex treatment delivery, treatment technique also. So in this the imaging era, so we can see the imaging the center part. The imaging center part, we can verify each and every session and rectify your problem. But if the process of the change, if you miss or we eliminate this error to reach to our patient. So make sure while implementing our process, patient should be not harmed, and it is indirectly effect of the treatment quality of life the patient. So in this process, we can see the multiple person like medical physicists, radiation oncologists, and radiation therapists, and the dosimeters involved in the process. But again, the morning speaker said that we are starting from the therapist and end from the therapist also. So we are the more responsible person to in this process. But we are the main part as the simulation and the imaging. We are also looking at the patient setup and the treatment delivery. We are commonest the problem related like simulation imaging. The common error happen like wrong site, incorrect orientation, unclear marking, and the patient setup also. There are the if you are changing your headrest and wrong headrest changing. So again the setup uncertainty and the software related errors. So these are the error happen in the radiotherapy process also, and this is the published data also. They also give the more number of the incidents happen, and they are published. We can see there is a number of list of the presentation also. So our main bottom line, So quality of radiotherapy is depend upon the constant verification at every step, like not once and not sometime, but at every step. Because even a small mistake can reach the patient, right? So there are again the 2009, there is a simultaneously two publication in the Green Journal. They say that the 30 years data published in the radiotherapy safety data, overall incidents happen 15 per 10,000 treatment courses. So error, maximum error, we can see the commonest error, that is the wrong patient, wrong site and the wrong identification. So it says to give the maximum dose to the patient incorrectly. So there are not theoretical problems, they are real and reported problems in the event. So after that, we are correcting, yes, we identify this problem, we are correcting our treatment flow, but still there are the top listed, we misfill the problem, everyone's agree with this listed, like radiation treatment plan created using incorrect setup plan. Still we are lagging, still there are many centers, same problem happen. Patient aligned incorrect treatment setup radiograph. I think everyone know about. Similarly, we are doing the routing. This the commonest mistake. Treatment console display the wrong radiation treatment plan for specific treatment, specific patient, and incorrect patient positioning relative to the plan and the treatment table parameter also. So then how to implement the more precisely, more integrate our treatment workflow, that is called as the dry run. So there are the one publication is just simple the newsletter. They can say while implementing your process or implementing a radiotherapy plan or publish your radiotherapy plan, before delivery of the treatment, we can check all the parameters. Most of the center adopted this dry run test because the through being having the very good facility, this is a not just simple rehearsal of the before treatment delivery. What is the evidence say? We can reducing the error, reduce the patient anxiety, and improve the patient safety. And the main these authors say that a safe and effective radiation treatment therapy environment require proactive error identification. So purpose, we identify all the technical parameter, all the beam geometry parameter, and just take all the quality check. If have any disturbance or any technical issue, we can rectify prior of the treatment setup also. Then how to perform this dry run test. So we can see we set all the parameters with the immobilization, with the couch parameter, and we just rotate the dummy patient look like setup. If have any collision, see this is the SRS treatment procedure, and we give the collision injection. So I am done the dry run test, but my therapist know about this test. Then how to communicate with one therapist to second therapist? Then we simply documented in our system, that is where what are the immobilization device used, and we clearly mention that rotate the gantry from inside, carefully. You have to go inside the treatment room and carefully rotate the gantry. Then we can attach our the what are the technical parameter like immobilization, facing photo, and the treatment parameter. So make sure there is no collision for the at the time of the treatment. So after that, yes, there are the still again problem, and we found everyone's the where about this the biggest incident of the health our airline industry. They are not following the checklist, but after that our checklist the generator they are creative generate, because this also the life the saving the service they are providing. And similarly most of the industry we adopted, and one of our healthcare industry adopted this the technology checklist. We don't want to the big checklist, we can identify all the error. Basically we want like that checklist. So in this checklist we can there are the some checkpoint, simplest way, we don't want to the bigger one, time consuming checklist. So simple we can add your checkpoint, patient identification, treatment patient setup, the patient identification, setup node, accessory, and the site location. This is the only simplest way we can minimize our the error, and the system we can follow our according to your the checklist also. So after that there are the multi-step, like first our introduction, when your patient come for the treatment first day, we have to the every day each therapist should be follow the identification rule. because same name, same patient can be happen in come to the treatment room, so we can verify all these parameters, the patient photo, and if any have changes, we can stop the treatment also prior the treatment. So again, the setup safety is the team activity, not as a solo performance or solo task. So second step, pre-treatment verification. Still they are using the, most of the people not adapted in the paperless department, still have the big paper. They can identify the monitor unit, the treatment calculation, the ISO center, everything we can identify, and we can set the patient accordingly. You the generate, publish or the treatment plan according to which is it also. Third one, treatment verification, day 1, day 2, day 3, and verified again. Before changing in modification, we confirm that one therapist is verbally, and second should be verified with the electronic record or the treatment record also. Then after that, we fire the bill. So we are changing our role like paper to paperless. So most of the, still, how many of using the paper? RT chart कौन use करता अभी भी? Still are using? Yes. And paperless? Yes, both also. Now we are changing the paperless, the workflow in our department. Simplest way, we can minimize all the error. So advantages of moving to paperless, like we have to shorter, smarter our workflow, and definitely improve department communication, reduce the error, and minimize the human error, and strengthen the safety level in our daily practice also. So then after that, there are the many of multi-professionals involved in our treatment process, like receptionist, staff nurse, oncologist, medical physicist, and radiation therapist also. But if you give the individual work, they can follow the line, so we can the segregate work, so it's more appropriate for the streamline of the department, the paperless. So we have to generate like we call as the care path. So like oncologist lane, physicist, and the therapist lane also, and we each and everyone verify all the checkpoint added in the treatment process also. So this is the therapist checklist. We can see the simulation. What I added at the time of simulation, we just like that confirm the code, then confirm the scan lane, then set up the everything we loaded, and then once everything appropriate, then we send for the next station for the medical physicist. So accordingly, we can also, and your department, you can implement like the checklist also. The main thing, the checklist, right time, and the right time, that is very important, like the oncologist and medical physicist and the staff nurse also. So again, the safety improves and responsibility is clear, defined each and every multi-professional also. But again, we are doing the paperless, we are doing the seamless workflow, but still there is one example in my clinic. We planned initially the 25 grade, we treat 25 grade, but one day patient come from the Saturday, and one of my the therapists do the manually, the treatment completed, that day system is down and the server is totally down, but he not passed the message to medical physicist and my other core team, and the next day we add the one fraction, like give the extra one fraction dose to initially PTV, but suddenly we ask the patient, Saturday आप आए थे? जैसे उन्होंने बताया सर मैं Saturday आया था. Then we rectify, then go back to our reverse. What happened? Then just we catch and we PTV fraction, we reduce the one fraction. So this also a real world example in my center. So again, we are using old practice to changing the room location. So initially our treatment room inside the patient changing room in the Cobalt 60. But the smarter we can see that this Cobalt 60 room and this LA room, but we are changing the most of the room in the outside the treatment area, so we can safety aspect, we can change out the practice. Basically, the small things can make the big safety difference in the culture in our department also. Again, the last means is that is the most important person, like not therapist, but he is like a person to check every point before pushing the button, everything. When you accept the patient, no one can inside the treatment room, so you can just put the alarm and push the button. Second one is if you have the non-coplanar beam and like HDIP or like treatment technique. So these are the collisions. But if you have the difficulty while waiting the gantry, so first the therapist and second should be understand if this is the collision happen. So you have to document it in area. Next, when you open the the patient prior, we can give the alert sign. This is suppose a diabetes patient is alert, yes, then we can open, and then we give the clear information, rotate the gantry inside the treatment. So we can alert all the time and do the safety point of view. So again, there are the incidents reported and we are documented in the what action should be done in our department, like incorrect patient identification means like a treatment delivery to wrong patient, like breast to breast. Same patient also happen, breast to breast side done. The prostate, pelvis also. Then we just introduced our photograph in the ARIA system. Then again missing the bolus. We introduced the bolus parameter in the ARIA also. Then patient hits the gantry. So like all the errors we introduced and we take up the action noted and documented in our system also. So in radiation therapy, the patient safety improves when we shift from the blame culture to learning culture. So like rather than we asking who made this mistake, and we can ask like what can we learn from the learning from this mistake. So if you are taking the positive way, I think definitely to improve our system, like taking responsibility, learning from the mistake and improve our system without blaming culture to improve definitely patient safety and the care. No blaming learning culture is essential for excellence in the radiotherapy also. Rather than very, I think the simplest way, if you don't have the standard SOP, we don't have any checklist, so at least we have to verify the patient ID, photographs, appropriate imaging protocols like minimum exposure to the patient and all the parameters. If you do the ethically and standardly, so no need to do the checklist also. Again, that is the physical safety is important. Most of the patient, pediatric or the geriatric patient, maybe sometimes fall down the treatment couch. We have to tie the patient, or we can assist the patient. And last one, very important, continuously monitor the patient, because if you the distraction or using the social media at the time of the treatment consult, again it affect our treatment quality also. So again, the patient safety begin with attention, support and the teamwork. So it's my opinion in the radiotherapy, who is the final person responsible for the checking the patient safety? Loudly, please. Or who was the most important person? Sure? 100%? So look at this, the data. There are the people like physician, other dosimetry, the known physicists and the radiation therapists. I think the most of the error identified only by the radiation therapist before pushing the button treatment delivery. So because we are the housekeeper, no, we are the final safety guard, right? So again, don't forget the principle as alarm. And again, if you using the every month higher treatment delivery, always use the traffic light signal to see, to verify, and to treat. That which we follow in daily practice. And again, the simple good tips for each and every professional in radiotherapy. Simpler way, great and comfort for the patient, or make sure the patient is comfortable. Avoid the gantry, rotate with the wedge outside the console. Most of the therapists put in the wedge, rotate the gantry outside. That is very dangerous for. Check the setup node, very essential. Confirm the tattoo placement. Select the correct scan protocol. Train the staff only. Most of the मौसी को बोलते हैं यार ये वेज लगा के और फिर निकल, this is the wrong practice, and respect patient privacy and dignity in our clinical practice. Right? The patient trust is our biggest asset. Okay, don't lose all the patient trust because they are believe for us. So radiation therapists are the front line work in radiotherapy each and every step. RTT maintain excellent safety culture, even limited error in reporting system in India. Reducing the error requires the teamwork, continuous learning process, and the share the responsibility. Patient safety improve when entire the team value the therapist role and all the profession commitment for the to safety first culture. So to improve our patient's quality of life, safety care must be always come first. Again, our mantra, each and everyone, health worker and the patient, safer and better together. So bottom line, safety is our responsibility. Safety no choice, it is our habit. So thank you very much. So, Om Namah Parvate Har Har Mahadev.
And thank you, Prakashji, for taking us to dry run of the technology and to identify the errors. Definitely, the responsibility of accidents doesn't lie with the Alto or the Mercedes. It depends on the driver how he is going to take you to the journey and to identify what features the both vehicles having and what improvements he needs in his skills to minimize these accidents and to find the outcome of the journey, as I think so. Thank you so much. Any questions from the audience? I want to say that
धन्यवाद सर, आपने हमें बताया कि आरटीटी फाइनल पिलर है। टाइम आउट से एरर्स को बाय बाय बोले, सेफ्टी फर्स्ट। ये कॉन्क्लेव कार्यक्रम नहीं, जिम्मेदारी है। सीखते रहना ही प्रोफेशन की तैयारी है। आज जो समझ बढ़ी वो कल जान बचाएगी। यही सीख आगे चलकर पहचान बन जाएगी। इसी के साथ इस सत्र को समापन की ओर मैं सम्मानित अध्यक्ष मिस्टर गुरवेंद्र सिंह बाधवन सर से अनुरोध करती हूं कि वे मंच पर आएं तथा वक्ताओं को सम्मानित करें। वक्ताओं से अनुरोध करती हूं कि वे मंच पर आएं। मिस्टर फायक अहमद, नेक्स्ट स्पीकर श्री सुमित शर्मा जी। श्री अशोक रेड्डी, हमारे अगले स्पीकर श्री प्रकाश उम्बरकर। कृपया जोरदार तालियों से अपनी सराहना व्यक्त करें। अब मैं अध्यक्षगण से अनुरोध करती हूं कि वे मंच पर आएं तथा मिस्टर गुरवेंद्र सिंह बाधवान सर से अनुरोध करती हूं कि वे मंच पर आएं और अध्यक्षगण को सम्मानित करें। डॉक्टर मुकेश जैन, चीफ रेडिएशन थेरेपिस्ट, एकेडमिक इंचार्ज, AHP SMS जयपुर। मिस्टर नरेंद्र कुमार वत्स, सीनियर मेडिकल फिजिसिस्ट, MP MMC HVCH वाराणसी। धन्यवाद सर। एक सेशन गया है पर सीख अभी बाकी है। हर चर्चा ने बदली सोच, बात अभी बाकी है। जो आज यहाँ समझ गया
वो कल काम आएगा। ये कनक्लेव है, कनक्लेव का जादू है जो अगले साल ले जाएगा। इसी के साथ मैं चीफ टेक्निकल ऑफिसर एम्स दिल्ली एंड मिस्टर देवेश, सीनियर रेडिएशन थेरेपिस्ट IGIMS पटना, एवं मिस्टर रमेश चंद्र, सीनियर रेडिएशन थेरेपिस्ट LCI लखनऊ। आइए जोरदार तालियों के साथ स्वागत करते हैं इन इंडस्ट्री के क्लिनिकल ब्रिज मेकर्स का। इस सेशन के पहले स्पीकर को मैं मंच पर आमंत्रित करती हूं, मिस्टर यस हेमराजनी, रीजनल प्रोडक्ट मैनेजर जी हेल्थ केयर। कृपया जोरदार तालियों के साथ स्वागत करें।
Hi, good afternoon, all. So today we have some great sessions regarding radiotherapy, around MR linear, so we all got enlightened about all the topics. Now I'm going to present on a topic which is as close as radiotherapy as we can, right? Which is the diagnosis part. So we have talked about the treatment part, we have talked about the planning part for the radiation therapy. Now we are going to talk about the diagnosis part, which is rough precision diagnosis, how we are enabling more outcomes from the diagnosis towards the therapy, right? So first of all, if we talk about diagnosis, there are two modalities that take care of the diagnosis part majorly. First is the PET CT part, second is the gamma camera or the SPECT CT. So amongst these two modalities, we see majority of the cases and the length and breadth of cancer detection usually happens on a PET scanner. And as you can see, GE Healthcare, the Pro-G Healthcare is a trusted partner. We have a strong global presence across, and we have an innovative and versatile portfolio of products which are scalable, which are the technologies that enable you to detect better and precision, right? So we talk about the PET CT market overall. We have more than 320 plus PET CT scanners just in India, and out of 200 of them are just even a single model which is called Discovery IQ, which you can find in every city, every tier 1, tier 2, tier 3 place across India, which is enabling, which is a vision part of our enablement for the cancer diagnosis, and it's a product which helps us to enable the access to care for the patients. Third, we talk about the largest service network across
for imaging for any company. And fourth, we talk about the satisfaction that the customers have shown with us. And that is why GE probably is one of the companies which is there from last 35 years in PET-CT, and we have continuously evolved and shown our innovation leadership in terms of PET-CT. If just three quick points in this. So first one, the first integrated PET-CT scanner that was commercially available was brought in the world by GE Healthcare, which was in 2001. If you can see this one, Discovery LS. Then we brought the latest technology, which is a scalable PET-CT platform, first time in the world, which is the Discovery IQ platform, which we can see how you can start with different concepts. So we have a 2-ring, 3-ring, 4-ring and 5-ring configuration in this. You can start with a 5-ring on day one, but majority of the diagnostic or setups start with a 2-ring, and then it's a scalable model. On site you can upgrade it to a 3-ring or a 4-ring or a 5-ring within 72 hours. So this video shows you how we are scaling it up, and it's an upgradable model. Next comes the most important part, which is relevant to diagnosis, which is the clinical outcomes, how it is enabling the clinical outcomes. So we see that there is a ultra high sensitivity, and it comes with a segment leading resolution of 2.9 mm. So the smallest of lesions cannot escape, and that is one of the reasons we have installations across Tata, across AIMS, and soon enough you will be seeing this system in AIMS Delhi as well. So this system has 200+ installations in India and more to come. This is primarily because that it provides improved lesion sensitivity and detectability. So as you can see in this image, you can see even the smallest lesions, which are very, very small, right? And it also gives you better and improved lesion visualization. So not just detectability, but visualization is also better. As you can see in this image, we have a QClear protocol which enables you to see these two images are not very clear, but with QClear you can see even the smaller lesions, and detectability is very nice. Then the second and the most important part of a PET-CT scanner is the CT scanner, the machine behind which lets you see the anatomy visibility clearly. It has a very powerful X-ray tube, so it's a high capacity X-ray tube that we have paired with a very powerful generator, and hence you along with a faster rotation time, which gives you a very high-end and high quality superior CT images, and overall high quality PET-CT images. So if you see, not in terms of just integrating to the PET-CT, but the CTs can be used for radiation therapy planning, as well as it can be used as a standalone diagnostic CT, as it has all the capabilities of a diagnostic. Except cardiac scans, you can do everything. It comes with a excellent low signal performance, and you can see that it has enhanced level of adjustment and adaptability. Second, the most important thing, it comes up to 32 slice configuration, so you can easily do all the angiographies except barring the cardiac angiography on the system. You can do all the anatomy. Face quad phase liver exams, for example, or abdomen exams. And it comes with low dose protocols built in, so that as a company we have a focus to decrease the overall dose to the patient. And it comes with organ dose modulation and faster rotation times, so that the dose that is being delivered to the patient can be minimized. And in terms of the clinical outcomes that we speak, we focus in the PET-CT on all these modalities. So in your routine scans, it helps you to get fast and automated analysis for routine exams. It also helps you in oncology primarily, as around 80 to 90% of scans in the center would mostly be oncology scans as of now for the PET. So it optimizes your PET and CT lesion segmentation and detection. And if we talk about neurology, it helps you to identify and quantitate the FDG and beta amyloid analysis. Then even in cardiology, it has a use case wherein it can do analysis of cardiac PET images. For radiotherapy planning specifically, since this is a very high-end CT, so the radiotherapy planning can be coupled on the PET-CT itself, and as a part of that, we have applications that are supporting the radiotherapy planning, like the Smart MAR application, which helps to decrease the artifacts which are produced by metal objects inside the body. So it gives you a superior radiotherapy planning as well. And in the last, it helps you in general workflow optimization. It boosts your PET-CT productivity and performance in terms of daily work and workflow. So thanks a lot. This was a short overview over our technology that we wanted to present to the community. We are open for questions if there are any. Sure, thanks a lot. Thank you.
Thank you. Next speaker is Diksha Bharti.
Good afternoon to all of you, and thank you to Apex team for giving this opportunity for beginners. And I am fresher and performing first time. For any kind of mistake, then I am really very sorry for that. Now I am starting my presentation. My name is Diksha Bharti, radiation therapist from Jindal Institute of Medical Science from Haryana. My topic is CAR-T cell immunotherapy. Chimeric antigen receptor, genetically encoded artificial fusion molecule can program the specificity of peripheral blood polyclonal T cell. CARs are genetically engineered receptors combine the specific binding domain from a tumor targeting antibody with T cells. That does not exist in nature. The DNA encoding the receptor was implanted in T cells so they could fight and kill cancer. In year 2010, first successful cancer treatment with CAR-T was an advanced follicular lymphoma patient was reported by the lab Steven Rosenberg, MD, PhD, Chief of Surgery Branch, NCI Center of Cancer Research. On 30th August 2017 was first CAR-T cell immunotherapy approved by FDA. It was approved for children and young adults aged 25 and under who replaced or were not responding to therapy of acute lymphoblastic leukemia. Successful rate 30 to 40% for lasting remission with no additional treatment according to Michael Bishop, MD, Director of Chicago Medicine Cellular Therapy Program. Infusion time for this it will be take 30 to 90 minutes. And the cost it is in dollar. Patient is stay in hospital for at least 7 days after receiving this treatment. available in countries like China, Europe, Canada, Australia, UK, England, and Scotland, or may be found in other countries. In India, 4th June 2021 was a historic day for TMH, IIT Bombay team, and cancer care in India, as the first CAR T cell therapy, a type of gene therapy, was done at bone marrow transplant unit at ACTREC Tata Memorial Center in Mumbai. Now, procedure: it is a complex and personalized treatment process that is involves like collecting T cells. T cells are type of WBC that help fight injection and extract from the patient blood through a process known as apheresis. Genetic engineering: in laboratory, the T cell are genetically modified to expression a special protein called a chimeric antigen receptor on their surface. This CAR is designed to recognize and bind to a specific antigen found on cancer cell. Expansion: like does engineered T cell as multiple in large number in lab. Infusion time: it takes expand CAR T cell as are the infused back into patient bloodstream, where they can identify and attack cancer cells that express the target antigen. As the process is can we see here, and how does CAR T cell therapy work? To understand CAR T cell, it will help to know more about T cell, which are white the blood cell in your immune system. Your immune system monitor your body for including cancer by tracking protein called antigen on the surface of inducer cell. Your T cell have their own surface protein called receptors. These receptors can recognize cells that have abnormal antigen. T cell acts as a surveillance system for abnormal cells, becoming active when a receptor has abnormal antigen. Cell acts as a surveillance system for abnormal cells, becoming active when a receptor recognizes an abnormal cell. The activated T cell goes to work destroying the abnormal cells and activating other parts of your immune system to come help find and destroy abnormal cells. But your T cell receptor does not always detect cancerous cells. Enter CAR T cell, your own T cells that are changed so they recognize specific antigen on the surface of cancer cells. Scientists change your T cell by adding a lab-made gene for a chimeric antigen receptor. Next, they make the new CAR T cell grow and multiply until there are enough cells to target cancerous cell effectively. Once in your bloodstream, CAR T cell receptor detect and destroy cancerous cells. The cell also keeps on multiplying, so you have a long-term supply of CAR T cells targeting your cancer cells. That long-term supply is why research the health provides called CAR T cell therapy, a type of living drug. What happened before CAR T cell therapy? First, you donate WBC through the procedure called leukapheresis. In leukapheresis, a machine draws some of your blood, extracts your white blood cell, and then return the remaining blood to your blood. Typically, your provider will insert a central nervous catheter to remove and return your blood. Next, your white blood cells are quickly transported to the facility where scientists will turn your cell into CAR T cell. This process can take 3 and 6 weeks, depend on your situation. You may have chemotherapy or radiation therapy after leukapheresis, but before you receive CAR T cells, your health provider may call this bridging therapy. These treatments manage blood cancer during the time it takes to provide and grow enough CAR T cells to treat your condition. When when it's time for you to receive your new cell, you will undergo lymphodepleting chemotherapy. This treatment keeps your blood for rejecting CAR T cells. A 2020 study tracked children received treatment for acute lymphoblastic leukemia. More than 85% of children had completion remission right after CAR T cell treatment, and 60% of those children remained free of cancer 12 months after treatment. On the other hand,
And analysis of CAR T cell therapy research included that for a significant percentage
of people, CAR T cell wasn't a cure for their conditions. And some challenges and limitations need to be overcome before CAR T cell therapy, like relapses, efficiency, toxicity. And that's all. Thank you.
Good presentation.
Thank you,
Any
sir.
question? Thank you.
थैंक यू मैम। देवी और सज्जनों, मंच पे आमंत्रित हैं श्री ऐश्वर्य सोनेवाने का। एक हल्की नोट के साथ मैं उनको आमंत्रित करता हूँ। उनके अगले टॉपिक स्टेबलाइजमेंट ऑफ न्यू रेडियोथेरेपी डिपार्टमेंट RTT पर्सपेक्टिव से तालियों के साथ स्वागत कीजिए श्री ऐश्वर्य सोनेवाने जी का।
Good evening everyone. Myself Aishwarya Dilip Kumar Sonewane. I am from National Cancer Institute NCA, Nagpur, from Maharashtra. Today's my topic is establishment of a new radiotherapy department and radiation therapist perspective. First one, introduction. Radiation therapist is an integral part of the multidisciplinary cancer center. Along with the surgery, chemotherapy, it plays a vital role of the cancer treatment. Establishment of radiotherapy facilities required careful planning, aligning with the institutional goal and available resource is essential. Some key areas in the radiotherapy facilities design in the radiotherapy department: waiting area, examination room, mold room, simulation room, treatment room, then TPS room. It is most important room or the facilities design in the radiotherapy department. Then first one is the radiotherapy examination room. It is the most important in the radiotherapy department. The radiotherapy examination room is used to the initial patient assessment, clinical examination, counseling and follow-up before, after and during radiotherapy. Some essential equipments in the examination room: examination couch, desk, sitting consultants, and computer and hospital information system, HIS, SS, examination lights, basic measuring tools just like weight scale, measuring tape, and the privacy of the patient, screen, curtain, etc. This is the examination room and equipment. Next one is the mold room. Mold room is a very important room in radiotherapy facilities design. Because of the mold room, it is used to the fabricate patient-specific immobilization device, ensure accurate reproducible positioning during the simulation. So, where is mold room located in the radiotherapy department? Located near the simulation room for effectively workflow. Located near the simulation room for the effective workflow, adequate space for the patient movement and the staff handling, proper ventilation and temperature control room, then clean, organized, storage with the patient identification and patient privacy during the mold preparation. Some equipment is required to the mold room as a radiation therapist perspective. Hot water bath or the heating over the thermoplastic sheets, molding table and the workbench, storage racks, patient safety devices, cutting tools, safety equipment, Then next one, ventilation system also most important in a mold room. So next one, CT simulation room. This is also radiotherapy dedicated CT is most important and in our department. So CT simulation room, it is used to accurately reproduce patient treatment position before the actual radiotherapy. They form the foundation of the prescribed treatment planning. Some key functions of the CT simulation room. CT simulation room for the target and the organatrics delineated, patient positioning and immobilization, reference marking just like tattoo, skin marking, and the data acquisition for the treatment planning system. After CT scan will be done, then CT scan sent to the TPS, just like used to CT simulation room. Some equipment necessary in CT simulation room, CT simulation with flat tabletop, laser position system just like moving laser, free laser, some immobilizing devices also storage in CT simulation room, thermoplastic mask, vacuum cushion. After mold will prepare, then this simulation device will come in the CT simulation room. So contrast injector is most important, workstation linked to TPS. Next one is a treatment planning system room, TPS room. The TPS room is where the radiotherapy treatment plans are the created, optimized and evaluation to prescribe dose accurately to the tumor while sparing normal tissue, called as the TPS. So important, the key function in the TPS room in our radiotherapy department, improving CT, MRI, PET image in the form of simulation, target volume and the organ at risk OAR, dose calculation and optimization, plan evaluation using DVH, plan approval and the transfer to the treatment machines. After creating plan in TPS, then sending to the treatment machine. Next, some essential equipment in the TPS, just like image show. High performance planning workstation is important. License of TPS software, just like Mosaic, Monaco, ARIA. High resolution dual monitors. Secure data storage, network connectivity is important in TPS. Again, UPS and power backup system. Then next, radiotherapy department, radiotherapy treatment room, bunker. It is a very most important room in our home only, because of 8 hour we engage in LINAC room na, so then that reason. The radiotherapy treatment room, also called as a bunker house, the house of treatment machine, it is used the accurate and the safe delivery of the radiation to the patient. Some functions is in the treatment room, daily patient positioning and verification, deliver the prescribed radiation dose, image guided radiotherapy verification, IRT verification, monitoring patient during the treatment via LCD cameras. Some major equipment in the radiotherapy treatment room, linear accelerator machine is important because of machines room only. Cobalt, either or cobalt system is used. Treatment couch will the multiple direction movement, just like 4D couch, 6D couch is important in treatment room. Onboarding imaging system is important, just MVCBCT, KVCBCT, MVKV image. Laser positioning system is important. Then audio visual patient monitoring system, it is also used. Treatment control console area located outside the bunker. This is a major equipment in the radiotherapy console or radiotherapy room. In department, some radiotherapy workflow in the radiation oncology department. First one, patient position and immobilization, volumetric data acquisition. Then after image transfer to TPS, then proceed to the target volume delineation, 3D models generation, forward and inverse planning, dose distribution. Then after treatment QA will perform. Then next one, treatment deliver. This is the workflow in our department, radiation oncology. Result and conclusion: establishment of a radiotherapy department, it is a complex and resource intensive. Properly planning, improve treatment accuracy and the patient safety. A well-designed department significantly reduce the cancer patient suffering. Thank you.
Any questions from the audience? The next speaker is
अब
Mr.
हम बात करेंगे हम अपने आधुनिक रेडियोथेरेपी ट्रीटमेंट टेक्निक के बारे में, जैसे कि IMRT और VMAT पर। मैं सुश्री स्मृति सिंह को इन दोनों टेक्निक पर व्यवहारिक उदाहरणों के लिए उनके अगले व्याख्यान के लिए मैं मंच पे आमंत्रित करता हूँ। सुश्री स्मृति सिंह।
बायोहोप कंपनी के द्वारा एक स्क्रैच कूपन दिया गया है, वो एक तरह का लकी ड्रॉ है। उसको स्क्रैच करेंगे, फिर लकी ड्रॉ निकाला जाएगा। जो भी कूपन कोड लकी ड्रॉ में आएगा उसको बायोहोप कंपनी कोई ना कोई गिफ्ट देगी, इनाम देगी। ठीक है, वो लास्ट में जब होगा वोट ऑफ थैंक्स उस टाइम पे करेंगे। सो अपने जो पैम्पलेट्स हैं उसको सब संभाल के रखें, कोई भी लकी हो सकता है।
Miss Spriti Singh.
Ma'am is available.
Next speaker is Mr. Rajendra Tripathi.
स्मार्ट रेडिएशन इज़ अ सेफ रेडिएशन। अब मैं मंच पर मिस्टर राजेंद्र त्रिपाठी जी को उनके अगले व्याख्यान के लिए आमंत्रित करता हूं। For a lighter notes, good setup saves more time than the fastest machines. इन्हीं शब्दों के साथ स्वागत कीजिए मिस्टर राजेंद्र कुमार त्रिपाठी जी का।
Everyone, good evening. Myself, Rajan Kumar Tripathi, Government Medical College, Haldwani, Nainital, Uttarakhand. My topic: comparison of setup accuracy, fresh thermoplastic mask versus one-time use thermoplastic mask. Introduction: radiotherapy is a localized treatment. Thermoplastic masks are used in radiotherapy for patient immobilization so that radiation dose delivered accurately on tumor site. In market, there are various types of thermoplastic masks. Thermoplastic mask material qualities vary from supplier to supplier. There are some good quality masks which can be used 2 to 3 times depending on their cost. Ideally, thermoplastic mask must be used only once, but in country like India, where most of the patients belong to poor background who cannot afford to buy thermoplastic mask, therefore we are reuse thermoplastic mask for the type of patient. Purpose of the present study is to compare setup accuracy between fresh thermoplastic mask and one-time use thermoplastic mask. Material and method: in this study, I used fresh thermoplastic mask for 15% of head and neck cancer patient and one-time use thermoplastic mask for 15% of head and neck cancer patient. In our department, POCR supplied thermoplastic mask named RFID being used for evaluation of setup accuracy in both studies. Following setup coordinate has been taken into account: shift in lateral X, longitudinal Y, and vertical Z direction have been observed by both group of patient. Group A consists of patient with fresh thermoplastic mask and group B consists of patient with one-time use mask. Patient after treatment setup, EPID image before treatment. Result, this patient 15, P1, P2, P3, P4, so on, P15. This mean value of consists of patient group A, X value of mean value x1 plus x2, x3, so on, x1 divided by x, mean value x 0.03 and y directions mean value of 0.18 and z directions mean value 0.11 and consist of B group one time use thermoplastic mask mean value of 0.45 and y direction 0.38 and z directions 0.38. This is standard deviations consist of group A x value 0.1063 and y direction 0.1574 and z direction 0.0998 consist of group B one time use thermoplastics mask standard deviations x direction 0.4335 and y directions 0.2348 and z directions 0.3649 is mean value of x, x1, x2, x3, so on, x1 divided by n and standard deviation rho is equal to sigma x minus bar is whole square divided by n. Rho is standard deviation sigma sum of x each value in the data set, x bar mean of all values in the data set and number of values in the data set. The above table indicate that difference between shift of group A and patient and group B patient are not statistical significant. Conclusion, thermoplastic mask used for patient in mobilization are quite expensive for poor patient. In our department, we prefer to use one-time use thermoplastic mask for such patients in mobilization. By this study, we can conclude that one-time use masks are also provide satisfactory setup accuracy. Thank you.
Any questions from audience? Thank you, Mr. Rajendra.
केयर हैज़ नो बॉर्डर्स। स्वागत कीजिए वर्चुअल इंटरेक्टिव वीडियो का सेशन। इस सेशन में देवी और सज्जनों हम एक स्पष्ट संदेश देना चाह रहे हैं। प्रिसीजन केवल टेक्निक नहीं है, सेफ्टी केवल चेकलिस्ट नहीं है और आरटीटी केवल एक पद नहीं है बल्कि एक जिम्मेदारी है। अब हम एक इंटरनेशनल पर्सपेक्टिव की ओर बढ़ रहे हैं। इन्हेंस पेशेंट केयर थ्रू प्रिसीजन फोकस्ड एडवांस्ड रेडियोथेरेपी प्रैक्टिस विषय पर मिस्टर पीटर एमेनुअल का वर्चुअल संबोधन सुनेंगे।
Early 20th century, where official marks are in delineating where you intend to treat. moved to the mid 20th century where cobalt 60 came in, and it helped improving the depth dose but still lacked fine precision. Late 20th century came the advancement of 3D conformer, where imaging is used to shape radiation beams to the tumor. And in the early 21st century, development of inverse planning like the IMRT and stereotactic body radiation therapy came into existence, giving highly precision and being able to deliver maximum dose to the site. Present day integration of IGRT, which is image guided radiation therapy, and adaptive techniques, which enables real time adjustment and personalized treatments to our patients. So, why precision matters in modern radiation therapy? One, it matters because cancer incidences are increasing globally, and radiation therapy is used approximately in treating 50% of all cancer cases, either as palliative or as curative. And precision diagnosis outcomes and toxicity. So, what are the key benefits of this integration? One, it enhances tumor control, it reduces recurrence rates, minimizes tumor toxicity, and improves long-term survival. The advancement in technology. One, you have the IGRT and real-time tumor tracking. Then you have things like adaptive radiotherapy, which has come in IMRT, stereotactic, and volumetric radiotherapy. So what is the precision radiotherapy workflow? It starts from the consultation, then you move to simulation, contouring, planning, dose delivery, and follow-up. Then you have a very integral part of this flow, which is the quality assurance. Then you come to the imaging aspect. As we said that we are now doing IGRT, so we cannot do without imaging. So what does this imaging help us do? It helps us in delineation these two, and it improves accuracy by helping us to fuse our simulated images and our diagnostic CT or MRI or PET scan with what you call as image fusion, where the two are being put together side by side in order to help delineate these tumors. It equally reduces geographical miss and helps in improving personalized care for patients. So, when we talk about the planning and dose optimization in precision, we talk about inverse planning, and just like we talked about how you do with image fusion and you do your base painting to give colors to your PTV, GTV, and your CTV. Then what are the trade-offs? The trade-offs between coverage and organ sparing are the two things that has come to revolutionize in planning. Then you have clinical judgment, which remains essential despite all these advancements in radiation therapy. So, quality assurance as a patient safety tool. You have to do your machine QA, which ensures output and accuracy of the prescribed dose. Then you do your patient specific QA, which helps in validating plans. Then you do your IGRT, whereby it helps in verifying the treatment delivery in real time. So, what are the clinical impacts of precision? It helps in improving and reduce side effects by preserving organs, preserving the functionality of the organs, reduction in induction of secondary cancer, higher local control rates, treatment of inoperable tumors, palliative care, and it enhances effective therapy. What are the challenges and future directions? Despite remarkable process, the field of radiation therapy faces ongoing challenges and presents exciting opportunities for future innovation. Addressing this will be critical to ensuring equitable access and further personalization of cancer care. One, by addressing the disparities, the coming in of AI and machine learning, the integration of AI and machine learning, the immunoradiotherapy and molecular diagnostics, then you have enhanced adaptive protocols. In conclusion, precision radiotherapy as a cornerstone of patient-centered care in today's world helps us to, one, offer tailored treatment, offer highly effective and significantly safer approaches to cancer treatment. It equally helps and promises even greater precision, accessibility, and integration by ensuring that more patients worldwide benefit from these life-saving opportunities and life-enhancing advancements. By embracing collaboration, we can continue to transform cancer treatment and improve quality of lives in countless. What are the key takeaways in enhancing precision? One, and tailored towards. Two, it enhances efficiency even in challenging cases by sparing healthy tissues, side effects, and preserving organ functions and improving quality of life. Integrated care. Integrated care has to do with the MDTs, the collaboration between the multidisciplinary team to give seamless integration with systemic therapies and amplify treatment benefits. Lastly, continuous innovation for further AI, molecular diagnostics, and adaptive protocols, promising even greater precision and personalization. Thank you for listening.
धन्यवाद सर, आपने अपने अनुभव साझा किए। इसके लिए सीखने की कोई उम्र नहीं होती और ज्ञान की कोई सीमा नहीं होती। इन्हीं शब्दों के साथ सत्र 4 का समापन हो रहा है। अब हम हमारे माननीय सम्मानित श्री रविंद्रन गोपाल सर से अनुरोध करता हूं कि वे मंच पर आएं और सारे वक्ताओं को पुरस्कृत करें। वक्ताओं से अनुरोध है कि वे मंच पर आएं। श्री यस हेमराजानी जी। सुश्री दीक्षा भारती जी, श्री ऐश्वर्या सोनावरे जी एवं सुश्री स्मृति सिंह जी एंड लास्ट श्री राजेंद्र त्रिपाठी जी। एक एक करके मंच पे आएं। श्री ऐश्वर्य सोनावरे जी, सुश्री स्मृति सिंह जी, श्री राजेंद्र त्रिपाठी जी, माननीय अध्यक्ष गणों से अनुरोध है कि वे मंच पे आएं एवं श्री रविंद्रन गोपाल सर से सम्मान ग्रहण करें। डॉक्टर अजीत सिंह सर। मिस्टर देवेश सर। मिस्टर रमेश चंद्र सर। अब हम मूव करते हैं अपने अगले सत्र की ओर। आदरणीय अतिथिगण, सम्माननीय प्रोफेसर्स एवं प्रिय सहकर्मियों एंड मित्रों, अब हम इस सम्मेलन के उस सत्र में प्रवेश कर रहे हैं जहां प्रेजेंटेशन नहीं पार्टिसिपेशन होगा, जहां स्लाइड्स नहीं सोच बोलेंगे, जहां भाषण नहीं भविष्य गढ़ा जाएगा। पैनल डिस्कशन में आज का शीर्षक होगा एकेडमिक ग्रोथ ऑफ रेडिएशन थेरेपिस्ट इन इंडिया, क्योंकि किसी भी प्रोफेशन का विकास सिर्फ मशीन से नहीं होता बल्कि माइंड्स एंड मेंटोरशिप से होता है। फॉर अ लाइटर नोट्स, डिग्रीज गिव यू अ जॉब बट लर्निंग गिव्स यू अ कैरियर। आज इस मंच पर हमारे साथ रेडिएशन साइंस के वे स्तंभ उपस्थित हैं जिन्होंने न केवल इस प्रोफेशन को जिया है बल्कि इसे दिशा भी दी है। मैं अपने सम्मानपूर्वक हमारे पैनलिस्ट का परिचय कराना चाहूँगा। हमारे सम्मानित पैनलिस्ट से अनुरोध है कि वे एक एक कर मंच पे आएं। श्री मनोज वाखड़े सर, आप अपोलो प्रोटॉन सेंटर चेन्नई में चीफ रेडिएशन थेरेपिस्ट पद पे कार्यरत हैं। नेक्स्ट, मिस्टर दीपक कुमार सर, आप मैक्स शालीमार बाग में चीफ रेडिएशन पद पे कार्यरत हैं। डॉक्टर अभिजीत मंडल सर, आप रेडिएशन थेरेपी बीएचयू में प्रोफेसर पद पे कार्यरत हैं। डॉक्टर राजीव कुमार सिंह सर, आप टेक्निकल और मैनेजियल पोस्ट पे कार्यरत हैं एपेक्स वाराणसी सेंटर में। डॉक्टर संबित स्वरूप नंदा सर, आप एसोसिएट प्रोफेसर हैं एमपीएमसीसी एंड एचबीसीएच हॉस्पिटल में। एंड लास्ट, मिस्टर मनोज पिल्लई सर, आप चीफ रेडिएशन थेरेपिस्ट हैं महावीर कैंसर संस्थान पटना में। आप सभी का इस मंच पर हृदय से स्वागत है। इसी विचारशील चर्चा का संचालन करने के लिए श्री गुरविंदर वाधवान सर एज अ मॉडरेटर को मैं मंच पे आमंत्रित करता हूं। आप एक कुशल मार्गदर्शक, एक संतुलित विचारक, एक अनुभवी शैक्षणिक नेतृत्व करता हैं। देवी और सज्जनों, आज भारत में रेडिएशन थेरेपिस्ट की भूमिका तेज़ी से बदल रही है। फॉर अ लाइटर नोट्स, इफ़ यू वांट टू गो फास्ट, गो अलोन। इफ़ यू वांट गो टू फार, गो टुगेदर। इसी शीर्षक के साथ अब हम अपने पैनल डिस्कशन की शुरुआत करते हैं। डॉक्टर गुरविंदर वाधवान सर, अब मंच आपका है।
Thank you, my dear friend, colleagues, expert panel और पैनलिस्ट ऑफ दिस सेशन। और दोस्तों, सुबह से आप लोग बैठे हो, एकेडमिक की ही बातें चल रही हैं, तो अगर सबको नींद आ रही है तो चाय पी के चलें घर। अगर चाहते हैं तो आधा पौना घंटा बैठ के एक बार डिस्कस कर लेते हैं, क्योंकि द टॉपिक एकेडमिक ग्रोथ ऑफ रेडिएशन थेरेपिस्ट गिवन बाय ऑर्गेनाइजर्स, it is a topic which needs lot of discussion in our country. Discussion means how academic growth of a radiation therapist is being enriched by knowledge, and why it is required. Once person has completed diploma or certificate or bachelor or master or PhD, then why ongoing knowledge, improvement in knowledge it is required? Why? And what are the challenges being faced during this overtime experience in our work practice, and what opportunities we are getting currently, or what opportunities we are going to get out of present available resources. And yes, way forward, future growth. So we are not going to give you all these things. No. We are going to come with a discussion, and this discussion, I think, will guide us, enlighten us, and make a dream in our brain that what we are and where we can go if we are with academically enriched. So first I would like to already introduction is given, but it is my duty that our enriched experienced panelists are available here. A lot of experience is there with them, so I will introduce them. Mr. Manoj Wagale, Chief Radiation Therapist, Apollo Proton Cancer Center, Chennai. He has been honored with Suman Seva Award. He has served as a student coordinator and instructor at Yashoda Hospital, having 28 years of experience. Welcome, Manoj Wagale sahab. Next, please. Thank you. Next, our expert is Deepak Kumar, Chief Radiation Therapy Technologist from Max Hospital, Shalimar Bagh, New Delhi, having 18 years experience, and in which he has worked international hospitals also, so nationally is there. So welcome, Deepak ji. Next expert is Manoj Pillai sahab, Chief Radiation Therapist, right now Mahavir Cancer Sansthan, Patna, Bihar. He is a founder member and office bearer of our association of therapists, mentor of young therapists, and he has organized conferences and CMEs in Bihar multiple times. He is awardee of many awards from ARTTI, from AROI, and from AMPI. Welcome, Pillai sahab. And yes, of course, Professor Abhijit Mandal sahab. He is from Institute of Medical Sciences, Banaras, Hindu University, Banaras. He has a lot of interest and has experience in radiation oncology physics, radiation biology, and of course treatment planning, which is being implemented by therapists in radiotherapy department. He has a lot of publications, more than 70 articles in his career, supervised PhD and MD students, developed 2 MOOC courses. He is a member of professional associations and of course received many academic awards, and right now he is a professor in BHU. So next speaker is Associate Professor Dr. Sambit Swarup Nanda Sahab. Nanda Sahab is a radiation oncologist working at HBCH and MPMCC Varanasi. He is specialized in head and neck cancer and pediatric tumors also. And welcome Dr. Swarup sir. Now I don't think that Dr. Rajiv needs an introduction. He is a chief radiation therapist at Apex Hospital, and he is one who is a author of radiation books. Very big clapping for him. And there are 2 books are coming also for publication in the field. I think what he is working on this. So this is a great achievement for the community of radiation therapists that they are started working in this academic era also. So welcome, Dr. Rajiv. So let us start with the discussion. Why next? Okay, this is mine. Next, please. Next. Okay. Why academics needed? Why education needed? How it is going to help? If you know knowledge, it will give knowledge. And what knowledge will do with us? Knowledge will guide what to do. हमें क्या करना है, हमें क्या कहना है, हमें क्या करना है, हमें क्या कहना है. ये नॉलेज जो हम एकेडमिक पढ़ेंगे ये हमें गाइड करेगा. इट विल डेवलप स्पेसिफिक स्किल सेट. स्किल आएगी हमारे अंदर, सोचने की क्षमता आएगी. जो हमने कहना है, जो हमने करना है, उसको कैसे कहना है, हाउ टू से. लठ मार के कहना है, गोली मार के कहना है, या वो सुबह मॉर्निंग में क्लास की सॉफ्ट स्किल या इनॉग्रेशन में एम्पैथी का डिस्कशन किया, उसको बीच में ला के कहना है. तो दैट academic will going to guide us. And yes, of course, it will enhance attitude. हमारे व्यवहार को, हमारी कैरेक्टर को एनहांस करेगा ये पढ़ाई हमारी एकेडमिक. हाउ मच टू से, भाई कितना कहना है, बहुत ज़्यादा तो नहीं कहना, बहुत कम तो नहीं कहना, पॉजिटिव कहना है या निगेटिव कहना है. ये सारी चीज़ें ब्रेन में सोचनी पड़ेंगी. एंड दीज ऑल दिस थिंग्स व्हाट वी आर गोइंग टू गेट from academic growth in our profession. डिप्लोमा करा, BSc करा, MSc करा, but at each level we have to think accordingly. Then only we are going to be fit and we are going to be recognized for the work which is being implemented and translated in our practice. So these things in panel discussion we are going to discuss with our experts, and experts are from different regions, and they will guide, they will give their opinion, and there are going to be 3 rounds. In one round we will ask one question to each expert, then we can ask audience also कि आपका क्या विचार है, क्या आप इन एक्सपर्ट से कुछ और पूछना चाहते हैं या आप इनकी बातों से सहमत नहीं हैं. क्योंकि ये डिस्कशन है, डिस्कशन में आप अपने विचार रख सकते हैं. हो सकता है आपकी सोच और भी ज़्यादा, क्योंकि इन्हीं ब्रेन में से ब्रेन और बढ़िया मिलेंगी आगे आने वाले के लिए, तो वो हमें सामने लानी है चीज़ें कि आपके इनपुट कैसे हैं. देन ओनली द थिंकिंग विल गो ऑन राइजिंग आवर स्टैंडर्ड, आवर लेवल ऑफ प्रैक्टिस इन डे टू डे. So, so this will develop our learning curve. थकना नहीं है कि यार ठीक है सुबह आए रोज़ वही काम, वही बटन दबाना, वही टास्क लगाना, वही एनर्जी देनी, वही नहीं. लर्निंग कर्व, भाई यार बटन दबा रहा हूँ, ये बटन हल्का सा कम दब रहा है, अगर ये कम दब रहा है तो कहीं फंस गया तो प्रोफेसर अभिजीत मंडल के लिए मुश्किल ना हो जाए कि ये एकदम से ERB से. थिंकिंग, वी हैव टू हैव क्रिटिकल थिंकिंग हर रोज़. अरे दरवाज़ा अटक रहा है, दरवाज़ा क्यों अटक रहा है, कास्ट ठीक से लग रहा है, नहीं लग रहा है. दैट इज़ आवर लर्निंग कर्व. वी हैव टू ट्राई टू गेट हाउ वी कैन गेट लर्निंग फ्रॉम आवर वर्क एवरी डे. So that is our learning curve and scope of practice. वही प्रैक्टिस हमारी गोइंग टू बी एवरीडे ऑन इम्प्लीमेंटेड। सिमुलेशन में हमने क्या करना है, हर रोज़ कोई चीज़ सोचनी है और उसमें इम्प्रूवमेंट की कोशिश करनी है। और सेम थिंग वी आर गोइंग टू बी ड्यूरिंग डिलीवरी ऑफ रेडिएशन डोजेज ऑन ट्रीटमेंट मशीन। सो दिस इज व्हाट वी आर गोइंग टू डिस्कस। अच्छा, ये एक बिजनेस insider.com है, वो क्या कह रहा है? बिजनेस insider.com, व्हाट इज थिंग? It is a major global online media company owned by German publisher Axel Springer। वो कहते हैं कि रेडिएशन थेरेपिस्ट इज द 7th हाईएस्ट पेइंग जॉब इन द लिस्ट ऑफ 40 बेस्ट जॉब इन इट्स रैंकिंग टॉप ऑफ द हेल्थ केयर सेक्टर। तो मतलब हमारी सिचुएशन बहुत अच्छी है। हम लोग 40 हेल्थ केयर जो एलाइड हेल्थ प्रोफेशनल्स हैं उनमें साथ में आ रहे हैं, सातवें लेवल पे आ रहे हैं। तो इसका मतलब कुछ हमारे उसमें प्रोफेशन में हम स्टेमिना को ऊपर ला सकते हैं, उसको अपग्रेड कर सकते हैं ताकि और हमारे को रिकॉग्निशन मिल सके। एक्चुअली सो लेट अस स्टार्ट विद वन क्वेश्चन। कंप्यूटर साहब ने पहला क्वेश्चन दिया हमें। यस, फर्स्ट राउंड, फर्स्ट क्वेश्चन विद मिस्टर मनोज वागड़े। वागड़े साहब, आपका क्या कहना है? वी वुड लाइक टू नो हाउ स्टेटस ऑफ एकेडमिक ग्रोथ ऑफ रेडिएशन थेरेपिस्ट इन इंडिया इन करंट सिनेरियो। व्हाट इज योर ओपिनियन, व्हाट यू से इन दिस?
थैंक यू गुरविंदर जी, आपने मुझे यहाँ पे चयन किया इस पैनल डिस्कशन में। उसके पहले मैं जहाँ पे इस पवित्र भूमि पे हम विराजमान है उसको मैं नमन करता हूँ और मेरे सारे साथियों को सप्रेम नमस्कार। और दूसरी बधाई देता हूँ कि बहुत अच्छा ऑर्गेनाइज किया इन्होंने। सो थैंक्स फॉर इनवाइटिंग मी फॉर दिस पोजीशन। सो दैट वी वुड लाइक टू नो स्टेटस ऑफ एकेडमिक ग्रोथ। तो जो आप ये क्वेश्चन है तो रियली मेरे हिसाब से इट्स अ ट्रांजिशन मोड। एक्चुअली वी आर इन द गुड फेज राइट नाउ। Because when 10 years back I was there in the Indonesia, actually there I saw there nothing was there, is just like a radiotherapy courses. But here from last 25 years almost we are running the 25, before that also we are running these courses, only it is a different way. But what are the present scenario is to be there. So we are in the transition phase actually. As he said, we have some post graduation diploma holders, we have some certification courses, some in South India we are finding the many BSc RT courses are there. But for the being the time actually over the time maybe it will go in the uniform manner, that I am much more optimistic in that way. So nothing to be, sometime it is a contract situation is to be there, how we have to accept with each other in our Indian scenario. Some is the diploma, some is the big therapy, some is the degree holder, some is the, even though many are the MSc right now, many are the MSc, even though PG, Chandigarh, they have the MSc courses as well. So it's a different, but same, our aim is to be same only. But yes, it is to be okay, it is to be in the transit phase. So slowly it will go within this 5-6 years. I am seeing actually this, it should be the uniform way in India. And in Indian future is very good, because we required actually almost 500 to 600 machine in futures, linear accelerator. So in that way, we required more skill therapists required for to take care for that one. So it is, our future is the best actually, and Indian scenario this is the best thing.
So you mean to say it is if we are academically sound, we are a bright future in India?
Yes. Obviously, means when we are comparing with the globe, actually we have the rank actually. It is not a first rank, but we are the rank in between actually. We can say today. So we are in the transit mode. Maybe after 5-6 years, maybe we will be on that list also, in the top list.
मतलब अगर हमने ये choose किया है profession, so it means we are in very good profession.
Yes, definitely I am proud to be, and those are here sittings are there, they are equally proud to be. Maybe they are agree with my this position.
Thank you वागड़े साहब. तो साहब एक next question देखें किनके पास जाता है. Oh, next question is for Deepak Kumar ji. how does the current curriculum for RTs, RTs is referred now new nomenclature internationally, is radiation therapist. So RT wherever is written you can think radiation therapist. How does the current curriculum for radiation therapists in India align with international best practices and technological advancement? क्या विचार है आपका? What do you say?
पहले तो thank you sir, and I would like to thank Kamal, who's actually invited me here for the panel. He gave me the suggestion, and thank you the organizers for having me in the panelist. So the current curriculum is according to NCH Act 2021 currently. It's it's designed for to say that it's on standard global design, which says one curriculum one nation standard. Okay. उसके बाद इसमें देखिए then it's acting as a bridge, for the better practice, not only on the clinical role, but making it like a skill based along with cutting edge technological evolutions. Secondly, I would say that it is strongly recommended on a strong pivot. We can say that the theoretical route of learning has been changed to competency based learning. उसके अलावा it is equipping the professionals to master on high technologies, adaptive radiotherapy, AI driven imaging, which is upcoming in the enrolled BSc program of 2026. On soft skill, we can say that it has added for medical ethics, better communication, skilled communication, what we can say. And for me, like what I feel like regulatory transmission can be like कि जितने भी courses है ARTT के, it should strictly come under the act of NCHP authorities. And future perspective is like we should the entrance for allied health should go directly under NCPH Act to the NEET registration.
Okay.
It should be.
Okay. अब आपको क्या लगता है कि इंटरनेशनल विदेशों में और हमारे यहाँ जो कोर्स चल रहे हैं इनमें मतलब आपने काम किया हुआ है, वहाँ के लोग भी वहाँ काम करते थे, तो उनकी पढ़ाई के लेवल में और हमारी पढ़ाई के लेवल में वेयर वी स्टैंड ऑन इंटरनेशनल स्टैंडर्ड?
सर वेरी फ्रैंकली स्पीकिंग, तो अभी जो हमारा लाइक इन द current scenario, the diploma section, if we talk about, not about the BSc, I'll come to the BSc. Diploma section में we are very very far behind to the standard of international. इसीलिए हमारा registration शायद बहुत जगह approved ही नहीं हो पा रहा है. But yes, coming to the BSc curriculum, it is coming up to that level of global standard, जहाँ आपका registration accept होता है. मार जो खाते हम, it is like internship या hands-on practice was missing in the BSc curriculum. इसीलिए if you see in the NCPH Act, they have strictly gone for internship program also. So that is one of the basic things.
Okay, good. Thank you. Now we will move to the next expert. पिलई साहब आपके लिए सवाल है. What is your opinion on challenges? क्या दिक्कतें आ रही हैं? हम ट्रेनिंग लेने में, पढ़ने में हमारे को बिहार में या दूसरे स्टेट्स में क्या क्या मुश्किलें आती है? क्या बिहार का आदमी यहाँ यूपी में आके आराम से काम कर लेगा या यूपी का उसके नॉलेज में कोई फ़र्क है? क्या है, कैसे, मतलब व्हाट यू आर थिंकिंग?
Several thanks to Dr. Raji to give me an opportunity to do. Actually, the main problem is our curriculum. The diploma peoples are not getting so much highly qualified. Only degree peoples are getting syllabus, good syllabus.
Okay.
Moreover, practical training also very less. In advanced training technique, they are not getting good training. That are the main challenges.
What do you mean they are not getting good training? इसका क्या मतलब है? समझ नहीं आ रहा.
Mostly those who are completing diploma holders from such as जो भी जो है उसका जो मतलब सारा फैसिलिटीज़ नहीं है, वहाँ से कंप्लीट कर रहे हैं तो उनको सारा सीख नहीं पाता है ना।
ओके, मतलब हर सेक्टर पे उस
हाँ,
लेवल का टीचिंग
स्टैंडर्डाइजेशन होना चाहिए।
ओके, दैट इज आल्सो चैलेंज, यस ऑफ कोर्स इट इज। बिल्कुल ठीक, आप प्लीज कंटिन्यू।
फिर जो है टेक्नोलॉजिस्ट अभी जो काम कर रहा है वो 90% तो डिप्लोमा वाला ही है। वो लोग को डिग्री कैसे भी होना चाहिए, मतलब जो यूनिवर्सिटी से लैटरल एंट्री थ्रू होना चाहिए।
ओके,
तब स्टैंडर्डाइज हो जाएगा। हर एक आदमी जो नेशनल लेवल में पूरा लोग स्टैंडर्डाइज हो जाएगा। ये सब बिग चैलेंजेस होता है। फिर ट्रेनिंग हम लोग अभी जो है, जो भी अभी कर रहा है, CMA कर रहा है, वो भी इनसफिशेंट है। हर जगह से आदमी लोग कहाँ आ पा रहे, नहीं आ पा रहे। ऑनलाइन इवन हम लोग ऑनलाइन शुरू किया है, फिर भी मैक्सिमम उसमें अटेंड होता है 100 आदमी अटेंड होता है। 2000 से ऊपर टेक्नोलॉजिस्ट है, कहाँ ऑनलाइन वो लोग अटेंड नहीं कर रहा है।
तो अब ये चैलेंजेस कैसे दूर होंगे, मतलब क्या
ये कंपल्सरी करना पड़ेगा हर एक हॉस्पिटल को और हर एक इंस्टीट्यूट को। कैसे भी जो है, अभी सपोज राजीव का इंस्टीट्यूट का हर एक स्टूडेंट्स और टेक्नोलॉजिस्ट को बोलना है कंपल्सरी आप लोग अटेंड कीजिए, तब आपको कुछ क्रेडिट मिलेगा। इससे तो एसोसिएशन को देना पड़ेगा, इसे करना पड़ेगा।
और कैंडिडेट को भी खुद आगे आना पड़ेगा पढ़ने के लिए।
हाँ, आगे आना
बहुत
पड़ेगा।
जरूरी है।
आप जो अभी बताया है, कोई 7th पे स्केल, हाईएस्ट पे स्केल है करके। आई नो पीपल्स हु आर वर्किंग विद 12,000 rupees रेडियोथेरेपी टेक्नोलॉजी।
ओके, दैट इज द बिग चैलेंज।
Big challenge. Salary uniformity is not there.
Okay. So this is the challenge. Mr. Pillai is saying. Next, please. Next expert, please. Yes, Professor Abhijit Pandit. How can a culture of research be established within clinical department to encourage radiation therapists to participate in research and publication activities despite high patient workload?
First of all, thank you organizer Rajiv, Kamal and Varanasi sir for giving me a chance to present over here. Actually, I am engaging the radiotherapy technician teaching from 2007. Actually, when I came here, मैंने देखा कि ज़्यादातर टेक्नोलॉजिस्ट जो है they are not properly trained, means they know their work, but they don't have any type of certificates. So what we felt that there is a shortage of radiotherapy technologist course in this region. So we started that course, PG diploma in radiotherapy technology, and many of our students sitting here. And now we have converted that course in BSc radiotherapy technology in BHU. And I am also myself and Dr. Ganesh, who is radiological safety officer in our department. We have designed one course in Swayam portal that was radiation physics, comprised of 40 lectures. And now we are going to start another course for radiography and imaging technology for X-ray technology. Now in the question that culture of research, I always promote our students to present their work, their small work, their problem-based work. Just I have listened one topic from Mr. Tripathi that one-time cast and first time cast and many time cast. He just explained his research. This is a problem-based research. This kind of research I have my students are present in many conferences. And one of my students, he sum up with work, and we published in a 1.4 impacted journal, Journal of Cancer Research and Therapeutics, as a co-author. So to promote the culture of research in radiotherapy technologies, they should get the academic incentive. Means if they are involved in any research, they should give the proper co-authorship. Now, if he is a first author or co-authorship, this is academic incentive. And the department also should promote such type of technicians that they are actively participate in their there, and they should mentor that small problem-based research, so that they can present, and by comprising this small work, we can achieve big things. So this is my opinion.
So what professor says that we need to pick up small things in our day working, like Tripathi has given. Similarly, in imaging, similarly in positioning, and then we have to put that title under research.
Yes, we have in one my experience that in radiotherapy institution, there is a problem between the administrator that this much number of patients should be treated in month. But technician he thinks that अरे मेरे लिए तो बहुत ज़्यादा हो रहा है, ये तो इतना पेशेंट तो नहीं हो सकता. तो वो जो पेपर हमने लिखा था, that was workload modeling of a cobalt. That time we have cobalt 1618. So workload modeling का हमने मॉडल किया कि अगर आपके पास इतना पेशेंट ब्रेस्ट का है, इतना हेड एंड नेक का है, इतना सिंपल पेशेंट है, बायलेटरल पेशेंट है, तो आप इतना पेशेंट ट्रीट कर सकते हैं. तो आपने एक सॉफ्टवेयर जनरेट किया जिसके अंदर आपने पेशेंट डालने हैं, इतना पेशेंट है, तो आपको बता देगा कि आपने ओवर टाइम जो टाइम है वो ज़्यादा लग रहा है, कम. मतलब इतना सिंपल काम है, कोई बड़ा काम नहीं है. लेकिन ये पब्लिश हुआ था,
मतलब आप वर्क लोड पे भी प्रेजेंटेशन दे सकते हैं.
हाँ, मतलब आपका जो प्रॉब्लम है, you just identify the problem, and जैसे Mr. Tripathi identify problem that one time mask or multiple use mask क्या है, और उन्होंने निकाले और उन्होंने बता दिया. तो ये कोई अगर आपको प्रॉब्लम है तो आपको उसको क्वेश्चन को आंसर देना, और वो साइंटिफिक कहेंगे.
ठीक है, मेरे ख्याल समझ आ रही है बात को कि भाई. हाँ,
मेरा एक क्वेश्चन है आपसे. एक मिनट की सेशन में जैसे हम रिसर्च में खुद को कैसे इन्वॉल्व करें और पार्टिसिपेट करें, उसके लिए कहीं ना कहीं जो हमारे ऑन्कोलॉजिस्ट है, फिजिसिस्ट है, उनको इन्वॉल्व करना पड़ेगा. लेकिन मेरा सवाल है कि सर, एक ये 5 मिनट के डिस्कशन में जितने भी हम लोग बैठे हैं उसमें आपसे 3 बार टेक्नीशियन वर्ड का यूज हुआ. ये जो माइंडसेट है सर, कब ख़त्म होगा? मेरा ये सवाल है सर, इस तरह का माइंडसेट कब ख़त्म होगा सर? क्योंकि जब तक ये माइंडसेट ख़त्म नहीं होगा सर, तो हम लोग आगे नहीं बढ़ पाएंगे. सॉरी सर इसके लिए.
ये क्योंकि हमने बहुत 2005 में मैंने
मतलब it is not Professor Bapka, it is not
just I would like to add actually, Sumit, one quote is to be there. Sometime he was telling in conference actually, what we need a pilot or we need a car driver. So just like he shows the difference actually. Pilot, we can say it is just like a radiation therapist, and then you can just consider actually car driver as a technician. So this is a transition. I am saying actually previous I said it is a transition. We have to go away from the technician to therapist. Actually, you are expecting much more from us. So why we should not accept the nomenclature from the top end actually? When it is to be started there, then nothing is to be impossible, because then we will get some what we are moral support, or some we are getting some that type of work we can do with the responsible way.
And of course, he is advising that how to go in research. Once we are entering to research, automatically if it is thinking in So our next expert is Dr. Nanda Saab. What, as a radiation oncologist, what specific opportunities for advanced specialization, like, do you think that in contouring radiation therapists can be more helpful or not, or for any specific cancer site some more additional responsibility can be added, or if new technology currently coming, then there also, because your burden is more, you are clinically side with wider thinking and lot of patients think, so few responsibilities like contouring, like specific some kind of protocol research or some kind of can be given to slightly transfer to the therapist. Why therapist? That you can justify. भाई थेरेपिस्ट हर रोज मशीन पे मैचिंग कर रहा है, हर रोज सेटअप कर रहा है, हर रोज DVH देख रहा है, ITV, CTV, GTV, PTV देख रहा है. तो अगर वो पहले दिन जब CT सिमुलेशन करेगा और पहले दिन ही कंटूरिंग में अगर उसको नॉलेज होगी, तो जब वो मशीन पे मैचिंग करेगा, जो हम लोग सोचते हैं, तो हो सकता है वो ज़्यादा बढ़िया तरीके से आपके सपनों को बढ़िया कर दे. आपका क्या ख्याल है? तो क्या आपकी या आपकी कम्युनिटी में डॉक्टरों को इससे दिक्कत तो नहीं होगी, या इससे कोई हमारे उसमें रोल में आपको कोई चैलेंज तो नहीं आएगा? लाइक दैट वी वुड लाइक टू.
So at the outset, I would like to thank everyone, all the organizers for giving me this opportunity. जो टॉपिक हमारे यहाँ पे अभी चल रहा है कि व्हाट आर द न्यू थिंग्स इन टू विच जो रेडिएशन थेरापिस्ट हैं दे कैन वेंचर, तो क्या नया चीज़ है अपार्ट फ्रॉम व्हाट दे आर डूइंग करेंटली, जो अभी वो कर रहे हैं उसके बियॉन्ड वो क्या कर सकते हैं. सो अगर हम फॉरेन में देखें तो नॉर्मली एक पार्ट ऑफ द कंटूरिंग रेडिएशन थेरापिस्ट एज वेल एज फिजिसिस्ट उसमें इन्वॉल्व रहते हैं, जो कि हमारे यहाँ पे हमारे करिकुलम में करेंटली नहीं है. स्पेसिफिकली जहाँ पे कि थोड़ा सा बहुत इंटेंस थेरापी नहीं है, जैसे कि
इम्पोर्टेंट बात बता रहे हैं डॉक्टर साहब, ध्यान से सुनिए.
जैसे कि पैलिएटिव थेरापी है, कोई पेशेंट पैलिएशन के पर्पज से आ रहा है और बहुत टाइम ऐसा होता है कि जस्ट क्लिनिकल मार्किंग से हम ट्रीट कर रहे हैं, जहाँ पे कि एग्जैक्टली कोई भी कंटूरिंग हम कर भी नहीं रहे हैं. ठीक है, वैसे सिचुएशन में उस चीज़ को और अगर हमने रेडिएशन थेरापिस्ट को प्रॉपरली ट्रेन किया हुआ है कि कौन से एरिया को टारगेट करना है, और फाइल में देख के या CT स्कैन या MRI या PET स्कैन जो भी इमेजेस हैं उस इमेज से देख के वो एग्जैक्टली लोकलाइज कर पाए कि सरफेस एनाटॉमी के बेसिस पे कौन से एरिया को प्राइमरी टारगेट करना है. सो इफेक्टिवली ये ऐसा होगा कि एक 2 पॉइंट्स वेरिफिकेशन होगा कि डॉक्टर ने देखा, ठीक है, डॉक्टर ने हो सकता है मिस कर दिया, हो सकता है किसी टाइम पे सीनियर डॉक्टर नहीं है, कोई जूनियर डॉक्टर देख रहा है, उसका भी एक्सपीरियंस कम है. उस सिचुएशन में अगर एक रेडिएशन थेरापिस्ट है जो कि डे टू डे यही काम करता है, जो जिसका कि उस चीज़ को लेके एक्सपोजर बहुत ज़्यादा है, ठीक है, तो एक एग्जांपल जैसे मैं बोलता हूँ कि एक वीगो लगाना होता है, डॉक्टर चाहे कितना भी क्वालिफाइड हो जाए, सिस्टर से अच्छा कोई नहीं लगा सकता, क्योंकि डॉक्टर हो सकता है पहले अपने इंटर्नशिप के टाइम पे, अपने रेसिडेंसी के टाइम पे 100 या 200 लगाया हुआ है, सिस्टर ने 1000 या 2000 लगाया हुआ है, तो कभी भी वो एक्सपीरियंस हमेशा वो एक्सपीरियंस काउंट होता है. सेम चीज़ है. सो अगर एक पार्ट है जो कि फॉरेन में होता है, लेकिन उस चीज़ के लिए इम्पोर्टेंट ये है कि जो हमारा करिकुलम है करेंटली, उस करिकुलम में उसको ग्रेजुअली इंट्रोड्यूस किया जाए, लोगों को उस हिसाब से ट्रेनिंग दिया जाए, सो दैट वहाँ पे कोई मिस्टेक्स ना हो, क्योंकि अल्टीमेटली वो लास्ट स्टेप है, उसके बाद पेशेंट का ट्रीटमेंट डिलीवर हो जाता है. गलत अगर कंट्रोलिंग हुआ तो गलत प्लानिंग होगी, गलत डिलीवर हो जाएगा, वो इम्पोर्टेंट है. सो जब तक हम स्टैंडर्डाइज नहीं करेंगे तब तक मुश्किल है. सेकेंड थिंग है स्पेसिफिक कैंसर साइट. 2 चीज़ें जो हमारे इंस्टीट्यूट में मैं ऑब्जर्व करता हूँ, जैसे कि बोन एंड सॉफ्ट टिश्यू ट्यूमर्स होते हैं, उनके लोकेशंस बहुत ही ऑड रहते हैं. वहाँ पे 3 लोगों की काम चाहिए होता है. एक तो रेडिएशन ऑन्कोलॉजिस्ट की कौन से एरिया में प्राइमरी ट्रीटमेंट देना है, एक फिजिसिस्ट की कौन से बीम पोर्टल्स देना है ताकि हम एक स्ट्रिप बचा सकें, और वहीं पे इनोवेशंस की रिक्वायरमेंट होती है, और उस इनोवेशंस में रेडिएशन थेरापिस्ट का बहुत ज़्यादा रोल होता है. सो हमारे इंस्टीट्यूट में बहुत टाइम ऐसा होता है कि हम उनसे इनपुट लेते हैं, सो गिविंग दिस इमेजेस हमको ये चाहिए कि इस साइड का मुझे एक स्ट्रिप बचाना है। अब आप बताओ कि किस हिसाब से वो कर सकते हैं। डेफिनेटली जो डे टू डे उसको कर रहा है वो ज़्यादा प्रॉपरली उसको बता पाएगा कि अगर हम ऐसे करेंगे या ऐसे करेंगे, लेकिन उसके लिए एक क्लोज कोऑर्डिनेशन बिटवीन फिजिसिस्ट एज वेल एज रेडिएशन थेरापिस्ट बहुत इंपॉर्टेंट है। थर्ड पॉइंट है न्यू टेक्नोलॉजीज। डेफिनेटली आज के दिन में मशीन चेंज होते जा रहे हैं। पहले हम कोबाल्ट यूज़ करते थे, उसके बाद लिनक्स आए, लिनक्स में भी अब हेल्सियन आ रहे हैं। हमारे इंस्टीट्यूट में ही जब स्टार्टिंग में हमारे पास ट्रूबीम था, जब हेल्सियन आया, हमारे जो टेक्नोलॉजिस्ट जिन लोगों ने अलग अलग मशीन में काम किया है लेकिन हेल्सियन में काम नहीं किया था, उन्होंने खुद से रिक्वेस्ट किया कि सर हमको कुछ दिन के लिए हेल्सियन में भी पोस्टिंग दीजिए, हम भी नया कुछ सीखना चाहते हैं। करंटली प्लान चल रहा है कि टोमोथेरेपी आएगा, और मुझे पता है कि लोग अपने तरफ से इंटरेस्ट से जाएंगे कि नया मशीन में भी हम एक बार काम करें, क्योंकि डे टू डे सेम काम करते हुए हर आदमी बोर हो जाता है, हम भी बोर होते हैं, वो भी बोर होते हैं। तो अगर कुछ नया सीखने को मिले वो इम्पोर्टेंट है। लेकिन जो चैलेंजेस है वो ये है कि प्रोटॉन, जैसे कि किसी को मन है कि प्रोटॉन में काम करे, वो प्रोटॉन सेंटर में जाएगा, वहाँ कोई उसको हैंड्स ऑन तो नहीं करने देगा। लेकिन जब तक हमारे देश में मल्टीपल प्रोटॉन सेंटर्स नहीं हो रहे हैं, कोई अगर उसमें सीख भी जाए तो उसको इम्प्लीमेंट करना उसके लिए मुश्किल है। सो दिस विल बी द सिचुएशन जहाँ पे कि नेक्स्ट लेवल में हमको जाना पड़ेगा, और वो स्टार्टिंग ट्रेनिंग से ही होना चाहिए, तभी जाके वो हो सकता है। तो इफेक्टिवली ट्रेनिंग के दौरान स्टूडेंट्स को अगर ऐसा हो सके कि सारे मशीन्स का एक्सपोजर मिले, अगर उस सेंटर में है तो अच्छी बात है, नहीं है तो कम से कम इंटर्नशिप के टाइम पे दूसरा सेंटर में भेजा जाए जहाँ पे कि दूसरे मशीन से, अगर किसी ने इलेक्ट्रा सिस्टम में काम किया है तो वो वेरिएंट सिस्टम में जाए, किसी ने वेरिएंट में काम किया है वो टोमोथेरेपी सिस्टम में जाए, किसी ने अगर प्रोटॉन में हो सके तो दैट इज वेल एंड गुड। आज के दिन में शायद पॉसिबल नहीं, क्योंकि एक या दो सेंटर हैं, तो इन टाइम जब बहुत करते
वेरी थैंक यू वेरी यस नेक्स्ट एक्सपर्ट इज डॉक्टर राजीव. What are the major disparities in the academic quality of education and training? What do you say? Where we stand in this scenario?
Thank you so much, sir. I'd like to thank you all the people who came here for a long place and listening here from the morning session to the evening. So continuing over the sessions, I would like to say that one कि जैसे डॉक्टर सर ने कहा कि एजुकेशन बहुत बड़ी चीज़ होती है, टेक्नोलॉजी को एजुकेट करना ही पड़ेगा। अगर हम एजुकेट नहीं करते हैं तो वो आगे नहीं बढ़ पाएंगे, मोडेलिटीज़ चाहिए। लेकिन हमारे पास क्या होती है, अर्बन एरियाज़ में और पेरिफेरल इंस्टीट्यूट में बहुत सारी चीज़ें लैक ऑफ रहती हैं। मैं जैसे बात कर रहा हूँ, मैं कोबाल्ट मशीन हमारे पास है एग्जाम्पल, और मैं पढ़ा रहा हूँ BSc RT कर रहा हूँ, लेकिन BSc RT के लिए आप क्या करिकुलम है वो आप नहीं पता है। आप लिनक्स मशीन को बारे में बता रहे हैं लेकिन लिनक्स मशीन दिखा नहीं रहे हैं, उसके ऊपर काम नहीं कर पा रहे हैं, तो उससे क्या होता है, डिसपार्टीज होते रहते हैं। सर ने कहा है कि ज़्यादातर आप जितने भी टेक्नोलॉजिस्ट हैं वो इंस्टीट्यूट में आकर पढ़ाई करते, जो स्टूडेंट्स हैं वो पढ़ाई करेंगे, उनके लिए आपको पहले करिकुलम बनाना पड़ेगा। जैसे कि टीचर्स हैं, अब टीचर हमारे पास लास्ट ईयर के पास आउट बच्चे हों और पढ़ाना स्टार्ट कर दें तो फिर हम क्या ही पढ़ेंगे। ये बहुत बड़ा ड्रॉबैक होता है। जैसे कि बहुत सारे इंस्टीट्यूट में क्या होता है कि 2 साल के पुराने जो स्टूडेंट्स होते हैं वही पढ़ाते हैं, तो ना उनके पास कोई क्लिनिकल नॉलेज होता है, ना ही मैकेनिकल नॉलेज होता है। तो जब वो नहीं कर पाते हैं तो वो पढ़ा नहीं पाते, बता नहीं पाते हैं। इसके वजह से हमारे पास क्या होता है, क्वालिटी ऑफ एजुकेशन क्या होती है, ख़राब हो जाती है। जब वो जाते हैं इंटरव्यूज़ में तो दे आर नॉट एबल टू से एनीथिंग। सो इस चीज़ के लिए, इसको ठीक करने के लिए वी नीड अ करिकुलम कि एजुकेशन के टीचर्स जो हों वो कितने लेवल के पढ़े हों, क्या पढ़ाएं और क्या चीज़ें होनी चाहिए, और कौन से इंस्टीट्यूट के पास क्या चीज़ है उसके थ्रू वो एजुकेट करें अपने स्टूडेंट्स को, तब जाके हम आगे बढ़ सकते हैं सर।
थैंक यू डॉक्टर राजीव। आपके लिए फ्लोर, आपके लिए, ऑडियंस के लिए, आपको कोई डाउट है? पहला राउंड ओवर हो गया है। जो ज़्यादा सवाल करेगा, जो ज़्यादा क्वेश्चन पूछेगा जो ज़्यादा हमको चांस देगा सोचने के लिए आपके क्वेश्चन पे, उसको मेरे ख्याल ऑर्गेनाइजिंग कमेटी वाले कुछ शाम को
यहाँ
इनाम
से भगाने वाले हो इसका मतलब।
तो आप लोग सवाल जरूर
नहीं कुछ नहीं, एक्चुअली
और डाउट जरूर पूछिएगा।
मुझे ऑलमोस्ट सभी के लेवल पे थोड़ा सा एक एक क्वेश्चन सबके लिए। तो जैसे इन्होंने कहा लेटरल एंट्री दे के काम कराना है, पढ़ाई करवाना है लेटरल एंट्री। मनोज सर आपका सोच बहुत अच्छा है, बट वो लेटरल एंट्री के लिए हम लोग किस हद तक कहाँ कहाँ जाके हम क्लियर करवाएंगे, या कोई यूनिवर्सिटीज़ वगैरह में हम डायरेक्ट अप्रोच करें या सिर्फ NCAHP को अप्रोच करें, क्या उसके बारे में कुछ आइडिया है आपको? So we have to start.
हर एक स्टेट का एक यूनिवर्सिटी में अप्रोच कर सकता है, एक यूनिवर्सिटी नहीं 2-3 यूनिवर्सिटी अकॉर्डिंग टू साइज ऑफ दी स्टेट। ओके, हम लोग को डिवाइड करके अप्रोच कर सकता है, करके NC का जो भी मैंडेटरी थ्रू हम लोग उसका करिकुलम जो भी है बना के एक वर्किंग पीपल्स के लिए उनको एक
जैसे NCAHP है उसमें RTT रिप्रेजेंटेटिव कोई भी नहीं है।
कोई
हाँ
कोई नहीं है,
RTT कोई नहीं है, तो इसमें आपका क्या है? क्योंकि
हर एक स्टेट में ऐसे एक RTT का भी जरूर एक होना चाहिए। RTT
NCAHP में ही नहीं है, हमारे रिप्रेजेंटेटिव नहीं है।
तो हम लोग का एसोसिएशन का जो प्रेसिडेंट है, प्रेसिडेंट
हाँ सर।
साथियों नमस्कार। और जैसे कि आपने प्रश्न उठाया, हमारा जो है NACPH एक्ट में रिप्रेजेंटेटिव नहीं है, उसके लिए हम बहुत ट्राई कर रहे हैं, लेकिन कुछ हेडल्स ऐसे होते हैं जिन्हों को हमें पार करना बड़ा मुश्किल हो रखता है। हम दिल्ली में रहते हुए भी हम इसके साथ इतना काम करते हुए और मिनिस्ट्री के अंदर जाते हुए, अभी उन्होंने हमारे रेडियोलॉजी और रेडियोथेरेपी को एक रिप्रेजेंटेटिव दिया हुआ है, वो हमारे एम्स से दिया हुआ है। लेकिन ये बात हम बिल्कुल अपने आप को मानते हैं कि हमारा रिप्रेजेंटेटिव होना चाहिए, लेकिन कुछ चीज़ें मैं आपको कह नहीं सकता विद दिस फ्लोर पे, क्योंकि उससे कॉन्फ्लिक्ट पैदा होगा। अगर कोई पर्सनली मेरे से पूछना चाहेगा तो मैं बताऊंगा कि हमारा क्यों नहीं हो पा रहा। वो कॉन्फ्लिक्ट को शायद फ्लोर पे नहीं कहना चाहिए। और मैं अब आपको भी बताना चाहता हूँ कि सर आपका संस्थान भी बहुत बड़ा है। मैं आपकी बात से बिल्कुल सहमत नहीं था, लेकिन मैंने कहा जब फ्लोर पे आएगा तब मैं बात करूँगा। आपकी बात से मैं सहमत नहीं था कि भी आपके यहाँ कोर्सेज हो रहा है।
कोर्सेज हो रहे हैं, लेकिन हम लोग को पूरा जो है ना
सर आप ये बता हो रहा है?
हो रहा है, अभी बंद है।
अभी बंद है सर। आप इतने सीनियर आदमी हैं, बहुत पुराने आदमी हैं।
हम लोग
और
डिप्लोमा कोर्स बंद कर दिया है
सर। मैं हाँ वही कह रहा हूँ। हमारे अभी मैं इस इंस्टीट्यूट में आया तो आज भी मुझे पता चला कि भाई यहाँ पे भी डिप्लोमा चल रहा है। तो मैडम से, अंकिता मैडम से मेरी पर्सनली जब हम मीडिया पे अपना वक्तव्य बोल रहे थे, तब हमने उन्हें कहा कि आप डिप्लोमा कोर्सेज करा तो रहे हैं, और कोई भी संस्थान अगर कोर्सेज कराता है तो उसकी जिम्मेवारी बनती है कि उसको कम से कम 50% जो प्रोडक्शन हमारी बाहर आ रही है उसको रोज़गार देना। मैंने कहा आप कितना रोज़गार दे पाओगे? बोले नहीं मैं इसको बिल्कुल चेंज करूँगी। मैंने कहा हम आपसे उम्मीद करते हैं कि अब अभी तो हम आपको वैसे ही बात कर रहे हैं, लेकिन आगे शायद हम लेटर भी इस चीज़ का भेजेंगे पूरे भारत के अंदर। हमारा प्लानिंग पूरी चल रही है, ऐसा नहीं है। लेकिन इसके लिए मैं आपको ज़रूर बताना चाहूँगा, इसके लिए हमारे खुद के टेक्नोलॉजिस्ट, खुद के रेडियोथेरेपिस्ट की सीनियर की जिम्मेवारी है कि वो वहाँ पे डिप्लोमा कोर्सेज ना होने दे। एसोसिएशन जो रेडिएशन थेरेपी की एसोसिएशन है, जिसके हम प्रेसिडेंट हैं, प्रधान हैं, हम पूरे भारत में घूम नहीं सकते, ना ही हमारे पास कोई फंड है कि भाई हम अपने खर्चे पे कितना जा सकते। कभी जहाँ मौका मिलता है कॉन्फ्रेंसेस और इनों में आने का, उसमें कोशिश करते हैं, वहाँ जाके रिक्वेस्ट करते हैं। टाटा जैसे बड़े हॉस्पिटल के अंदर भी हो रहा है। मैं और वधावन जी वहाँ पे डिस्कशन हमारा चला, HOD से बात करी हमने कि भाई इसको बंद करें। और मैं आपको अपने कार्यकाल की एक मिनट सर, देखो अभी जरा कर लेना, तो बहुत सबके माइंड में क्वेश्चन है। और NACPH एक्ट के अंदर सर ब्रीफ भी कर रहे हैं सर। हम वहाँ पे गए तो एक आपको बड़ी अचीवमेंट बता रहा हूँ हमारे कार्यकाल की, कि हमारा चेन्नई से आगे कौन सा है, उसको हमने सरकार को चिट्ठी लिखी। मैं अभी नाम मेरे को याद, त्रिपुरा में डिप्लोमा हो रहा था, हमने सरकार को चिट्ठी लिखी। और वहाँ के टेक्नोलॉजिस्ट ने, क्योंकि टेक्नोलॉजिस्ट ही तो बताएगा हमें कि भाई वहाँ ये हो रहा, मेरे सेंटर पे ये हो रहा, आप सर इसको ये करो। तो ये हमारी सबकी जिम्मेवारी बनती है। आप मान के चलो सरकार ने उस चीज़ को चेंज किया। और इसके साथ मैं दीपक जी की बात से बिल्कुल सहमत नहीं हूँ कि हमारे वहाँ पे फ़ॉरेन की बात हुई थी कि फ़ॉरेन में हमारे कोर्स का और इंडिया के कोर्स में क्या फ़र्क है। नहीं, मैं आपको आप भी रह के आए हैं, आप भी फ़ॉरेन रह के आए हैं, और मैं फ़ॉरेन में जाके आया हूँ, रह के तो नहीं आया। मैंने भी डिप्लोमा किया हुआ है, मेरा तो खैर बहुत टाइम हो गया, 89 के बैच के हैं। लेकिन मैं आपको बता रहा हूँ आज की डेट में हम जो एक सर्टिफिकेट इशू करते हैं, गुड स्टैंडिंग सर्टिफिकेट एसोसिएशन के जरिए जाता है और उससे उसको जॉब मिलती है। आज अगर 32 स्टेट के अंदर BSc कोर्सेज चल रहे हैं, 32 स्टेट के अंदर BSc कोर्सेज चल रहे हैं। ऐसा नहीं है, हमने इम्प्रूवमेंट किया है, काफ़ी किया है, कोशिश की है, लेकिन उसमें हमारे सभी भाइयों की बराबर की जिम्मेवारी होगी और उसको तभी हम आगे बढ़ा पाएंगे। और NACPH एक्ट के अंदर हम पर्सनली, मैं और मिस्टर वधावन पर्सनली लगे हुए हैं कि जल्द ही हमारा रिप्रेजेंटेटिव भी अंदर होगा वहाँ पे। कोशिश जारी है। थैंक यू।
एनी अदर क्वेश्चन? यस प्लीज, फास्ट। हाँ, जैन साहब, पहले किसने हाथ उठाया था? जैन साहब, हाथ आप बताइए।
बिल्कुल सर, थैंक यू। एंड फर्स्टली आई वुड लाइक टू कॉन्ग्रेचुलेट यू राजीव सर, अजित सर, फॉर डूइंग अ ट्रिमेंडस टास्क। ओके, सॉरी। इसमें सर सिंपल से मेरे 2-3 सजेशंस है आई वुड लाइक टू से। अपन कहते हैं कि चीज़ ये होनी चाहिए और चीज़ क्या वो है क्या, इन दोनों के बीच का डिफरेंस क्या है एंड कैसे अपन उसको अचीव करें। अपन ये मान के चलते थे कि रेडिएशन सेफ्टी, बीइंग ए टेक्नोलॉजिस्ट, मैं बहुत अच्छा काम करता हूँ और मैं पूरा ध्यान रखता हूँ मेरे रेडिएशन सेफ्टी का। तो फिर LMO क्यों आया, लास्ट मैन आउट स्विच क्यों आया? और हम उसको, बिकॉज रेगुलेटरी अथॉरिटीज़ ये चाहती हैं कि आप उसको रेगुलेशन के रूप में अडॉप्ट करें। और रेगुलेशन अडॉप्ट करने का मतलब होता है कि वो चीज़ मैंडेटरी फेज़ में आ जाए। देन अपन बात कर रहे हैं करिकुलम्स की। करिकुलम एंड रेगुलेशंस, इन दोनों में बहुत डिफरेंस होता है। करिकुलम इज़ अ सेट ऑफ डॉक्यूमेंट दैट let you to know what about the technology and how to teach this technology, what is the requirement of that technology। मतलब कोई अपन रेडियोथेरेपी की बात करते हैं तो मेरे रेडियोथेरेपी में हिस्टोरिकल पर्सपेक्टिव और आज के पर्सपेक्टिव में मेरा जो टेक्नोलॉजिस्ट है उसमें क्या क्या स्किल्स प्रेजेंट सिनेरियो में नीडेड है और वो उसको फुलफ़िल कैसे करेगा, दैट इज़ वन पार्ट ऑफ द डॉक्यूमेंट। अनदर पार्ट इज़ डॉक्यूमेंट हाउ आई एम गोइंग टू इम्प्लीमेंट। जैसे सर ने भी बताया कि इंडोनेशिया में वहाँ कोई सेटअप नहीं था। इंडिया में अपन 25 साल से डिफरेंट कोर्सेज चला रहे हैं। आज की डेट में अपन प्रेजेंट सिनेरियो की बात करें सर तो अराउंड 0.6 लिनक्स पर मिलियन पॉपुलेशन इंडिया में है और एज़ पर इंटरनेशनल स्टैंडर्ड 1 लिनक्स फॉर 1 मिलियन पॉपुलेशन इज़ रिक्वायर्ड। यानी आप मान के चलिए 63 से अराउंड 60 से 70 सेंटर्स इंडिया में ऑपरेट हो रहे हैं और इन सेंटर्स का यदि आउटपुट माने तो 1000 रेडियोथेरेपी टेक्नोलॉजिस्ट पर ईयर होने जा रहा है। देन हाउ टू मेक चेक ऑफ दीज
काइंड सिनेरियो, आप में बोलेंगे या आप 10 जगह जाएंगे सर, माइट भी हो सकता है कि आपके पर्सनल रिलेशन से 4 जगह इस चीज़ को अडॉप्ट कर लिया जाए, बट इन टोटलिटी ये मुश्किल होता है। देन अपने पास चारा क्या है उसके पास में, देन लुक फॉर द रेगुलेटरी फॉर। जैसे सर बैठे हैं यहाँ पर, हम जानते हैं कि रेडिएशन सेफ्टी सभी देखते हैं, देन वाई RSO इज़ नीडेड एंड वाई इट इज़ इम्प्लीमेंटेड। तो RSO क्योंकि AERB ने उसको no, I'm not distracting the question, sir. I'm trying to explain my views. तो सर हम regulations, हमारा जो curriculum है, it's excellent piece of work, but where we need to improve, सर उसमें जो regulatory guidelines है, we need to introduce that thing कि आप सभी इंस्टीट्यूट खोलने जा रहे हैं, तो सर मेरा इंटेक क्या होगा, मेरा इंटेक पर्ली नेक के हिसाब से होगा या मेरा इंटेक फैकल्टी के हिसाब से होगा। 25 साल से मैं तो इंटेक के अकॉर्डिंग इंफ्रास्ट्रक्चर गाइडलाइन अपन को देनी पड़ेगी सर। उसमें मैं गवर्नमेंट सेटअप में हूँ सर, एंड एफिलिएशन मेरे जो राजस्थान पिरामिड आज की डेट में अलाइड हेल्थ केयर काउंसिल है, उसका मैं नॉमिनी मेंबर हूँ टास्क फोर्स का, और मैं ये एफिलिएशन प्रोसेस देखता हूँ कई बार। तो अब आप सब सपोज़ मैं रेडियोथेरेपी सेंटर खोलने जा रहा हूँ, और रेडियोथेरेपी सेंटर वो कहेगा कि आपके इसमें लिखा ही नहीं, कहाँ लिखा है कि मेरे को 10 बाई 10 का कमरा चाहिए, वाई शुड मैं कहीं भी टीच कर दूँगा। तो आपने वो गाइडलाइन में है क्या चीज़, ये कहाँ लिखा है कि मैं एक लिनेक पे 5 ही लोग लूँगा, मैं 50 भी ले सकता हूँ, वेयर इट इज़ रिटन। सो प्रैक्टिकली सर, तो ये गाइडलाइन हमें इम्प्रूव अपने इसमें ऐड करनी पड़ेगी। बीइंग इन प्रोफेशनल लेवल हम सर आपकी गाइडेंस में इसको आगे लेकर बढ़े। NCHP में डेफिनेटली अपना जो RTT रिप्रेजेंटेशन है, डायग्नोसिस के 4 मेंबर्स एट प्रेजेंट हैं सर, तो अपना भी हम कैसे इसको इम्प्रूव कर सके उस डायरेक्शन में सोचे। एंड थैंक यू सर।
वेरी गुड, वेरी नाइस। ठीक है, नाउ वी विल क्लोज क्वेश्चनिंग फ्रॉम ऑडियंस। ओके, नेक्स्ट राउंड वी विल स्टार्ट सेकंड राउंड। यस पिल्लई साहब, प्रोफेशनल डेवलपमेंट एंड स्पेशलाइजेशन विद करंट CMEs, क्या ये सफिशिएंट है? शायद आपने तो जवाब पहले ही दे दिया है इसके बारे में। इज सफिशिएंट टू कीप एग्जिस्टिंग वर्कफोर्स अपडेटेड और रैपिड एवोल्यूशन? क्या मतलब दोबारा एक छोटा ब्रीफ, एक मतलब
नॉट सफिशिएंट। आपको ये ना हर एक डिस्ट्रिक्ट में करना चाहिए, मेरा ओपिनियन से। CMI
क्या करना चाहिए?
CMI और ये जो ट्रेनिंग, प्रैक्टिकल ट्रेनिंग।
देखो आपकी बात बिल्कुल ठीक है।
उसके लिए सर हम लोग को जो है ना एसोसिएशन थ्रू जो करना पड़ेगा, हर एक डिस्ट्रिक्ट में एक स्टडी क्लब और एकेडमिक क्लब खोलना पड़ेगा, उसका थ्रू उधर एकेडमिक एक्टिविटी कराना पड़ेगा।
एक मिनट एक बार मैं मुंबई ट्रेनिंग में था, वेरिएंट की ट्रेनिंग से एक हफ्ते का। एक फॉरेनर था वैसे, पैट्रिक साहब, स्विट्ज़रलैंड से थे वो, साथ में ही थे, हम 6 लोग कर रहे थे। उनके यहाँ एक प्रोसेस बताया उन्होंने कि मतलब RTTs करते क्या हैं। उनके यहाँ RTTs कंट्रोलिंग भी करता है, प्लानिंग भी करता है और इम्प्लीमेंट भी करता है। मैक्सिमम फॉरेन कंट्रीज यानी यूरोपियन कंट्री में जो है वो ये प्रोसेस है, बट हमारे यहाँ ये नहीं है। और जैसा सर ने कहा, बीच में बैठे हुए हैं, सॉरी पार्डन, गुड नेम नहीं पता है मुझे, समित सर, तो उन्होंने कहा कि उसके लिए जो एक पैटर्न बनाने की ज़रूरत है, यानी कि नॉलेज गेन करने की ज़रूरत है। हम कंटूरिंग कर सकते हैं, हम प्लानिंग कर सकते हैं। मैक्सिमम जो सीनियर RTTs अगर वो इन्वॉल्व, जैसे मनोज जी हैं, सुमित हैं, योगेश हैं, आप लोग हैं, ये बहुत ऐसे जो सीनियर हैं, उनको बहुत अच्छा नॉलेज है। अकॉर्डिंग टू नहीं कहना चाहिए, बहुत सारे फिजिसिस्ट एंड अकॉर्डिंग टू बहुत सारे अंको जो नए आते हैं, उससे बेहतर नॉलेज उनके पास है। बट लीगली वो ऑथराइज नहीं है। उसके लिए लीगली ऑथराइज करने के लिए, जैसे समित सर ने कहा कि हमको अकॉर्डिंग टू एजुकेशन जाना पड़ेगा। यानी यूजीसी के माध्यम से, या एआरबी में क्या है, आरएसओ क्यों इतने पॉपुलर है? आज उनकी सैलरी स्टार्ट होती है 2 लाख से, वो स्टार्ट होती है, मिनिमम 2 लाख रुपये। रीज़न है उसका, मैं ये नहीं कह रहा, क्योंकि वो एक बैन है। आरएसओ आप जब तक सर्टिफाई मतलब बीआरपी पास नहीं करेंगे, आप कहीं अथॉराइज नहीं है। फीसेस बहुत सारे हैं पर आरएसओ बहुत कम है, क्योंकि लिमिटेशंस है उनकी, डिमांड बहुत ज़्यादा है, प्रोडक्शन बहुत कम है। हमारे यहाँ का है प्रोडक्शन बहुत ज़्यादा है, डिमांड बहुत कम है। और सबसे इंपॉर्टेंट चीज़ है कि लैक ऑफ नॉलेज, हमारे पास नॉलेज नहीं है और हम उस नॉलेज की तरफ बढ़ना भी नहीं चाह रहे हैं। अभी कभी डिप्लोमा और बीएससी का फ़ाइट होता है, कभी डिग्री और डिप्लोमा का फ़ाइट होता है, हम उसी में उलझे रह जाते हैं। हम अपने आप को कैसे इम्प्रूव करें, नॉलेज वाइज कैसे इम्प्रूव करें, सबसे इंपॉर्टेंट है, और उसका सोल्यूशन ढूंढना पड़ेगा। हम ऐसे बात करते रहें कुछ नहीं होगा, हमको सोल्यूशन के साथ जाना होगा, और सोल्यूशन भी फैक्ट के साथ होना चाहिए। जब तक हम उस पर काम नहीं करेंगे, चाहे वो डिप्लोमा स्टार्ट हो आपके यहाँ हो या हमारे यहाँ हो या जो भी बच्चे, देखिए
solution is the academic growth.
Definitely. We will go with academic.
Thank you sir. So yes, next expert राजीव सिंह जी, आपका नंबर फिर से आ गया। What mentorship program are available and how crucial are they for the academic and professional growth with career satisfaction?
मैं कहता हूँ सर, इस चीज़ में मैं कहना चाहता हूँ कि बहुत ही क्रूशियल रोल होता है मेंटरशिप का। तो अगर आप टेक्नोलॉजी के माध्यम से आप देखें तो टेक्नोलॉजी क्या क्या कर सकते हैं, या थेरेपिस्ट क्या चीज़ें कर सकते हैं, किस तरह से आगे ले आ सकते हैं किसी को, तो वो मेंटरशिप में आपके कैरियर ग्रोथ में आ सकते हैं, आपके रिसर्च पेपर में भी हेल्प कर सकते हैं, और बहुत सारी चीज़ें होती हैं जो आपको प्रेजेंट करने में भी काम आती हैं। सर ने एक चीज़ कहा था, प्रकाश जी हर सैटरडे को एक क्लासेस लेते हैं, पाठशाला लेते हैं, दैट इज़ अ वंडरफुल थिंग। मैं उस पर क्रिटिसाइज़ नहीं कर रहा हूँ, बट एक चीज़ बोलता हूँ कि डूइंग अ क्लास like this in Saturday is like a CME, small CME for 3 hours or 2 hours. So rather than doing that one, you should go with a class, mental class, that is हर सैटरडे को क्लास करें, 4 हफ्ते में क्लास करें, और उसका एग्ज़ाम लें, उसका टेस्ट करें, तब जाके उसका मेंटरशिप ये होता है। मैं क्रिटिसाइज़ नहीं कर रहा हूँ किसी को, ना ही मैं पॉइंट आउट कर रहा हूँ।
It is a discussion. It is an open discussion. No one should mind.
अगर मेंटरशिप है, दैट इज़ अ गुड वन, बट मेंटरशिप में आता क्या है कि आप किसी के ग्रोथ को डेवलप करो, ना कि CME डेवलप करो। मैं एक CME करा रहा हूँ, और आज आए सब लोग मिले, खाए पिए, एंड दे हैव डन अ गुड वन, they have voted me, they have thanks giving done, they have get a knowledge, but after that, does that knowledge has given something to them? No. CPD is the main one. आपके पास CPD नहीं है तो आप आगे नहीं बढ़ सकते। So we need a CPD. For that only we should go with a proper classes and examination to help students of technology to grow. So that is the mentorship. This is the first mentorship to do this one.
प्रधान जी, वैसे इनका एडवाइस बुरा नहीं है कि स्मॉल काइंड ऑफ एग्जामिनेशन और एसोसिएशन कैन कंडक्ट दैट काइंड ऑफ कमेटी एंड स्टार्ट डूइंग दिस एक्टिविटी। भाई वो तो जब सरकार करे या कॉलेज करे या यूनिवर्सिटी करे, डिफरेंट इशू। एसोसिएशन तो अभी प्राइवेट है, हमारी अपनी है, हम कभी भी
लाइक जैसे बाहर भी आप देखे होंगे, इवन रविंद्र सर भी देखे होंगे, आप लोग देखे होंगे कि बाहर में स्पेशलाइज्ड IGRT बन गया। सेम लाइक दैट ISRO, सॉरी, सेम लाइक ISRO क्या करता है, मेंटरशिप करता है। दैट इज अ मेंटरशिप थिंग्स, दैट थिंग वी वांट इन इंडिया, दैट थिंग्स वी वांट। लाइक टेक्नोलॉजीज को आगे बढ़ने के लिए सिर्फ CME काफ़ी नहीं है, वी नीड a classes, we need an examination and then pass. After that, he or she should be a specialized person in each section. IGRT, IMRT, 3D CRT, BMAT, blah blah, lot of things is there. But you are a specialized? No, you are a technologist. Same thing I'm saying. ARB is different.
ये एक छोटा टॉपिक नहीं है, इसको कम से कम 2-3 घंटे चाहिए, और बहुत पेशेंस बताने वाले को भी चाहिए और सुनने वाले को भी चाहिए। देखो साथियों, ARB को हम क्या समझते हैं, ARB इज ए रेगुलेटरी बोर्ड है। ARB कोई गवर्नमेंट ऑफ इंडिया नहीं है कि भाई आपको ये बता रही है और ये काम हो जाएगा। वो बोल देगी, हमारे इंस्टीट्यूट को बोल देगी, उन्हें गाइड कर देगी। ARB रेगुलेटरी बोर्ड है, 1972 में उसका हुआ था, रेगुलेशन पास हुआ था। उसके बाद एक 2015 में हम लोग गए थे मीटिंग के अंदर, उसका रिजल्ट अभी तक भी नहीं आया 2015 के बाद। क्यों? वो अपग्रेड करना चाहते थे। सभी एसोसिएशन और यूनियन से, सभी एसोसिएशनों से, ऑन्कोलॉजी RI से, MP कौन से, ARTT से उन्होंने सजेशन मांगे थे, हमने दे दिए। सिर्फ मात्र एक ही रास्ता है, और वो रास्ता सिर्फ ज़्यादा दूर नहीं। आप निराश मत हो, प्लीज़ आप निराश मत हो। उस पर हम काम कर रहे हैं, हम जाते जाते इस काम को करके जाएंगे, निराश नहीं होना आपको। लेकिन बस मेरा निवेदन सीनियर आदमियों से एक ये है, सीनियर आदमियों से निवेदन है कि वो अपने सेंटर पे डिप्लोमा कोर्स को चालू ना होने दें। अगर उन्हें कोई प्रॉब्लम आती है बताओ, हम करेंगे। जितना मेरा टेक्नोलॉजिस्ट, मेरा रेडियोथेरेपिस्ट अगर वो व्हाट्सएप पे लिखता है, उतना ही वो सजेशन हमें क्यों नहीं लिख के भेजता? और रात को ही वो व्हाट्सएप पे लिखता है, दिन में नहीं लिखता। अच्छा, वो क्या है, सिवाय नहीं टाइम की बात नहीं है,
क्योंकि वो डबल काम करता है प्रधान जी।
हाँ जी, डबल
उसके पास कितना प्रेशर है आप समझिए।
ये समझ रहे हैं सर। लेकिन मेरा एज ए प्रेसिडेंट ये कहना है कि अगर आप ग्रुप पे लिख रहे हो तो आप एसोसिएशन को सजेशन भी भेज सकते हो, एसोसिएशन को सजेशन भी भेज सकते हो। प्लीज़ एसोसिएशन को सजेशन भी करो और पेशेंस रखो। मैं आपको बता रहा हूँ। और यहाँ एक सबसे बड़ी जो प्रॉब्लम है एसोसिएशन के पास है, और जो सर एक मिनट आती है,
सेशन चल रहा है सर।
एसोसिएशन के पास जो एक 3 घंटे में इस पे बता सकता हूँ आपको। एसोसिएशन के पास एक जो सबसे बड़ी प्रॉब्लम है कि एसोसिएशन किसी से रिकग्निशन नहीं है, इसको यानी कि मान्यता किसी से नहीं मिली हुई है। जिससे मान्यता मिलती है संस्थान के अंदर, इसके अंदर मेंबर्स क्या होते हैं? मेंबर्स ही तो ताकत होती है एसोसिएशन की। वो क्या है, 30% मेंबर सरकारी है, 25 से भी ज़्यादा बोल रहा हूँ मैं, 70% प्राइवेट सेक्टर है। अगर एसोसिएशन का, मैं 25 साल से ऑफिसर एसोसिएशन एम्स दिल्ली चला रहे हैं, हमारी कोई बात नहीं मानी जाती, हम तुरंत काम बंद कर देते हैं। क्या मैं अपने प्राइवेट सेंटर से उम्मीद कर सकता हूँ वो 1 घंटे के लिए बंद नहीं कर सकते? कभी नहीं बंद कर सकते। अगर मैं इतने सालों से वहाँ
ठीक है, ओके थैंक यू प्रधान जी, थैंक यू। प्लीज सामने आइए।
बहुत सारी चीजें हैं मेरे पास आपको समझाने के लिए, बोलने के लिए बहुत सारी चीजें हैं।
Now our next question, computer साहब, next question. Yes, professor साहब, can we unlearn some topics or devices which are not used routinely and contributing overall bulky syllabus? क्या ऐसा हम कर सकते हैं?
सर थैंक यू। एक्चुअली हमारा जो सिलेबस है ये धीरे धीरे करके ये बहुत हेवी होते जा रहा है, क्योंकि हमको पुराना चीज़ें छोड़ नहीं रहे और नए नए चीज़ें आते जा रहे हैं। तो हमारा जो कोई भी करिकुलम होगा, चाहे 3 साल का होगा, कुछ भी होगा, तो उसके अंदर एक फिक्स टाइम पीरियड है। तो जैसे कि मोबाइल आया तो कैलेंडर की काम ख़त्म हो गया, रिस्ट ख़त्म हो गया, तो इस तरह से टीवी देखना लोगों ने बंद कर दिया, आज के दिन पे रेडियो सुनना बंद कर दिए, म्यूजिक सुनना बंद कर दिए, सारी चीज़ आपको मोबाइल पे हो रहा है। उसी तरह से हमारा रेडिएशन थेरेपी टेक्नोलॉजी में बहुत बड़ा एक जो हम मानते हैं कि मल्टीलिप कॉलिंग, वो आने के बाद IMRT आए, और IMRT से ये कई सारे चीज़ें, आज के दिन पे आपको OH का जरूरत नहीं है, आज के दिन पे आपको बिल्डिंग का जरूरत नहीं है, आज के दिन पे आपको थेरेपी है, कन्वेंशनल ट्रीटमेंट हमको नहीं लगता है कि बहुत ज़्यादा लोगों ने आज के दिन पे करते हो। और लेकिन इसके लिए फोर्थ फील्ड टेक्निक, पैरेलल ऑफ फोर्थ फील्ड टेक्निक, ये सारी चीज़ आपको ज़बरदस्ती का पड़ती है। मेरा ओपिनियन है कि कुछ चीज़ें हम हल्का कर सकते हैं, एकदम छोड़ना नहीं है, मतलब कुछ चीज़ें मैं कम कर सकता हूँ, मतलब उसका इतना इम्पोर्टेंस आज के दिन पे,
क्योंकि अगर छोड़ेंगे तो फिर एक जो है पूरा पिक्चर क्लियर नहीं होगा ना।
पूरा नहीं छोड़ना है, लेकिन इस तरह से एकदम OH का पूरा सारी चीज़ें अगर आपको पढ़ाया जाएगा, उसका पूरा पढ़ाना है, उसका पूरा पढ़ाना है, तो कोई OH नहीं आपको 1-2 लेक्चर
पीछे से सवाल आ रहा है, पीछे से सवाल आ रहा है। हाँ पीछे
बेसिक
उधर से
बेसिक
सवाल
है,
आया,
लेकिन आप
पीछे वाली
बेसिक जो है उसको अगर आप छोड़ेंगे नहीं तो फिर सारे चीज़ आपका, आप सोचिए अब कल जाकर कुछ नया टेक्नोलॉजी आएगा तो फिर वो कैसे कितना चीज़ आप
न्यू पर्सन प्लीज नया नया आदमी नया कैंडिडेट सवाल करेगा, कोई नया पीछे की सीट से। आपका सहमत है क्या आप सर की बात से? सहमत चुप रहेंगे तो इसका मतलब सहमत है, बिल पास हो जाएगा। हाँ जी अच्छा कोई बात नहीं। वागड़े साहब आपका अच्छा चलिए ठीक है वागड़े साहब कोई बात नहीं, हम नो प्रॉब्लम, आपके सवाल को हम फ्लोर से पूछ लेंगे, फ्लोर से पूछ लेंगे आप। ऑल द बेस्ट। फ्लाइट है इनकी, जा रहे हैं, फ्लाइट का टाइम हो गया। हाँ फेलिसिटेट कर मंडल साहब को, मंडल साहब आ जाओ, तुम भी आ अरे वागड़े साहब कुछ प्रोटॉन के लिए कुछ नई चीज़ नया मॉड्यूल बनाइए, ठीक है, ताकि हम लोग कुछ
Thank you, Raju ji. Thank you, Kamal. Actually, wonderful gathering. And best luck for next time. Maybe again we want to come it.
Okay, next question goes to Dr. Ninda. How does the very tittling and lack of uniform professional identity for radiation therapists across different regions affect academic progression? आपका क्या विचार है?
So definitely लोगों का two aspect to it. One is the titling and second part is uniform professional identity. So the uniform professional identity will only come when the basic requirements and the courses are same. Suppose someone is doing PG diploma, someone is doing ACRTT, someone is doing something else, and ultimately they are entering the field at the same level. One is 3-year course, one is 4-year course. Then there will be a disparity, and people will be exploited based on that. So in due course of time, I think as a community, the radiation therapist, the physicist, and the radiation oncologist, everyone has to make sure that we have got a uniform inclusion criteria. The courses should be uniform. Then the nomenclature can be same, and the qualification can be same. Then everyone will get the same amount of respect. That is what I think. And if in going forward, as has been said, there is some sub-specialization beyond the basic level. So you have got some basic level that everyone has to do. After that, if we want to go to contouring also, if we want to go to some advanced technologies or advanced machineries, then some extra courses beyond that can be like fellowship or something like that, can be introduced. That will give an extra edge and incentive to some of the people who are more talented among the masses to go forward.
That kind of learning, and that can be given. Very good, very nice. Dr. Saab. Yes, so you can bypass this question. Next, please. Next. Yes, Deepak Kumar ji. Do you think that academic growing will take you going beyond with your wisely debate? क्या मतलब हम बहुत ज़्यादा बुद्धिमान हो जाएंगे, साइंटिस्ट बन जाएंगे, क्या मतलब ऐसा क्या तूफान आ जाएगा जब हम इतना पढ़ जाएंगे? तो व्हाट डू यू थिंक? क्या
फ्रैंकली स्पीकिंग, देखिए इस क्वेश्चन का जवाब आई थिंक हाफ पार्ट हैज़ ऑलरेडी बीन गिवन टू द क्राउड, जो अभी हम डिस्कस कर रहे थे। एकेडमिक ग्रोथ जरूरी है सर प्रोफेशनल लाइफ को एक्सेल करने में।
अच्छा, ये मानना चाहिए हमें?
बिल्कुल मानना चाहिए सर, बिना इसके तो हो नहीं सकता कुछ सर। और जो हम जैसे बात कर रहे थे, लाइक अभी भी जो सर शेयर कर रहे थे, वंस यू गेट द नॉमेनक्लेचर डिफाइंड थ्रू अ फिक्स्ड करिकुलम, उसके बाद आप छोटे छोटे कोर्सेज को जैसे इसरो करवाता है या बाकी करवाते हैं, टू गेट यू स्पेशलाइज्ड फॉर स्पेसिफिक मशीन्स और ट्रेनिंग।
मतलब आपका आंसर वहीं आ गया जो अभी डॉक्टर नंदा ने बताया कि छोटे छोटे मॉड्यूल बना लो,
बिल्कुल, और
वो मॉड्यूल को बांट दो और उस पर स्टडी कराओ। और फिर अभी एग्ज़ाम लेने की बात आई थी, ऐसा और कोई ना करे तो एग्ज़ाम ARTTI करा ले और मॉड्यूल करा ले। बिल्कुल बिल्कुल ठीक है।
तो वो चीज़ होना सर ज़रूरी है सर,
बहुत ज़रूरी,
ठीक है। और दूसरी बात सर जो मैं एक और चीज़ करता हूँ कि आपका एक करिकुलम के बाद व्हेन यू हैव द करिकुलम, तो इट्स नॉट ओनली कि BSc MSc रहता है, यू कैन गो टू PhD लेवल। तो वो जब तक हमारा एक सेट स्टैंडर्ड सेट नहीं होगा हम उस पर नहीं जा सकते। एंड द हायर यू गो फॉर एकेडमिक ग्रोथ, प्रोफेशनल लाइफ में आगे बढ़ने के चांसेस भी उतने ही होंगे। इट्स नॉट कि हम अभी सिर्फ चीफ है तो सिर्फ चीफ ही रह जाएंगे। लाइक अदर डिपार्टमेंट्स ऑफ फिजिक्स और रेडिएशन ओंकोलॉजी दे आर गोइंग अप टू द हाईएस्ट पोस्ट। या हम गवर्नमेंट सेक्टर की बात करें वेयर प्रोफेसर होते हैं, डीन होते हैं, तो डेफिनेटली जब तक एकेडमिक ग्रोथ नहीं आएगा वी विल नॉट गो अप टू दैट लेवल।
गुड,
सो दिस इज माय सजेशन।
तो जनरल सेक्रेटरी साहब आ गए आपके, उनसे कहो नोट करें ये बात, यार अपनी एसोसिएशन में कुछ ऐसा शुरू कर दो, क्या प्रॉब्लम है? ये बात डिस्कशन का कुछ तो फ़ायदा उठाए। अच्छा, बट वेयर इज योर सेक्रेटरी? आई क्वेश्चन पीछे से पीछे आगे क्वेश्चन जो
नहीं सर। और दूसरा एक और चीज़ था मेरा अजीत सर का था कि सर आपका गुड स्टैंडिंग सर्टिफिकेट कोई करिकुलम डिफाइन नहीं करता, ठीक है? नहीं वही बोला मैं सर, मैंने उस समय जवाब नहीं दिया था। इट्स ओनली फॉर योर प्रोसेस ऑफ सेइंग कि आपके वर्किंग करियर में आपसे कोई मेजर मिस्टेक नहीं हुआ, ठीक है? इट डज नॉट डिफाइन योर करिकुलम, और करिकुलम जो सर आपका जब तक नहीं होगा आप रजिस्टर नहीं हो पाओगे।
थैंक यू सर। सर एक क्वेश्चन मैं पूछना चाहती हूँ। सर जैसे आपने एकेडमिक ग्रोथ की बात की, हम BSc RT करते हैं, हमें जॉब करने को मिलता है एट लेवल 6। अगर अब मैं गवर्नमेंट सेक्टर की बात करती हूँ, उसके बाद अगर मैं चाहती हूँ कि मैं MSc रेडियोथेरेपी करूँ तो मुझे अपनी लेवल 6 की जॉब को छोड़ना पड़ेगा, क्योंकि MSc रेडियोथेरेपी कोई भी डिस्टेंस से नहीं कर सकता। एंड उसके बाद भी मतलब इंडिया में MSc रेडियोथेरेपी की कोई पोस्ट नहीं निकलती। जैसे रेडियोलॉजी डिपार्टमेंट में MSc करने के बाद लेवल 8 की पोस्ट निकलती है, पर MSc रेडियोथेरेपी करने के बाद भी मुझे लेवल 6 पे ज्वाइन करने को मिलता है। तो MSc रेडियोथेरेपी मुझे क्या फ़ायदा दे रही है?
यस, वेरी वेरी वैलिड क्वेश्चन मैम। अब इसमें एक चीज़ है कि ऐसा नहीं है कि आप MSc करो देन यू कैन ओनली हैव द ऑप्शन ऑफ कमिंग टू द प्राइवेट जॉब। जो आप बोल रहे थे कि लेवल 6 गवर्नमेंट में अगर लेवल 6 की बात कर रहे हैं तो आप टीचिंग इंस्टीट्यूशन में जाओ, विद आपका जहाँ करियर ही स्टार्ट होगा असिस्टेंट प्रोफेसर से। तो यू ऑलवेज हैव द चांस ऑफ ग्रोथ, इट्स नॉट कि नहीं है।
The present curriculum, that is a big mistake done by the association, I'm telling you. Their teaching staff should be radiation oncologist, medical physics, and radiotherapy technologist can teach. Can कब आ जाएगा, it's a question mark. ठीक है, it's a big mistake. It's a business. So whatever this is, so वो है एक है. While is in the radiology, it is not. Radiology में है कि that radiology people they can teach you and they can recruit a radiologist for their subject. While it is reverse here.
टू कॉल सर एक्चुअली, तो हमारे NCHP में जो क्लास है उसको थोड़ा सा हमें मॉडिफाई कराने की बहुत ज़रूरत है, क्योंकि उसमें उन्होंने जो ये रखा है वो दो तो टीच करेंगे ही करेंगे, बट हमें करने के लिए वो बताएंगे हमें करना नहीं करना है। बट अगर हम लोग हायर स्टडीज़ में अगर स्किल्स को और डेवलप करेंगे तो हम लोग लीगली उनके पास जाएंगे, भैया वी हैव पोटेंशियल एंड वी कैन टीच, क्योंकि एक BSc स्टूडेंट नहीं पढ़ा सकता, बट वी हैव टू इम्प्रूव आवर स्किल्स ऑल्सो। उसके लिए हमें वी हैव टू फाइट, देयर इज़ नो ऑप्शन। अग्रीड।
नहीं, there are so many centers. It's a SMS SMS है, MSc रेडियोथेरेपी भी है।
हेलो गुरविंदर सर, वर्धर
standardization of curriculum is going on through NC, AHP. हो जाएगा क्योंकि सारा चीज़ तो लोग कर रहे हैं ना, दूसरा सब ये ऑर्डर निकाल दिया है या हाँ
दिस आई हैव ऑलरेडी आंसर दैट दिस इज़ द वे फॉरवर्ड। अगर ऐसा ही करके हमको स्मॉल मॉड्यूल और जैसे थोड़ा सजेशंस आया कि उसमें भी पहले लास्ट में एक एग्ज़ाम लिया जाए, उसको कुछ एक फेलोशिप जैसा बोला जाए, देन जो उसमें जो पास आउट होगा वो माना जाएगा कि उसका एडिक्वेट ट्रेनिंग हो रखा है और डेफिनेटली वो करियर प्रोग्रेशन के लिए इम्प्रूवमेंट होगा। लेकिन ये चीज़ ये भी है कि गवर्नमेंट को एसोसिएशन की तरफ से कन्विंस करना होगा that should be recognized at some career advancement facility should be there both in government and private तो I don't know whether that will be feasible or not। गवर्नमेंट में आइडियली कुछ उसके बेसिस पे लोगों का करियर प्रोग्रेशन अगर जल्दी होगा देन पीपल विल बी इंटरेस्टेड इन डूइंग दैट।
सत्र 5 का समापन हो रहा है। अब मैं हमारे सम्मानित अध्यक्ष मिस्टर राकेश कौल सर को अनुरोध करता हूं कि वे मंच पे आएँ और मंचासीन सारे पैनलिस्ट का स्वागत करें। मिस्टर मनोज वाकड़े सर। नेक्स्ट मिस्टर दीपक कुमार सर। दीपक कुमार सर। डॉक्टर अभिजीत मंडल सर। डॉक्टर राजीव कुमार सर। डॉक्टर राजीव कुमार सर। डॉक्टर संबित स्वरूप नंदा सर। एंड लास्ट श्री मनोज पिल्लई सर।
So now we are facilitating our best speakers today. So Mr. Fayak Ahmed. Mr. Aishwarya Sonewane. Miss Diksha Bharti. Miss Diksha Bharti. Can anyone take on her name? दीक्षा की जगह कोई और ले सकता है? ठीक है कोई. She is not. है नहीं. So now we have one quiz. So we have only 5 minutes for that. You can scan this QR code and enroll in the quiz. Be hurry, do it fast. $15 क्वेश्चंस हैं, 5 मिनट हैं, जो जितनी जल्दी करेगा. फर्स्ट सेकंड थर्ड प्राइज है क्विज कंपटीशन में. एनीवन कैन पार्टिसिपेट. दीपक सर आप भी. सर हम पैसे दे भी नहीं रहे. हमारे पास देने के लिए पैसे नहीं है. हो गया. जब हम क्विज कर रहे हैं तब तक मैं डॉक्टर राजीव कुमार सिंह को बुलाना चाहूँगा वोट ऑफ थैंक्स के लिए. कर लेंगे.
थैंक यू सो मच. शुरू करने से पहले एक शब्द बोलना चाहता हूँ. संगठन ही असली RTTs है, बिहाइंड द सीन प्रिसीजन, जीरो एरर्स। इसके साथ मैं शुरू करना चाहूँगा। वोट ऑफ थैंक्स। ज़्यादा कुछ बोल नहीं पाऊँगा, लेकिन तब भी मैं बोलना चाहूँगा कि सब CME पहले था, अब इसके बाद कॉन्क्लेव कर दिया गया था। और ये सब चीज़ होने के थ्रू मिस्टर कमल कौशिक एक भाई की तरह, एक साथी की तरह मेरे साथ लगे रहे। 99 नहीं, 100 भी नहीं, 200% मेरे साथ वो थे। और उन्हीं का योगदान की वजह से मैं ये आज कॉन्क्लेव कर पा रहा हूँ। कुछ बोलेंगे? मैं आभार प्रकट करना चाहता हूँ कमल कौशिक को। ये बहुत छोटा शब्द है आभार, लेकिन कमल कौशिक ने मेरी सहायता करते हुए इस कॉन्क्लेव को आज बहुत बड़ा, थैंक यू सो मच बोल रहा हूँ। सिर्फ कहते हैं कि सिर्फ एक इंसान ही काफ़ी नहीं होता है, उसके साथ चलने वाली उसकी औरत भी काम आती है। तो कमल कौशिक की वाइफ त्रिशा जी भी हमारी मदद की। पूरा सेशन स्पीक अप करने के लिए कैसे बोले, और उनके साथ ही हमारा साथ देते आए हैं सुबह से लेकर अब तक के लिए। मैं बोल नहीं पा रहा हूँ वैसे, लेकिन मैं बहुत बड़ा आभारी हूँ और रहूँगा अभी से लेकर पहले तक। और इवन इसके साथ भी मैं अपने पूरे टीम, अरे तुम्हारा नाम ले लेंगे, आइए खड़ा हो जाइए। प्रीति, कंट्रोल योरसेल्फ। तो ये तो बाहर से जो थे साथी हमारे जो साथ देते आए हैं, लेकिन मैं ये चीज़ कॉन्क्लेव जो है पूरा कभी नहीं कर पाता जब तक हमारे साथी जो हमारे संगठन में हैं वो साथ ना दें। तो हमारे पास 16 टेक्नोलॉजिस्ट हैं, शुरू से लेकर अंत तक तो नहीं, लेकिन मैं स्टेप वाइज बताते जाऊंगा। रिसेप्शन में पंकज, फरीदा, सुमंत, रेशमा, इसके हॉल मैनेजमेंट में धर्मेंद्र, प्रवीण, संजीत, आयुष, नीलेश, स्टेज पर नीरज, त्रिशा, प्रीति, मेमेंटोज में सैकत, सेजल, रूबा, फूड में संदीप, राकेश, रमा, प्रदीप, कुलदीप, अभय, विशाल, ट्रैवल में पंकज, गौरव। ये दोनों पंकज और गौरव जो थे वो ट्रैवल में और फूड जो होटल में हो रहा था उस चीज़ के लिए मैं उसका आभार प्रकट कर रहा हूँ। प्रीति का भी मैं आभार प्रकट करना चाहूँगा। प्रीति लास्ट सेशन के शुरू से लेकर पूरा उन्होंने संभाला है, और संभाला ही नहीं है, उस खूबसूरत पंक्तियों के साथ उन्होंने हिंदी शब्द में लाइनें बोल के अपना बहुत अच्छा चीज़ प्रेजेंट किया था। मैं थैंक यू सो मच, and thank you so much all the delegates who came here from all over through धुंध में, fog में, by traveling the train 4 to 5 hours late होते हुए भी यहाँ पे आए हैं, और बनारस के घाटों पे और महादेव के आशीर्वाद से ये कॉन्क्लेव बहुत अच्छी तरह से समापन हुआ है। मैं अपने टीम को और महामना की टीम को, BHO की टीम को मैं आमंत्रित करना चाहूँगा स्टेज पर। ठीक, RTTs फ्रॉम एपेक्स हॉस्पिटल, डॉक्टर अजीत सर, मैं चाहता हूँ कि फेलिसिटेशन आप हमारी टीम को करें। एपेक्स RTTs, एपेक्स RTTs। अब प्रीति सिंह नहीं, मामना की टीम RTTs एंड BHO के।
Now we are closing the quiz. Second. So our first winner of quiz is Anamika. Anamika. अनामिका की जो ईमेल आईडी वो है mini76pandey84854। इन्होंने 15 में से 14 सवाल एकदम सही किए हैं। दो सर प्लीज कम ऑन द डेस्क एंड फैसिलिटेट अवर विनर। वो भी होगा। Once again, Mr. Fayak Ahmed, second winner of a quiz. Sir, just a minute. Third prize also, Mr. Ranjan Kumar. Mr. Ranjan. Third prize, sir. So now lucky draw winners. 505 505 किसी के पास स्क्रैच कोड है? आइए. Ajit sir, please be on the dash to felicitate our winners. $505. जी सर. जी सर. सब एक ही हैं, दे दो. 507. 511. 511. प्लीज़ बी हरी, चाय ठंडी हो रही है बाहर, जितना जल्दी आएंगे उतना जल्दी होगा. 514. 514. 514. 514. 511. 514. 518. 518. 522. 518. 522. 521. 521. Anyone? 521. 513. 513. 53. Only 53. 525. 525. Anyone have 525? 529. 534. 534. 528. 528. 550. 550. 548. 548. 550. 548. 545. 545. 545. 541. 541. 539. 539. क्या सर? नहीं सर. 533. 534. 534. 533. 502. Last 502. 502. 2 है सर. अरे आप ही तो लिखे हो 502. एक रूबा का था, छोड़ दीजिए सर. सो प्लीज आप सब बाहर चलिए, हाई टी लीजिए और फिर घर की तरफ प्रस्थान करिए. फाइव टू फाइव.
हर